first
Hello, mic testing 1 2 3. Hello.
By 7:30 you should sit. After 5 minutes you give a beep. 6 minutes it should be stop abruptly. That is no display. 5 minutes you give a beep. Yeah, please. After 5 minutes you have a 1 minute to present. Okay? All the best. All the best to all. Yeah. Order వేసేసారు కానీ Naveen Kumar and Annapurna, actually they are the chairpersons. They are there, please come join as chairpersons. If they are not there, we won't stop for them. We will start.
So we can start?
Yeah.
Respected dignitaries and delegates, a pleasant good morning to one and all. Myself, Dr. Ashima Chandran, and my topic is the role of placental extract dressing in non-healing trophic ulcers in patients with Hansen's disease. Trophic ulcer is a dreaded recalcitrant disability of the sensory deficient foot and is a major cause for disability. Studies have shown that placental extract has a beneficial role as a topical agent in the management of chronic non-healing wounds. The aims and objectives are to evaluate the efficacy and safety of topical placental extract cream dressing in the healing of trophic ulcers in treated Hansen's disease patients. Materials and methods: sample sizes 10 patients. Patients with trophic ulcers of more than 8 weeks duration in Hansen's disease who had already been released from treatment are included in the study. Patients which age group below 18 years and with a history of bleeding disorders, anemia, uncontrolled diabetes mellitus, malignant ulcers, pregnant and lactating females, patients with non-allergy to placental extract, trophic ulcers due to other disease are excluded. First of all, an informed consent is taken and ruled out active lesions of leprosy by skin and nerve examination, and the ulcer size is measured and the wound area was calculated using the formula for an ellipse, that is length into width into 0.7854. Here, ellipse was used because ulcer size closely resembles an ellipse rather than a rectangle or a circle. Volume was calculated using the same formula into depth, and the healing of ulcer was assessed, area and volume were calculated, and the photographs were taken during each sittings. Surgical debridement of the topical ulcer was done under all aseptic precautions. Placental extract cream is applied between two sterile gauze pieces and is applied over the healthy wound, followed by the application of a secondary non-absorbable dressing to secure the placental extract dressing in place. And the patient is advised to take adequate rest and asked to remove the dressing from the wound bed after 2 days. And the patient should apply the cream every alternate day, that is 1 fingertip unit. And the procedure is repeated and called for weekly sittings. This is a table showing the characteristics of the 10 cases, their age. You can see the age ranged from 48 to 63 and the site of ulcer and the wound duration, which ranged from 8 to 18 weeks. And this is the table showing the area and the volume at the first to the 6 sittings. Volume is centimeter cube and area is centimeter square. Observations and result. The total number of patients were 10. Among them 7 were males and 3 were females. The mean age was 56. The duration of the ulcers ranged from 8 to 18. Mean sittings required was 4. Mean percentage improvement in the area was 90.6 and that of volume was 96.8. Maximum number of sittings required was 6. There were no adjuvant therapy and no adverse events. These are the pictures showing the first, second and third sitting. You can see even at the third sitting, there is near complete closure of the trophic ulcer. First, third and fifth sitting, you can appreciate the complete closure of the wound by the fifth sitting. These are before and after treatment of 3 cases. You can see near complete closure. Discussion. Plantar ulceration is one of the most common disability occurring in 10% of the leprosy patient. These are difficult to manage because of its chronicity and non-healing nature, which thus cause significant negative physical, economic and social effect on the patients. Various treatment modalities for trophic ulcers are available, which include moist wound dressings, vacuum-assisted closure and topical application of growth factor, etc. Human placental extract constitute of polydeoxyribonucleotide, fibronectin type 3 like peptide and various antioxidants. It has got an anti-inflammatory action. It promotes epidermal keratinocyte proliferation, increases the collagen synthesis and improves the tensile strength of the healing tissue, increases the DNA, total protein and hydroxyproline contents. It has got immunotrophic action. It accelerates fibrinogenesis, angiogenesis and epithelialization. Water solubility of the placental extract makes it 50 times more potent than the epidermal growth factor. It supports ossification and it is free from side effects. S.K. Tiwari et al. From Varanasi in their study comparing the placental extract cream and gel formulation in the treatment of chronic non-healing wounds found that there is less pain and discomfort during dressing change compared to gel formulation. That's why we used cream formulation in our study. We couldn't come across other studies using the placental cream extract dressings in the treatment of trophic ulcers in Hansen's disease patient in the published literature to compare our results. Near complete closure of all ulcers were achieved in a maximum of 6 weeks of 6 sittings. No adverse events were noted in our study. It is non-invasive compared to PR, platelet-rich plasma or platelet-rich fibrin matrix therapy for which the blood has to be taken. It is inexpensive compared to other topical epidermal growth factor preparations available in the market. It is simple, less time consuming and safe procedure. To conclude, placental extract cream dressing for the treatment of trophic ulcers is a novel, cost-effective, feasible, safe, simple, easy to perform procedure with good cure rate. These are my references. And there are no conflict of interest and no sponsorship for the study. Thank you one and all for your patient listening.
Thank you for a nice presentation. Now the second presenter is Dr. Sheikh Naushin. Comparative study between 30%. and 50% in the treatment of seborrheic keratosis. Yeah, the speaker, you come here. Dr. Ashima, you come here. Nera sir, come.
You can use the side buttons. Any side.
Good morning, respected sirs, ma'am, and my dear colleagues. This is Dr. Sheikh Naushi. My topic of presentation is comparative study between 30% hydrogen peroxide and 50% trichloroacetic acid in the treatment of seborrheic keratosis. Seborrheic keratosis are benign epidermal tumors composed of keratinocytes. They are frequently found in the middle-aged and elderly with equal sex prevalence. Common sites are head and neck, head and trunk can occur anywhere. Treatment modalities are topical 5-fluorouracil, electrocautery, cryotherapy, electrodesiccation, curettage, laser ablation, but they all have the risk of scarring. Simple, economical, non-invasive treatment for SKs is an unmet need. 40% hydrogen peroxide in various studies showed promising results. A lower concentration of 30% hydrogen peroxide is being studied here due to its wide availability in India compared to 40% hydrogen peroxide. Another promising treatment is 50% trichloroacetic acid. A comparative study was done between 30% H2O2 and 50% TCA to determine their effectiveness. Aims and objectives: to study and compare the effectiveness of 30% H2O2 and 50% TCA in treatment of seborrheic keratosis. Effectiveness can be defined as ability of an intervention to have a desired effect on patients in normal clinical conditions. Materials and methods. This study was done in DVL OPD from Jan to June 2021 for a period of 6 months. It is a prospective open label study comprising of 40 patients with SKs. Physician's lesion assessment scale was used for the evaluation of effectiveness of both treatments. A PLS score was used, which is physician's lesion assessment scale, which in that 0 means clear, 1 is near clear, 2 is thin SK and 3 is thick SK. Inclusion criteria: all patients with SKs having typical clinical appearance. Exclusion criteria: patients with SKs in intertriginous folds on eyelids covered with hair or within 5 mm of orbital rim of pedunculated. Patients like pregnant and lactating women were excluded. Patients with multiple eruptive SKs, which indicates sign of lesser trillet, are also excluded. Procedure: 30% H2O2. First, SKs were cleaned initially with spirit. Then H2O2 was applied sequentially to the lesions for 30 seconds per SK at each pass. Total of 4 passes, each at 1 minute apart. A maximum of 2 sessions was given and evaluated at the end of 6 weeks. In 50% TCA group, initially Vaseline jelly was applied around the lesion. 50% TCA will be applied till frosting was seen. Maximum 2 sessions are given and evaluated at the end of 6 weeks. Results: age and sex distribution. 40 patients have completed this study, among which 23 were females and 17 were males. Most of them belong to 60 to 80 years of age group. Among 40 laborers constituted a major proportion of the population. Skin type of patients: 28 were of skin type 4 and 12 were of skin type 5. This is the comparative table. We can see PLS score of 0 was achieved in 11 patients in 30% H2AT group and in 6 patients in 50% TCA group. PLS score at the time of assessment: 20 patients, 2 groups were divided, 20 patients each, and 8 and 9 patients had PLS score of 2 in 30% H2O2 and 50% TCA group respectively. 12 and 11 patients had PLS score of 3 in both groups respectively, and this is the graphical representation. Local skin reactions observed in H2O2 group were edema in 90% of patients, erythema in 60%, scaling and hypopigmentation. 50% TCA group showed burning pain sensation in 100% of patients, followed by erythema, edema and hyperpigmentation. PLS score at 6 weeks after 2 sessions. PLS score of 0 at the end of 6 weeks was regarded as successful treatment. A PLS score of 0 was achieved in 11 cases in 30% H2O2 and 6 cases in 50% TCA group. Discussion: most of the patients in this study were elderly with female predominance. This is similar to Yetman et al. Gill et al. Studies. Most of the patients in this study were laborers. This finding can be attributed to the prolonged sun exposure in the both occupations. More lesions were seen in the exposed sites than in non-exposed areas. Lesions from non-exposed sites resolved earlier than lesions from exposed sites. Faster healing was seen in lesions from head and neck compared to legs. This finding can be attributed to high vascularity of head and neck region compared to legs. In 30% H2O2 group at first session, that is at 2 weeks, PLA0 was achieved in 25% of patients, whereas in 50% TCA group it was in 15% of patients. At 6 weeks, PLA score 0 was achieved in 55% and 30% in H2O2 and TCA groups respectively. These results were statistically significant at p-value less than 0.05 using Spearman's rank correlation test. The findings in the study were comparable to Du Bois et al. With 30% H2O2 and Leslie Bowman et al. Done with 40% H2O2. Local skin reactions were edema in 30% H2O group at 90%, burning sensation were observed in 50% TCA group at 100%, hypopigmentation was seen in 5 cases in H2O2 group, hypopigmentation was seen in 6 cases in TCA group. No treatment emergent adverse events were seen in the both groups in this study. No recurrences were seen in either of the groups up to 3 months of follow-up. These are the pictures showing the results of 50% TCA group as well as H2O2. Conclusion, slight female predominance was seen in this study. Most of the patients were laborers and farmers with history of chronic sun exposure. Optimum response was seen in both groups. Statistically significant response was seen in H2O2 group compared to TCA group. Better response at PLA score 0 was achieved in H2O2 group with 11 patients at 6 weeks. 50% TCA showed a response of 6 patients at 6 weeks. Faster resolution in lesions on non-exposed sites was observed. Faster healing in lesions on head and neck was observed compared to legs. Local skin reactions were more in 50% TCA group compared to 30% H2O2 group. No recurrences and no treatment emergent adverse events were seen during 3 months of follow-up. Thus, 30% H2O2, which is easily available in India, may prove to be a potential novel, cost-effective, non-invasive treatment for SKs when compared to 50% TCA. No conflicts of interest, no sponsorship. These are my references. Thank you.
Yeah, thank you, Dr. Sheikh Naushin. Come to the photo booth. Now, they move on to the third presenter, Dr. Shushmita. Isomorphic response triggered by inflammatory dermatophytosis in acral vitiligo. Please go ahead.
Side buttons.
Good morning, respected dignitaries and delegates. This is Dr. Shushmita. My topic for paper presentation is the case report of isomorphic response triggered by inflammatory dermatophytosis in acral vitiligo. 31-year-old male patient presented to our OPD with the complaints of itchy, scaly, red raised lesions with coexisting white patches in the center of the lesions over the abdomen, groins, thighs, forearms, arms since 2 months. Patient was apparently asymptomatic 2 months back when he developed complaints of itchy, scaly, red raised skin lesions over the groins first, which later became extensive, spreading to trunk, thighs, arms and forearms. On continuous scratching, these lesions started developing light colored lesions in the center of the original lesions. There was no history of burning sensation, pain and discharge from these lesions. There are no similar complaints of red colored scaly lesions in the past. Patient was a known case of acral vitiligo for which he received unknown systemic Ayurvedic treatment. There is no history of any other underlying systemic illnesses. Patient is manual laborer by occupation whose personal history is pretty normal and there are no habits of smoking and alcohol consumption. There is no significant family history. Coming to the general physical examination, patient was conscious, coherent, well oriented to time, place and person. He was moderately built and nourished, whose vitals are febrile. Heart rate is 82 beats per minute, blood pressure is 120 by 70 mmHg, respiratory rate is 18 cycles per minute, and there are no signs of pallor-icterus, sinuses, clubbing, lymphadenopathy and edema. CVS S1 S2 heard, no murmurs, respiratory system bilateral air entry is present, normal vesicular breath sounds are heard and no adventitious sounds are heard. Per abdomen soft non-tender, no organomegaly or free fluid and CNS no abnormality detected. Coming to the cutaneous examination, diffuse depigmented patches confined to both palms and dorsal aspects of both feet with few hyperpigmented scaly discrete macules with central clearing are present. Depigmented patches with irregular borders are seen in the center of the lesions, largest measuring 10 centimeters to 12 centimeters distributed over anterior aspect of trunk, arms, forearms and over the thighs. Depigmented macular patches are present overall over the genital and oral areas also. These are the clinical photographs of the patient. Coming to the investigations, CBP, blood sugars, RFTs and LFTs are within normal limits and negative for the viral markers. CU is completely normal. Coming to the histopathological examination, histology section showed mild psoriasiform epidermal hyperplasia and compact hyperkeratosis and perivascular predominantly lymphoid infiltrate on HNE staining, and on special staining, GMS staining, fungal hyphae were shown which is positive for Gomori methamphetamine silver stain. On histology section of the depigmented patch showed no pigment deposition in the basal layer and there was complete loss of melanocytes. Coming to the diagnosis, based on the clinico-histopathological findings, the diagnosis of cobnarization of vitiligo patches in extensive dermatophytosis was made, whose differential diagnoses are erythema annulare centrifugum, granuloma annulare, discoid eczema, erythema multiforme, pityriasis rosea, and post-inflammatory hypopigmentation for the depigmented patches. Patient was started on oral antifungals and topical antifungals and counseled for fungal treatment primarily, followed by the vitiligo treatment. Discussion. Vitiligo is an acquired, often progressive disorder of depigmentation clinically manifested by circumscribed achromic macules. Dermatophytosis is a superficial fungal infection of keratinized tissue commonly designated as tinea. It usually presents with itching and scaly plaques. Cobness phenomenon is commonly observed in vitiligo vulgaris, wherein minor trauma on clinically unaffected skin results in the development of depigmented macules. The skin injury inducing it may be physical, mechanical, chemical, thermal, allergic or irritant reactions, chronic pressure, inflammatory dermatosis or therapeutic modalities. This is a case of vitiligo developing cobnarization and dissemination following scratching due to dermatophytosis. Physical trauma to the skin may lead to the increased oxidative stress, which including accumulation of hydrogen peroxide. In response to prolonged hydrogen peroxide exposure, many proteins are affected, including stress proteins such as heat shock protein 70, which prevents premature degradation of cellular proteins. Initially protective for the cell, once released into the extracellular environment, these stress proteins are very immunogenic, eliciting immune response. Coming to the conclusion, histopathological examination and immunohistochemistry may help to confirm the diagnosis of both dermatophytosis and vitiligo, whereas histopathology remains the gold standard for the diagnostic test. This case is being reported for the isomorphic response by the inflammatory dermatophytosis in the patient of acral vitiligo. Thank you. Thank you for the patient listening.
Thank you, Dr. Sushmita. Please come on to the photo booth. Now the fourth presenter is Dr. Sachi Gupta, the dual positive CD4, CD8 mycosis fungitis presenting with pityriasis lichenitis and hypopigmented patches. Please go ahead.
A very good morning to one and all. The topic, the case report is dual positive CD4 CD8 mycosis fungoides presenting with pityriasis lichenitis and hypopigmented patches. So a 31-year-old male who is clerk by profession presented with multiple asymptomatic hypopigmented macules and patches over the trunk and the upper limbs of 1 year duration. Initially started as scaly erythematous papules which are developing over the trunk.
You go and sit.
Trunk and
I
the
invite
proximal
the chairperson.
extremities,
Please go ahead.
which gradually evolved to form hypopigmented macules. And these papules were associated with mild occasional pruritus. No pain, burning sensation was noted. The patient was treated with various topical antifungals and steroid creams in the various dermatological clinics for a period of 1 year. And the patient responded partially, while new papules continued to develop in crops and hypopigmented macules and patches were seen to become more prominent, especially over the tongue. The patient denied any systemic symptoms including fever, chills, nausea, vomiting, weight loss, night sweat, recent travel or any abdominal pain. There was no seasonal variation, no significant medical or surgical intervention, no history of any drug intake prior to onset of lesions and no significant family history. On examination, journal examination, patient was moderately built and well nourished, no evidence of pallor, icterus, clubbing and colonychia. Lymph nodes were clinically not palpable and vitals were within the normal limits. Systemic examination was unremarkable. On cutaneous examination, we can see there are multiple ill-defined hypopigmented macules which are seen over the neck, trunk, upper limbs, and there was no scarring on the hypopigmented patches. And there are small erythematous scaly papules are present which are approximately 2 to 3 mm in size, are present over the lower back and the right forearm and right shoulder and extensor aspect of the right forearm, which was associated with the mild adherent scaling. There was the sensations over the patches were normal, and also there is no nerve thickening present, and journal mucosa, that is the oral mucosa and genital mucosa, was normal. Based on these findings, a differential diagnosis of pityriasis lichenoides chronica, pityriasis versicolor, gutted psoriasis, mycosis fungoides and Hansen's disease was made. And the patient was investigated on these grounds, that is Woods lamp examination of the hypopigmented patches did not show any fluorescence, QH mount was negative, slit skin smear was negative for lepra bacilli, hematological and biochemical investigations were within the normal limits, and peripheral blood smear was normal, ultrasonography of the abdomen was normal, chest X-ray was normal, VDRL and HIV serology were non-reactive. On histopathology, the epidermis shows basket weave and lamellar orthokeratosis with focal parakeratosis and almost regular acanthosis, and mild spongiosis was noted. There is moderate lymphocytic exocytosis. In the dermis, superficial dermis shows a moderate perivascular and interstitial infiltrate of lymphocytes, some of which show mild nuclear hyperchromasia and irregularity. Based on these atypical lymphoid cells, immunohistochemistry was advised, which showed it was positive for CD4, CD8 and CD3 cells in the epidermal lymphocytes as well as the perivascular lymphocytic infiltration, and it was negative for CD30, CD20 and CD7. Based on these findings, a final diagnosis of dual positive CD4, CD8 mycosis fungoides presenting with pityriasis lichenoides and hypopigmented patches, and it was staged according to the TNM staging as T2NO-MO, that is stage 1B, where T2 stands for generalized patch and plaque covering more than 10% of the body surface area. So mycosis fungoides is the most common primary cutaneous lymphoma, presenting with approximately 50% of all cutaneous T-cell lymphomas. Due to the non-specific clinical features, it is not easy to confirm in the early stages, resulting in improper medical treatment. The atypical lymphocytes in mycosis fungoides classically exhibit a CD3 positive, CD4 positive and CD8 negative. Although rare presentations of CD4 negative and CD8 have been reported, a case of CD4 positive and CD8 positive dual positive mycosis fungoides hypopigmented patch is a rare variant with a very few cases reported in the literature. This hypopigmented mycosis fungoides presents peculiar characteristics that differentiates from classical and conventional. That is, it is having a high prevalence in the young and black patients, it is having a chronic indolent clinical course and having a better prognosis, and histologically there is a marked epidermotropism of CD8 positive cells in contrast to the subtle clinical features which are seen in the hypopigmented variant. The significance of CD8 cells that have an important role in the pathogenesis, that is, it causes a melanocyte destruction due to the direct cytotoxic effects of the CD8 positive tumor cells. A study by Furan et al. Which was conducted on 18 patients with the hypopigmented mycosis fungoides, it showed that the CD8 cells were much more than the CD4 cells. It shows that in the index case also there are greater number of CD8 lymphocytes which may be responsible for the hypopigmentation in our case. A study by D. Markey et al. Where it was studied to study the expression of CD4 and CD8 cells having an impact on prognosis, which was done on 10 patients and for a time period of 42 months. They observed that the co-expression of CD4 and CD8 was associated with a slightly low rate of progressive disease as compared with the conventional phenotype. So in the end, I can conclude that dual positive CD4, CD8 mycosis fungoides are very rare with a very few reports in the literature. The neoplastic CD8 positive cells lead to the hypopigmentation. These patients show a slightly lower rate of progressive disease as compared with the conventional phenotype, and the co-expression of CD4 and CD8 is associated with the better prognosis in mycosis fungoides. Thank you, and these are my references.
Thank you, Dr. Sanjay Gupta. And I apologize for my late Dr. Bhumesh sir, and thanks for giving me the opportunity for chairing this award paper session. The next paper is Pattipati Vengamamba Ravali, and the topic is safety and efficacy of intralesional measles, mumps, rubella vaccine in Verruca vulgaris, a case series.
You will have to use the sides, any side.
Good morning, one and all. Today I am going to present safety and efficacy of intralesional measles, mumps, rubella vaccine in Verruca vulgaris, a case series. Common warts, also called as Verruca vulgaris, is a viral infection caused by human papilloma virus. HPV is a double-stranded DNA non-enveloped virus that belongs to Papoviridae family and papilloma virus genus. They are benign epidermal proliferations of skin and mucosa. They can occur at any age and spread by direct or indirect contact. The impairment of the epithelial barrier function by trauma or maceration predisposes to the inoculation of the virus. Commonly available treatment modalities for warts are salicylic acid, podophyllatoxin, 5-fluorouracil, electrocoagulation, cryotherapy, surgical excision, and CO2 laser. All these methods of treatments can be painful and may be associated with frequent recurrence. Hence, to overcome these limitations, immunotherapy has been tried with various vaccines and antigens over the past few years. The present study was undertaken to explore the effect of MMR vaccine for the treatment of common warts. Aim and objective is to know the efficacy and safety of intralesional MMR vaccine for the treatment of Verruca vulgaris. We included 15 patients with common warts attending to the OPD of the DVL department. Inclusion criteria, we included all clinically diagnosed common warts patients aged between 5 to 16 years, both males and females, and patients who are willing to participate in the study after taking informed consent. We excluded females who were pregnant and lactating and immunocompromised patients and hypersensitivity to MMR vaccine. Method of collection of data, and a written informed consent was taken, a detailed history was taken, and clinical examination was done, and diagnosis of Verruca vulgaris was made by 2 observers. Routine baseline investigations were done on the first visit. Distal photographs were taken for all the patients at the time of presentation and after each visit. The reconstituted MMR vaccine of about 0.5 ml was injected into the base of the larger warts with the insulin syringe at 3-week interval until complete clearance or for a maximum of 3 injections. The clinical response was documented by recording the decrease in the number and size of warts at each visit, that is at 3-week interval for 3 sessions and 3 months after the last injection. Adverse effects were minor with no life-threatening complications. Pain during injection was observed in 90% of the patient and swelling was seen in 34% cases. The observation and results are calculated based on different parameters. The most common age group affected is 20 to 40 years, constituting 53.3%, and males are most commonly affecting, constituting 66.6%. The most common sites involved are fingers, dorsum of hands, palms, followed by forearms and feet. Complete clearance was observed in 10% of the patient with 66.6%, and there is no much improvement in 20% of the patients, and 13.3% cases were lost to follow-up. Maximum response is seen in 40% of the patients within 9 weeks and 26.6% within 6 weeks. Here are the photographs showing the patients. The above images shows the patients presented to the OPD, and then the first image shows the clearance of the ward after 2 sessions of MMR vaccine, and the second one after 3 sessions of the vaccine. Despite the availability of the multiple therapeutic options for the treatment of warts, recurrence and resistance to is still commonly seen. Immunotherapy is the best available treatment in treating multiple warts, as it boosts the immune system against HPV virus, leading to clearance of both treated and untreated warts. Intralesional MMR immunotherapy employs the ability of the immune system to recognize viral antigens but induces the delayed type hypersensitivity reaction not only to the antigen but also against the HPV. Thus, increases the ability of the immune system to recognize and clear HPV. Consequently, the stimulated immune response clears all lesions on other body sites along with locally treated lesions. From the present study, we conclude that immunotherapy with intralesional MMR vaccine is safe and effective modality of treatment of common warts with minimal side effects. Our study mainly enhances the advantages of widespread and sustained effects of MMR vaccine against warts at distinct sites. The limitation in our study, since it is a small case series and with less number of patients, there is no long-term follow-up available for the patients. There is no conflict of interest, and these are my references. Thank you.
Thank you, doctor. The next paper is on ecthyma gangrenosum like atypical presentation of bullous pemphigoid in a patient with neurological disorder by Umal Khair, Dr. Umal Khair.
Use the side button.
Good morning, one and all. I am here to present my case, ecthyma gangrenosum like atypical presentation of bullous pemphigoid in a patient with neurological disorder. Bullous pemphigoid is an autoimmune subepidermal blistering disease with autoantibodies against BPAG 230 and 180 of basement membrane zone, characterized by tense bullae over edematous urticarial or over apparently normal skin, often with marked pruritus, generally affecting elderly population. Several atypical presentations of bullous pemphigoid have been described, such as prurigo nodularis-like, erythema multiforme-like, vegetating, vesicular, localized, ecthyma gangrenosum-like, and etc. Associations include neurological diseases like Parkinson's disease, stroke, epilepsy, and multiple sclerosis. Here we report a rare case of ecthyma gangrenosum like atypical presentation of bullous pemphigoid in a patient with neurological disorder with a probable drug association. Case report, a 34-year-old male patient resident of Raichur, farmer by occupation, presented with painful crusted erosions over both feet and legs since 15 days. Patient initially developed mildly pruritic, reddish, solid, elevated, flat lesions over bilateral feet, which progressed to involve bilateral legs and upper limbs not confined to trauma-prone areas. Subsequently, there were development of few itchy blisters within the lesions with resultant painful erosions with adherent crust. There were no intact bullae at the time of presentation, but photographs taken by the patient before presenting to us shows bullous lesions over feet. There was no history of involvement of face, scalp, mucous membranes, palms and soles, no history of fever, photosensitivity, joint pains or weight loss, no history of topical application of any irritants. Patient is a known case of epilepsy, non-hypertensive, non-diabetic. He was on anti-epileptics, phenytoin, phenobarbital, and carbamazepine since 8 years. He developed multiple pruritic tense fluid-filled blisters over trunk and extremities 3 months back, sparing face, scalp, and mucous membranes, for which he visited tertiary care hospital in Raichur. A provisional diagnosis of bullous pemphigoid was made there, and he was treated with systemic antibiotics and steroids. Subsequent to blistering episode, previous anti-epileptics were stopped and levetiracetam was started at that hospital. 2 weeks after starting levetiracetam, patient developed present episode of erosive plaques and few bullous lesions. Family history was insignificant. Personal history, patient was non-smoker with no addictions. General examination, patient was moderately built, conscious, coherent, cooperative, well-oriented in time, place and person. No pallor, icterus, cyanosis, clubbing or lymphadenopathy was seen. Vitals were stable. Cutaneous examination showed multiple well-defined circular polycystic erosive plaques symmetrically distributed over dorsum of bilateral feet and distal part of legs predominantly. The erosions were covered with thick adherent necrotic crust with eschar at the center and oozing and pus discharge at the periphery, which you can see in the images below. Few similar lesions, erosions with thick crust on bilateral upper extremities were noted. Scalp, face, neck, trunk, palms and soles were sprayed. Post-inflammatory pigmentation and old heel scars were seen over the trunk, which you can see in the image on the right side. Oral cavity and genitalia were not involved. Nail abuse lines and distal onycholysis of both hand and feet nails were seen. Nikolsky sign was negative. Bulla's Spitz sign could not be performed as there were no intact bullae at the time of presentation. Systemic examination was unremarkable. Differential diagnosis considered were bullous pemphigoid, epidermolysis bullosa acquisita, linear IgA disease, vasculitis and ecthyma gangrenosum. Laboratory investigation, total WBC counts were raised with neutrophilia 86%, C-reactive protein was raised 24 mg per liter. Liver and renal function tests were within normal limits. Complete urine examination, blood sugar levels and serum electrolytes were normal. Pulse culture sensitivity showed growth of Staph aureus initially, which was treated with IV mirovenom. Later, when repeated after 10 days, showed Klebsiella species, which was treated with oral linezolid with good response. Histopathology and DIF showed epidermis mild orthokeratosis and mild spongiosis. Dermis showed moderately dense infiltrate of lymphocytes, plasma cells, neutrophils and few eosinophils. DIF showed C3C deposits at basement membrane. Histopathology done at the first episode in the month of May showed subepidermal cleft. Management, the patient was started on systemic corticosteroids, systemic and topical antibiotics without significant improvement even after 2 weeks. Subsequently, he was treated with injection rituximab 500 mg per 50 ml, 2 doses, 2 weeks apart. Lesion subsided fully in 1 month. These are the images after the treatment. Discussion. Bullous pemphigoid is the most important autoimmune subepidermal blistering disease affecting elderly over 60 years of age. In the younger age group, the reported incidence rates is usually less than 0.5 cases per million population. It is often idiopathic, but genetic susceptibility and environmental factors like drugs can contribute to triggering BP. Several atypical presentations of bullous pemphigoid have been described, such as prurigo nodularis like erythrodermic, erythema multiforme like vegetating, lichenoid, vesicular, ecthyma gangrenosum like etc., which may be seen in up to 20% of patients. DIF shows immunoglobulins, IgG in 70 to 90% patients and complements in 90 to 100% patients in a linear pattern and dermoepidermal junction. The overall course of the disease, starting with bullous lesions and then developing ecthyma-like lesions, with DIF showing changes of bullous pemphigoid, helped us to diagnose this case as ecthyma gangrenosum like bullous pemphigoid, which responded well to rituximab. The episodes may have been triggered in our patient by anti-epileptics. The prevalence of neurological comorbidities among patients with bullous pemphigoid, as seen in our patient, ranges between 28 and 56%. It is believed that an insult to CNS may trigger exposure of neuronal BP180 antigen followed by synthesis of anti-BP180 antibodies. These may cross-react with cutaneous BP180 antigen. Only one case series of 3 elderly females with ecthyma gangrenosum like bullous pemphigoid by Jana et al. From Switzerland has been reported till today. There are no reports of this presentation from India till today. I would like to conclude, this case is being reported for its rare ecthyma gangrenosum like atypical presentation of bullous pemphigoid in a young epileptic male managed with rituximab with marked improvement. Atypical presentation of bullous pemphigoid poses a diagnostic challenge, thus it requires high clinical suspicion for diagnosing bullous pemphigoid presenting with varied morphology. These are my references. Thank you.
A small
Thank you,
announcement,
doctor.
AP10BG 8430I10. So the lights are on, so the vehicles, please go and switch off your lights. Otherwise the battery will be down. Yeah, go ahead, ma'am.
Thank you, doctor. The other paper is on varied manifestations of secondary syphilis in HIV, a case series by Dr. Samiha Hamza Chenganaseri. Dr. Samiha.
Yes, ma'am. A very good morning to one and all. My name is Samiha Chenganaseri and my topic is varied manifestations of syphilis in HIV, a case series. Syphilis is a sexually transmitted disease caused by spirochete treponema pallidum. The HIV pandemic has led to a resurgence of syphilis after a long period of declining incidence. Several conditions including HIV co-infection may cause atypical clinical aspects. The clinical manifestations of syphilis can be variable with typical and atypical patterns. Case 1 is a 60-year-old male. He was diagnosed to be HIV positive. He presented with a tender ulcer of size 1:1 centimeter with overlying crust over his scrotum since 2 months, and he had multiple papules and plaques with lamellar crusting and erythematous halo over his abdomen, trunk and extremities. He had history of recurrent episodes of fever with myalgia and reported having multiple male sexual partners. Louis maligna, Kaposi sarcoma and bacillary angiomatosis were the differentials we considered for this case. He had reactive TPHA VDRL with titers of 1:64, a CD4 count of 313 cells, and in histopathology we could see obliteration of the vascular lumina with plasma cells. A final diagnosis of Louis maligna was made in this case. Case 2 was a 24-year-old male. He presented with scaly plaques over bilateral palms and concentric succinate plaques over his left sole since 1 month. He admitted having unprotected sexual intercourse with multiple male partners, and he had his bilateral inguinal lymph nodes were enlarged. We could also see multiple ill-defined hypopigmented patches over his scrotum, as you can see in this image. Secondary syphilis, tinea infection and palmoplantar psoriasis were what we suspected. He was reactive for HIV-1 and VDRL with titers of 1:128. His CD4 count was 126 cells. And in biopsy, we could see dense collection of lymphoplasmacytic cells in the dermis. A final diagnosis of succinate secondary syphilis was made. Case 3 was a 30-year-old female, known case of HIV. She came with multiple hyperpigmented papules, plaques and macules all over her body since 4 months, had history of photosensitivity and recurrent episodes of fever with joint pain. She had positive Bushka-Lindorff sign and positive Hartoghi sign. SCLE and secondary syphilis were the differential diagnosis we considered. She had reactive TPHA and VDRL with very high titers of 1:2048 and a CD4 count of 212 cells. A final diagnosis of secondary syphilis was made and patient was adequately treated. Case 4 was a 26-year-old male. He presented with asymptomatic red color lesions all over his body since 15 days. He had history of sexual intercourse with his wife 20 days back, penovaginal type and unprotected sex. His bilateral inguinal lymph nodes were enlarged, and on cutaneous examination we could see multiple discrete non-tender erythematous papillonodular lesions over his trunk and multiple erythematous nodules coalescing to form plaques over his nose extending to involve his bilateral cheeks. We could also see multiple scaly erythematous papules over his frontal hairline and a single split papule over his right oral commissure. And in genitalia we could see multiple non-tender crusted erythematous nodules and papules over the penis and scrotum. Secondary syphilis, hystoid leprosy, sarcoidosis and Mycobacterium avium complex infections were what we suspected. He tested reactive for HIV, HCV, TPHA and VDRL with titers of 1:256. And in biopsy we could see a thinned out epidermis and dermis showed chronic inflammatory infiltrate. A final diagnosis of papillonodular secondary syphilis was made. Case 5 was a 40-year-old female. She presented with multiple tender erythematous to hyperpigmented annular plaques with crusting and multiple erythematous nodules over the face since 1 week. She had history of fever and we could also see crusted papules over her genitalia. Subacute cutaneous lupus erythematosus, secondary syphilis and guttate psoriasis were the differentials we kept. And she tested reactive for VDRL with titers of 1:64, reactive for HIV-1 with CD4 count of 180 cells. A final diagnosis of Lewis maligna was made. These are the before and after pictures of all cases taken on follow-up. As you can see, the crusted ulcer have almost completely healed and so has a papillonodular lesions over the penis. And the scaly plaques over his hands and annular plaques over the trunks have also showed healing. So syphilis can be broadly divided into the infectious and the non-infectious states. It's a disease of considerable public health importance because of its adverse pregnancy outcomes and facilitation of HIV transmission. It can commonly present as macular, papillar, papillosquamous and rarely as nodular, pustular and circinate form. When it occurs in an HIV infected individual, the clinical course, laboratory diagnosis and response to treatment may be altered. So the rarer clinical variants of secondary syphilis is more frequently seen in HIV seropositive individuals as seen in all of our discussed cases. All cases were diagnosed as syphilis based on clinical suspicions and they were confirmed with serology. All patients were treated with injection benzathine penicillin and followed up with serologic and clinical improvement. Therefore, secondary syphilis should always be considered in the differential diagnosis of inflammatory cutaneous disorders in HIV positive individuals. Syphilis can simulate many diseases and physicians should be well aware of these. This is my reference and thank you so much for your time.
Thank you, Doctor. The next paper is Autologous Plasma Biofiller, a novel cost-effective alternative to expensive dermal fillers. Dr. Battula Amulya.
You can use the side button.
A very good morning to respected chairpersons and everyone present here. My topic is autologous plasma biofiller, a novel cost-effective alternative to expensive dermal fillers. Scarring is a common complication of acne vulgaris that may even occur in the setting of appropriate medical therapy. Acne scarring results in an undesirable cosmetic appearance, potential impairment of mental health, social functioning and overall well-being. Treatment modalities for acne scarring include dermabrasion, laser resurfacing, radiofrequency, subcision, microneedling, punch techniques, chemical peeling and soft tissue augmentation. Popular dermal fillers include formulations such as hyaluronic acid-based fillers, polylactic acid gels and calcium hydroxylapatite. PRP has obtained worldwide attention in acne scar treatment. Plasma gel is one such PRP formulation with desirable biological and medical properties and highly suitable for use as a filling agent as it is soft, naturally injected into the dermis and subcutaneous fat layer. It is an autologous material obtained from the patient's own blood and hence any risk of immunogenic reactions or disease transmission are eliminated. Our aim is to study the efficacy of autologous plasma biofiller as a dermal filler in treating atrophic facial acne scars and facial rejuvenation. A total of 10 patients with atrophic acne scars of rolling and box scar type were included in the study, while excluding patients who are unwilling for the procedure, subjects with active acne lesions, immunosuppression, bleeding or coagulation disorders, active infection at the site of injection, chronic disease and known keloidal tendency, subjects with unrealistic expectations, pregnancy and lactation. Coming to the preparation of the biofiller, 10 ml of patient's venous blood was drawn and mixed with 1 ml of anticoagulant. It is centrifuged at 3200 rpm for 8 minutes. And then the plasma is withdrawn and centrifuged again at 1000 rpm for 5 minutes. The upper part, that is a platelet poor plasma, is aspirated gently, and calcium gluconate, which acts as an activator, is added in a proportion of 0.01 ml per 1 ml of platelet poor plasma and drawn into insulin syringes. These syringes are put into a hot water bath at 70 to 100 degrees of centigrade for 5 to 7 minutes, and then until the contents turn cloudy yellow, indicating gel formation. They are again put in a cold water bath at 8 degrees centigrade for 3 minutes. Here the image 5 shows the consistency of the plasma gel that is ready to be injected. After application of a topical anesthetic cream for 45 to 60 minutes, under strict aseptic conditions, plasma gel was injected intradermally or subdermally below each acne scar using insulin syringe or 24 to 28 gauge needle. Patients are advised to avoid massaged or extended pressure within the treated area for a week. Clinical assessment of the patients is done by photographs taken at baseline immediately post-procedure and at each follow-up monthly up to 3 months. Severity of the acne scar pre and post-treatment was assessed using Goodman and Barron qualitative grading system. Clinical efficacy was assessed from poor to excellent depending on the percentage of improvement. Improvement in skin texture was assessed from grade 1 to 5, 1 being much worse and 5 being greatly improved. Adverse effects during and after the procedure were noted, and overall patient satisfaction on a scale of 1 to 10 was recorded at the end of 3 months. Coming to the results, this is a graph showing the clinical efficacy of the treatment. 6 patients showed excellent improvement, 3 patients showed very good improvement, and only 1 patient showed poor improvement. Degree of improvement in the skin texture was greatly improved in 30%, improved in 60%, and it was same as before in 10%, and none of the patients have showed any worsening in the skin texture. Distribution of adverse effects. Pain at the injection site was seen in almost all the patients. Erythema was seen in 90%, tenderness was seen in 70%, and edema in 60%. And none of the patients have showed any features of infection or post-inflammatory hyperpigmentation. The overall patient satisfaction was excellent in 60%, good in 30%, and poor in only 10%. These are the clinical images showing before and after 8 weeks post-treatment from grade 4 to grade 2. Another case showing excellent improvement from grade 4 to grade 2 at 12 weeks of post-treatment. This is another case showing very good improvement from grade 3 to grade 2 at 8 weeks post-treatment. Coming to the discussion part, fibrinogen concentration in platelet poor plasma is much higher compared to the PRP, and the fibrin fibers tend to be formed in bundles. This fibrous network provides a scaffold for the platelets for the sustained release of growth factors. Platelets work through the degranulation of its alpha granules, which contain pre-synthesized potent growth factors like platelet-derived growth factors, vascular endothelial growth factors, among others. Moreover, the gel formula serves to localize these platelets and growth factors in the treated area, which interact with the dermal fibroblasts, promoting neovascularization, neocollagenesis, and resulting in soft tissue augmentation. In our study, 90% of the study subjects reported dramatical clinical improvement at 1 week post-treatment, and the results persisted up to 12 weeks post-procedure. Single session was effective in majority of the patients, and 3 patients were treated with a second session after a 2-week interval. The overall patient satisfaction on a scale of 1 to 10 was more than 7 in 60% of the patients. Similarly, in a study by Nashwa et al., they noted a remarkable improvement in acne scars in most patients after 1 session, and observed the combination of plasma gel with derma roller potentiated its effect. Other studies by Noha et al. And Godfrey et al. Observed immediate significant improvement of fine line amelioration, wrinkle reduction, and sagging improvement that maintained till the end of 3-month follow-up period. Finally, I'd like to conclude by saying that autologous plasma gel is a safe, very cost-effective, well-tolerated, and a minimally invasive technique with minimal downtime for the treatment of soft atrophic acne scars and facial rejuvenation. Soft tissue augmentation by plasma gel not only has a volume effect with an immediate improvement in contour, but also induce collagen remodeling by the activation of growth factors. These are my references. Thank you very much.
Thank you, Doctor. The next paper is Cutaneous mucormycosis in COVID-19, a case series, Dr. Mandava Snehasri.
Good morning, everyone. Today I am going to present a paper on cutaneous mucormycosis in COVID-19. Mucormycosis is an angioinvasive disease caused by saprophytic fungi of the order Mucorales. They predominantly infect immunocompromised hosts. Cutaneous mucormycosis is classified as primary, which is due to direct inoculation, and secondary, which occurs due to dissemination from other locations. It is further subcategorized into localized, deep, and disseminated. Most affected areas are the arms and legs, and others include scalp, face, and thorax. Histopathology characteristically shows angioinvasion, thrombosis, and tissue necrosis. Case 1. A 33-year-old male presented with pain, redness, and swelling over the left leg since 10 days. Initially small in size, and later he developed blackish discoloration over the lesion. He had past history of COVID-19 1 month back, no history of trauma or known comorbidities. On examination, a single well-defined black eschar with irregular borders surrounding erythema and induration measuring 5 × 5 cm was present over posterior aspect of left leg. Routine investigations were performed. KOH mount revealed broad acceptate hyphae wide-angle branching. On culture, white fluffy cotton colonies on seborrheic dextrazaga suggestive of mucor. Lactophenol cotton blue showed broad acceptate hyphae with sporangiospores. Histopathology, scanner view 10x showed epidermis showed ulceration, dermis bland infection like necrosis, fibrin thrombi and angioinvasion, broad acceptate right angle branching and ribble-like hyphae in the dermis. A diagnosis of primary cutaneous mucormycosis was made. Patient was started on injection amphotericin B. Extensive debridement with regular aseptic dressings were carried out. Tablet posaconazole at the time of discharge and followed up at regular intervals. So these are the lesions at the time of presentation. After 1 month and after 3 months, we can see the healing. Case 2. A 56-year-old male presented with pain and extensive ulceration over right flank and left thigh of 2 weeks duration. Patient was COVID-19 positive 2 months back, no history of trauma, and he was de novo type 2 diabetes mellitus with no other comorbidities. On examination, 2 well-defined ulcers with irregular borders, sloping margins, exposing underlying muscles, with overlying necrotic slough was present, measuring 10 × 10 cm over the left thigh. Routine investigations were done. KOH mount revealed broad acceptate hyphae, and on culture we could see salt and pepper fluffy colonies suggestive of Rhizopus species. LPCP mount revealed rhizoids, acceptate hyphae, sporangiospores bearing sporangia. Histopathology, epidermis revealed ulceration, dermis dense infiltrate was seen around blood vessels, and deep dermis and subcutaneous on 40x we could see broad acceptate wide angle branching hyphae along with fat necrosis. A diagnosis of primary cutaneous mucormycosis was made. Patient was started on injection amphotericin B, surgical debridement and regular papaya dressings were done for a period of 2 months. And later a split thickness skin grafting was performed and followed up. So on day 20 and after 1 month and after 2 months and after split skin grafting. Case 3, a 55-year-old male presented with swelling of left half of face, partial loss of vision and painful black colored lesion over the lip since 20 days. Patient was COVID-19 positive 1.5 months back. There was no history of trauma or other comorbidities. On examination, a well-defined hemorrhagic crusting measuring 2 × 1 cm were present over both upper lips and lower lips, erosions over hard palate, diffuse swelling and induration of left half of face, along with conjunctival chemosis and proptosis of left eye. MRI brain was suggestive of pachymeningeal enhancement, subacute infarct in left perirolandic region and bilateral orbital cellulitis. KOH mount revealed broad acceptate hyphae. Culture showed salt and pepper cotton fluffy growth and SD seborrheic dextrazaga suggestive of Rhizopus species. LPCB mount also showed rhizoids, sporangiospores. Histopathology showed fibrofatty tissue with focal areas of necrosis and scattered broad irregular acceptate fungal hyphae. On pass we could make out the magenta color of the fungal hyphae. A diagnosis of secondary cutaneous mucormycosis was made. Patient was started on injection amphotericin B and followed up. Lesions over the lip healed with post-inflammatory hypopigmentation. So initial presentation, ulcerations over the hard palate and after 2 months. A 20-year-old male presented with painful elevated dark color lesion over the forehead since 10 days. He was COVID-19 positive with a CT severity index of 7 out of 25. Known case of acute promyelocytic leukemia. On examination, we could single black colored eschar with well-defined borders with a central crateriform depression over forehead. Routine investigations revealed pancytopenia. Impression smears and scrapings 10% KOH revealed broad acceptate hyphae. Biopsy could not be performed and patient died the following day. In our observation, all were male patients. The time interval between COVID-19 recovery and initial presentation of mucormycosis was around 2 weeks. 3 of them had past history of COVID-19 and 1 patient had COVID-19 at the time of diagnosis. 3 of them presented with primary cutaneous and 1 patient presented with secondary cutaneous secondary to rhino-orbital cerebral. 2 patients presented with ulceration, 1 up to the level of fascia and other involving the entire depth of muscle. To conclude, mucormycosis has been linked to COVID-19 infections caused by the Delta variant which has spread rapidly. The prevalence of mucormycosis in India is 70 times the global prevalence and the cutaneous mucormycosis accounts for 15 to 20% of all cases. Following sharp rise in these cases during second wave of COVID-19, it was declared an epidemic. The rampant increase in these cases could be due to COVID per se, underlying immunosuppression, inadvertent use of systemic steroids or oxygen masks. Risk factors include uncontrolled diabetes mellitus, ketoacidosis, hematological malignancies, transplantation. Modani et al. Stated that mucosal erosions due to aggressive use of steam inhalation, high flow oxygen, ordinary tap water in ventilators promote fungus colonization. Cutaneous mucormycosis have been reported that in around 50% of the patients they were immunocompetent. The disease progresses rapidly and causes high mortality and morbidity. It is important to recognize this infection at an early stage to potentially reduce tissue necrosis and severe complication. The second wave encompassed clinicians from every specialty in the fight against this deadly condition, and it's an alarming highlight of the second wave, which caused considerable panic. These are my references. Thank you.
Thank you, Doctor. And the last paper today's morning session is Outbreak of Pediatric Dermatitis in Residential Hostels, a Prospective Clinical Study. Dr. Pradeep.
Good morning, respected chairperson, professors and friends. Today my topic is Outbreak of Pediatric Dermatitis in Residential Hostels, a Prospective Clinical Study. Pediatric dermatitis is an acute irritant dermatitis resulting from contact with pedrin, a hemolymph released when pediatric beetles are crushed against the skin. Irritants generate various responses on the skin such as stinging, burning and tightness to erythema, urticarial reactions, frank eczema or chemical burns. The synonyms include dermatitis linearis, row-weighted dermatitis, staphylinda dermatitis, whiplash dermatitis, and vacancy disease. Pediatritis, an active predator of number of crop damaging insects, prefers wet irrigated farmland and soil. The distribution is worldwide, but is mostly reported from hot tropical climate areas. Outbreaks of pediatric dermatitis from various regions of India are reported particularly during the rainy months. Aims and objectives: to analyze the epidemiological and clinical findings of pediatric dermatitis and factors associated with it. Materials and methods: a total of 211 patients with pediatric dermatitis attending DVLOP tertiary care center over a period of 3 years were included in the study. After clinical examination, patient details were collected using standard pro forma, which included age, sex, residential address, initial symptoms, site of lesion and type of lesion. Cutaneous examination was focused on the morphology of the skin lesions, pattern, number, site and the extent of involvement. A total of 211 pediatric dermatitis cases were studied, in which 126 are females and 85 are males, which includes 76 cases of pediatric dermatitis from residential hostels within 2 consecutive months of November and December 2019. The age range was around 10 to 55 years. Most of the patients presented within 48 to 72 hours of the onset of the lesion. The main duration of symptoms was 4 days. The common complaints were burning sensation and itching. In our study, the face is the most common site involved, followed by neck, then forearms, then trunk, then periorbital areas, and followed by lower extremities. Among the symptoms, burning sensation was seen in around 57%, itchiness was seen in 27%, pain was seen in 9%. Among signs, diffuse erythema and discommission was seen in 42%, erythematous streaky lines were seen in 40%, pustules were seen in 12%, and kissing lesion, which is a characteristic of pediatric dermatitis, was seen in 2.7%. In this picture, we can see an atypical variant of pediatric dermatitis showing diffuse erythema, discommission, and scaling over the face. In the first picture, we can see multiple ill-defined crusted erosions and pH seen over the left side of the face and neck. In the second picture, we can see 3 linear erythematous crusted erosions seen over the left side of the face, which is called dermatitis linearis, which is the most common presentation. The healing time was around 1 to 2 weeks for most of the patients, and 17 patients took more than 2 weeks to heal. Post-inflammatory hyperpigmentation was seen in 44 patients after healing, but none of them showed scarring. There was no significant difference in clinical features or therapeutic outcome of the patient on the basis of gender. Study constraints in our study include lack of species identification of the beetle, and we didn't do any HPE examination of the lesion. Discussion: the most important Indian species of Pediatrus are Pediatrus fusipus, Pediatrus irritans, Pediatrus sabacus and Pediatrus himalaycus. They are small, elongated, 5 to 10 mm long with dark orange bodies, with their head, tips of the abdomen and front wing colored black. The pediatric manufacture is limited to adult female beetles. Excessive vegetation and the tropical climate favors the breeding of the insects. Use of fluorescent and incandescent lights attack attracts the insect that inevitably results in infection to the people nearby such environment. In our study, major clustering of cases has been reported in the months of September to December. Seasonal variation is attributed to breeding pattern of the beetles and rainfall. Paddy or sugarcane fields were noticed close to the residences of the affected patients. In histopathological examination, in early lesion, we can see neutrophilic spongiosis, reticular necrosis of the epidermis. Later biopsy shows irregular acanthosis, pallor of superficial keratinocytes, overlying parakeratosis, and suprabasal acantholysis. In our study, exposed body parts were the most affected sites, involving mainly the face, extremities, and neck, which correlates with the study done by Gyanaraj et al. In 2007 from South India. Periocular lesions frequently occur secondary to transfer of peyroton by the fingers from elsewhere on the skin or direct contact with the periorbital skin. Presentation of unilateral periorbital dermatitis with or without character conjunctivitis known as Nairobi eyes can occur. The morphological patterns include dermatitis linearis, which is the most common presentation, which presents as erythematous streaky lines. Localized pustular dermatitis, which presents as grouped pustules in the area of contact. Kissing lesion is a characteristic of peyrotis dermatitis, occurs due to contact of adjacent areas of skin, often occurs in flexures. Extensive skin involvement may lead to systemic symptoms such as fever and vomiting. Genital lesions occur due to passive transfer of toxin to the genitalia. Atypical variants, which is seen in most of the cases in our study, shows diffuse desquamation and erythema. Atypical variant of dermatitis was seen in many patients in the form of diffuse erythema and desquamation, which is seen. In this picture, we can say diffuse desquamation scaling seen over the face and neck. The atypical variant is due to different exposure to different species of peyrotis, recurrent contact, existence of underlying disorders like atopic dermatitis, and use of heavily infested water source. Conclusion: peyrotis dermatitis has increased in recent years due to increased use of fluorescent lamps and deforestation. Clinical education regarding the prevalence of presentation of common and atypical variant of peyrotis dermatitis will pave way to prevent misdiagnosis. Basic tactics such as avoiding crushing of the beetles on the skin, avoiding manipulation of primary lesions, and use of insect repellents can be advised. In suspected contact with a beetle, the area should be washed with soap and water thoroughly. These are my references. Thank you.
So nice presentation by all the postgraduates. Now we'll move on to the another important session on the day 2. So that is a genital dermatosis. For this, I invite the chairpersons, Dr. M. Jayant. He needs no introduction. He is well known to everybody. Very close to heart of all the IADVL. Sir, please come on to the dais and occupy the chair. And Dr. V.R.C. Reddy. So another famous dermatologist is just retired from ESA hospital. So, sir, please come on to the dais and occupy the chairs. So the stage is yours for 1 hour. Over to chairperson.
Yeah, the first name is one. One second.
Hello. Yeah. Good morning, ladies and gentlemen. On this Boxing Day, very nice to see all of you in the early morning. It's my pleasant duty to be the chairperson. Me and Dr. Ramchandra Reddy, on both of them, we thank the organizers for this wonderful opportunity. So now, every phase in our life is bound to teach us something valuable, but it depends on us whether we analyze the lessons or just turn the pages. Okay, now I call upon the genital dermatosis topic and then call upon the speakers. We'll begin with non-venereal genital dermatosis by Dr. A. Venkatrakrishna. Dr. Venkatrakrishna, can you please come and deliver?
Good morning, respected chairperson and dear delegates. So today I am going to talk on non-venereal genital dermatosis. So variety of skin lesions can occur on genitalia, male genitalia, female genitalia, and few are sexually transmitted infections and majority are non-venereal origin. So non-venereal diseases are cause of concern to patients, often a diagnostic dilemma to the treating physician, and there is a lot of stigma and apprehensions among the physicians and patients. Wrongly labeling a patient as a case of venereal disease can have great psychosocial implications in addition to wrong treatment. It is necessary to have detailed knowledge and broader view while approaching genital lesions, as it can be a non-venereal disease. The most common non-venereal diseases are vitiligo, peripenal papules in males, fixed aggressions in both, scabies, superficial fungal infections, scrotal dermatitis, lichen planus, candidiasis, others, along with irritant contact dermatitis, LSC, LSA. So classification of non-venereal dermatosis are normal or physiological variants, most common, non-sexually transmitted infections, dermatological disorders affecting genitalia, lesions due to trauma and artifacts, precancerous benign tumors, precancerous tumors, and malignant neoplasms, and other special peculiar to the genitalia non-venereal disorders. So coming to normal physiological variants are benign acquired lesions, pigmentary variation in both sexes, skin tags, peripenal papules in males, sebaceous prominence, nevi, prominent veins, other common congenital anomalies. Coming to peripenal papules, this is a very common condition in male. Usually it causes venerophobia, multiple skin colored smooth 1 to 3 mm papules around the corona sulcus. So it causes venerophobia, except nothing significance, but only reassurance is required. For days past, nothing but ectopic sebaceous glands present on subprepital area of penis and vulva. Multiple tiny yellowish papules it presents, but it doesn't cause any disease, or it's only symptomatic treatment not required, reassurance is required. So non-retractable foreskin is it's normal at birth. Spontaneous retractability begins at 2 years of age, majority by 10 years, almost 95% by 16 to 17 years. So there is no need to go for circumcision, wait and watch approach is needed. So angiokeratoma of Portis is multiple blue to purple brown papules on scrotum, common site, shaft of the penis, rarely glands and vulva. So it causes bleeding intermittently on trauma. So developmental anomalies involving the genitalia and male genitalia, hypospadiasis, epispadiasis, and ambiguous genitalia, urethral atresia, nevus are common. You have to remember this. Non-sexually transmitted infections common are staphylococcus, streptococcal, and tuberculosis, and parasitic infestations, and defungal infections, other mycobacterial infections. This is Staphylococcus caldescens syndrome involving genitalia, and streptococcal periannular dermatitis, intense erythema, exudate is common in children. Pediculosis pubis. Scabies are classically papules, nodules, and scrotum and penile shaft characteristic feature of scabies. Foreigners gangrene is a special condition, emergency condition to recognize and diagnose and refer to surgeon immediately. So herpes zoster can occur on genitalia, and fungal infections can occur on shaft of the penis. Insect bite reactions can occur. Candidiasis can cause balanopositis in male and vulvovaginitis in female. So males, small papules, papulopustules, breaks, live behind superficial erythematous erosions. It's a classical presentation of balanopositis. Radial furrows or longitudinal fissures under surface of refuse is characteristic feature of chronic balanopositis, and chronic infection leads to phimosis. And other dermatological disorders that occur on genitalia are any condition, all dermatitis can occur on genitalia, along with special conditions and lichen planus, psoriasis, and drug eruptions, angioedema. All these conditions can occur on genitalia, female, male genitalia. So it's case of lichen planus, first one, annular lichen planus, it's a vitiligo, can occur on genitalia, vulva or penis. Psoriasis and fixed drug reaction, common drug reactions are present as a fixed drug reaction. So lichen sclerosus atropicans or BXY in female. So first it starts as the erythema, and later on it becomes porcelain white macules, papules, sclerotic plaques and atrophic plaques, and causing narrowing of intratus and phimosis in males. So classical presentation of porcelain white appearance of atrophic plaques on lichen sclerosus atropicans, and phimosis penis, BXO. So succinate balanitis of Rayta's disease, Bayes disease, multiple of the ulcers, and lentigens can present on penis of the ulcers, and granuloma annular also present as annular lesions. Lesions, coming to lesions due to trauma, lesions due to trauma artifacts are many. Sometimes we confuse with STA, penile hematoma, and non-mineral sclerosing implangitis, strangulation of penis, and dermatitis artifacta, self-mutilation, child abuse. Child abuse, these are the conditions can mimic child abuse like fissuring, nappy rash, eczema, purpura, and scrotal dermatitis. Now coming to benign tumors of genitalia, there are male and female both are same except a few conditions, peripenile papules and scrotal calcinosis in males, and Bartholin duct tumors, vulval ileomyomas, and syringomas, Fox-Fodder disease in female. Balanitis, so hyperkeratotic, thick scaly plaques, sometimes ulceration, fissuring on glands. So histopathology only mild or epidermal dysplasia seen. Erythroplasia of Curie. Erythroplasia Curie, Bowen's disease, Bowenite papulosis, represent penile intraepithelial neoplasia, analogous to vulvar, cervical, anal intraepithelial neoplasias. So it is associated with HPV 16, 18. Clinically, it presents as well-defined erythematous velvety plaque on the penis, glans, profuse, prepetal skin. Biopsy shows ATP of keratinocytes throughout the thickened epidermis. Differential diagnosis are psoriasis, lichen sclerosis, Jones balanitis. Bovenod papillus presents as multiple papules, brown colored erythematous, 2 to 10 mm. At close differential diagnosis, condylomata acuminata. Extramammary Paget disease, itchy, moist red, oozy plaques in the anogenital area. Common site is vulva. So primary, secondary. Primary is direct skin condition. Secondary associated with the underlying carcinomas. Buschke-Levinson tumor. It's a hyperkeratotic varicose large plaque. It spreads locally, but histologically it's a benign condition. Squamous cell carcinoma, it's the most common neoplasm of genital tract in both men and women. So cauliflower appearance of ulcers, plaques, nodules. So non-venereal lesions peculiar to genitalia. So peyronie's disease, phenylfibromatosis, causes painful erection with a varying degree of dorsal and lateral bending of penis on erection. Plasma cell balanitis or Jones balanitis, it causes circumscribed persistent plaque with shiny smooth surface on glans penis and spares the keratinized penile shaft and profuse. It occurs only on glans. So here is everybody knows it, phimosis and paraphimosis. So myelopathitis already covered. The causes may be traumatic, irritant, allergic, infective, and other causes of balanitis. Scrotal calcinosis, it's solitary, multiple odd papules, nodules present on scrotum. Close differential diagnosis, multiple epidermal cyst of scrotum. So conclusion, all lesions of genitalia are not manifestation of STDs. Non-venereal genital dermatitis are common, especially in men, are usually noticed after sexual intercourse, leading to diagnostic dilemma. They also have a significant impact on the quality of life of the individual. Therefore, comprehensive understanding of various presentation, their causes, and appropriate diagnosis and management options are essential. Thank you all.
Thank you, Dr. Venkatrakrishna, for your exhaustive talk.
Yeah,
Thank you
Dr.
so much.
Anantala, Dr. Anantala, please be there. Please be seated. Dr. Anantala, please. You be there as a panelist. No, you sit there, please.
Yeah, train your mind to see the good in everything. Positivity is a choice. The happiness of your life depends on the quality of your thoughts. Okay, now I invite Dr. Mohanlal, the next speaker, who is going to speak about venereal genital dermatosis. Dr. Mohanlal.
Good morning all. First of all, I acknowledge our HOD Dr. Rajeev Singh sir, our Professor Dr. Padmaja madam, and our registrar Dr. Indira madam for taking up this wonderful topic, giving us this topic. Thank you, sir. So today my topic is venereal genital dermatosis. Venkatrakrishna sir has covered non-venereal genital dermatosis. Venereal genital dermatosis are those sexually transmitted diseases which manifest in the form of genital lesions. These diseases are common in high-risk population like sex workers, truck drivers, drug abusers, transgenders, homosexuals, men having men sex with men, and not only these high risk people, high risk group people, high risk behavior people also will have STDs commonly. These are broadly classified as ulcerative lesions, non-ulcerative lesions, and discharges, discharge from urethral discharge, vaginal discharge, and sometimes rectal discharge also. Syphilis. In olden days it was on rampant, and then cases came down, but nowadays we are seeing again increase in the number of syphilis cases. So it is caused by Treponema pallidum. The incubation period is 9 to 90 days. Primary lesion is dull red macule. It is of 0.5 to 1.5 centimeter diameter. It ulcerates in a week. Typically, it is called a typical chancre is the primary lesion is called a chancre. The typical chancre is single round, slightly elongated ulcer, 1 to 2 centimeters in diameter. It is non-tender, regular edges, indurated margin and base, clear floor with granulation tissue without exudate. We usually diagnose by isolation demonstration of the spirochete in from the floor through dark ground microscope and serological test. In serological test there are screening test and confirmatory specific test. Treatment is by benzathine penicillin. Then comes chancroid. It is caused by Haemophilus ducreyi. Incubation period is 3 to 7 days. The ulcer is erythematous papule, appears at the site of entry of the organism, which turns into pustule, undergoes central necrosis, and forms a characteristic small necrotic tender bleeding non-indurated ulcer with ragged or undermined edges. Various clinical variants of chancroid are there. They are dwarf, giant, follicular, phagedenic, serpiginous, and pseudogranuloma. The regional lymph nodes become tender, inflamed. Lymphadenopathy occurs in 30 to 60% of people only. The bubo softens, undergoes separation to form unilocular fluctuant swelling, which may rupture spontaneously, resulting in ulceration. Microscopy of smear reveals presence of typical streptobacilli. Oh, sorry. Yeah. Lying in clusters, either inside of leukocytes or outside in chains, paralleling the shreds of mucus with the appearance of school of fish or railroad track. Treatment is with single dose of azithromycin 1 gram orally, ceftriaxone 250 milligrams intramuscularly, ciprofloxacin 500 milligrams orally twice a day for 3 days, or erythromycin 500 milligrams orally thrice a day for 7 days. Lymphogranuloma venereum. Sexually transmitted chlamydial disease that primarily involves in lymphatics. It is caused by Chlamydia trachomatis. Biovars are L1, L2 and L3. Clinical features grouped conventionally into different stages comprise of a primary stage, secondary stage, that is inguinal syndrome, and tertiary stage, that is genito-anorectal syndrome. The primary lesion may be an asymptomatic transient papule, pustule, it is herpetiform ulcer or nodular ulceration. Primary lesions occurs usually over coronal sulcus, followed by frenulum, prepuce, penile shaft, urethra, glans penis, and scrotum in men, and on posterior vaginal wall, foresheet, posterior lip of the cervix, or the vulva in women. See, perianal ulcer of lymphogranuloma venereum. This is the classical picture of saxophone penis. Secondary stage is proctitis, bubo formation, inguinal multilocular abscess, groove sign of Greenwald. Tertiary stage is genito-anorectal syndrome. Diagnosis: positive serology, isolation of the organism from infected tissue. Treatment is with doxycycline 100 mg twice daily for 3 weeks or erythromycin 500 mg orally QID for 3 weeks. Granuloma inguinal, otherwise called donovanosis. Causative organism is gram-negative bacillus. Incubation period is 3 days to 3 months. First sign of infection: form papule or subcutaneous nodule that later ulcerates. 4 types of donovanosis are described: ulcerogranulomatous, hypertrophic or verrucous type, necrotic, and sclerotic. Lesions of donovanosis. Ulcer of donovanosis is painless, beefy red, and bleeds on touch. Direct microscopy of tissue smear in the mainstay. Method of diagnosis: histopathology, culture, and PCR are other diagnostic modalities. Azithromycin is the drug of choice. The course of azithromycin is 500 mg daily for 1 week or 1 gram weekly for 4 to 6 weeks. WHO recommends 1 gram followed by 500 mg daily. These are the lesions. Herpes genitalis. Herpes simplex virus is the most common cause of infection related to genital ulceration worldwide. Pain, dysuria, urethral or vaginal discharge, genital and sacral paresthesia, and tender inguinal lymphadenopathy are the prominent local symptoms. Lesions appear 3 to 14 days after the exposure. Initial lesions are small, grouped, painful vesicles or pustules on an erythematous base, which break and form ulcers in 2 to 4 days. Initial lesions may involve as extensive area, and individual lesions may coalesce to form large ulcers. Here the floor we can see the coalescence. Tender inguinal lymphadenopathy appears during the 2nd or 3rd week and may persist despite lesions healing. Involved in inguinal and femoral lymph nodes are tender to palpation, firm and non-fluctuate. Diagnosis: we diagnose clinically usually, but the lab tests are Jank smear, viral culture, serology and PCR test. Treatment usually we give aceclor, treat with aceclor, but many other drugs are there nowadays. So for primary lesion we treat for 1 week, and for recurrent episodes we treat for 5 days only. Molluscum contagiosum, benign papillary disease of skin, often sexually transmitted. Molluscum contagiosum virus of Pox viridae family is the cause. Transmission is primarily by skin to skin contact by both sexual and non-sexual routes. Incubation period of molluscum contagiosum is 2 to 3 months. Clinical features are benign as papule which grow over several weeks to a diameter of 1 to 3 millimeters. The flesh colored papules are smooth, firm and dome shaped with characteristic central umbilication. These are the pictures of molluscum contagiosum in a HIV positive patient. Pediculosis pubis caused by crab loose, transmitted by close physical contact, infects the hair of the pubic and perianal areas. Appears as 1 to 2 millimeter tan colored attachments on the hair shaft, mostly in young adults, transmitted usually by sexual contact. Eggs are laid in groups of 20 to 30 and are glued to the hair of the host. Itching in the pubic region is the predominant symptom. It is diagnosed by demonstrating the loss or knit. These are the genital scabies pictures. Bacterial vaginosis. The most common vaginal infection in women of reproductive age characterized by replacement of normal lactobacillus with an overgrowth of anaerobic bacteria associated with a rise in pH above 4.5. Typical symptoms of bacterial vaginosis are an unpleasant fishy smell and with thin discharge. Occasionally, women develop soreness of the vulva from maceration due to continual wetness. On examination, the discharge is described as milky, homogeneous, low in viscosity, white or greyish, and free of grossly visible crumbs of epithelial cells that are seen in normal vaginal secretion. Treatment is with metronidazole 500 mg twice daily for 7 days or metronidazole 2 grams orally single dose. But nowadays NACO is supplying kit form for all many of the sexually transmitted diseases. So it is a syndromic approach where we cannot miss STDs at the primary level also. So and there and where you can be like it can be treated with mixed STDs also, we can treat with the kits and you can stop it's a STD spread of the STDs in the society with the syndromic treatment. Trichomoniasis, sexually transmitted protozoan parasite that invades genital epithelia and may cause trichomoniasis in women and urethritis in men. Prevalence in women is 4 to 5 times more than in men. Trichomonas vaginalis infection in men is known to be an important cause of urethritis, prostatitis, potentially male factor infertility. Symptoms appear within 7 to 10 days of the exposure. Symptoms in men include discharge, dysuria, pruritus, increased urinary frequency, prostatitis, and rare complications like urethral strictures or epididymitis. In women, vaginal discharge, itchy, musty odor, dysuria, pelvic pain, irregular bleeding, and pain or bleeding on coitus. Clinical signs of infection in women include punctuate bleeding of the cervix, referred to as strawberry cervix. Diagnosis is by direct microscopy and culture. Treatment is with metronidazole 2 grams orally in a single dose. Anogenital warts.
Mohanlal, time is up.
So, okay, sir. Thank you. So, these are the other genital, venereal genital dermatosis, anogenital warts. This is, see, these are the pictures. Perianal warts in a homosexual man, penile warts. These are the statistics from Usmania Medical College we collected. Vaginal discharge, genital ulcers. Thank you.
Yeah. Thank you, Dr. Mohanlal, for your exhaustive talk. Thank you so much. You can occupy the chair, I think, for the panel. If you have choices, choose the best. If you have no choice, do your best. Okay, now I have the pleasant opportunity to invite Dr. Rajiv Singh, who is the moderator. We will have a panel discussion on management challenges of genital dermatosis. Over to Dr. Rajiv Singh, please.
Thank you, respected chairpersons. Dr. Jain sir, who is quite senior. Dr. Jain sir is so good that he wanted to donate all the journals that he had to Usmania Medical College. So thank you very much, sir. That is the greatest any HOD wants from the people around. I thank Dr. Ramchandra Reddy sir, who is a chairperson here. He was so good that he was basically the person who taught me dermatology way back in 95, 96 and 97. Thank you very much, sir. Though we were students of venereology at Usmania Medical College, but we had so much of passion to learn dermatology that we used to go to Sanat Nagar ESI hospital where sir was placed. Myself and Dr. Satyanarayana Reddy sir, my colleague, in PG days we used to go to Dr. Ramchandra Reddy sir and learn dermatology. He is so good that when I used to say, sir, we have seen this case yesterday, he used to ask us to take out rooks and again read again and again and again. So the significance of reading for a dermatologist persists till he dies. That's what he taught me. Thank you, Ramchandra Reddy sir. I am Dr. Rajiv Singh, HOD, DVL Department, Usmania Medical College. I have very good faculty with me, all well versed, well knowledgeable at Usmania Medical College. Dr. Venkatrishna sir, who is one of the panelists here. Venkatrishna sir is a very senior professor of dermatology, very knowledgeable person, very shrewd at picking up points and telling the PGs to pick up what is important. So, Dr. Venkatrishna sir. Dr. Mohanlal, my colleague, Associate Professor. Mohanlal, I request you to kindly occupy your chair. He is an Associate Professor of DVL Usmania Medical College. Dr. Shahana, my colleague, since I worked as Associate Professor in Gandhi Medical College. Dr. Shahana may kindly occupy her respective chair. Dr. S.B. Kavita, my colleague at Gandhi, since I also worked in Gandhi. Dr. Kavita, an Assistant Professor of Department of DVL, keen learning STDs and genital dermatosis, very happy to learn genital dermatosis more and more rather. Sangeet Kumar, this boy from Warangal, a very good student, brilliant, upcoming, definitely very good, but I am sure his passion for genital dermatosis and his fear to diagnose lesions of genital dermatosis. Yeah. There we have an extraordinary panelist in the group, very gentle chairpersons and myself the moderator. Basically genital dermatosis was picked up at the inception of CUTICON. I respected our beloved president Dr. D.V.N. Murthy sir he said, Rajiv, you have picked up a reasonable topic which needs to be emphasized. And he straight away allotted maybe 1 hour for us. Thank you, DBN Murthy sir, for having allotted us an adequate time. The first case, please. The first case, anybody can pick up, anybody can, from the panelist, can highlight the issue of the patient who had come to me. He just complained of itching, recurrent itching, recurrently presenting to me saying that, sir, I have itching. When I retracted the papillae, nothing is same. Very important, anybody can talk. Anybody can talk. Anybody can speak about it.
Sir,
yes.
as per the peak, it observes, I feel it lot of dryness. So xerosis, that might have caused that sort of itching sometimes. Or in case if there is any history of any application or any excess usage of any condoms or contact dermatitis, anything might, because as such there is no inflammation, only we could see only the thickening of the skin and dryness. So I feel maybe the dryness.
Very good. So far as the outer aspect,
Pigmentation with few increase in skin markings could be LSC also.
yeah, good. Anything else, Venkatrishna sir or Mohanlal sir?
Maybe fungal infection also, symptoms.
I retracted the papillae, nothing is seen.
It can be because of allergy, because of condom.
He is not using, sir, he is unmarried. It is as open to the panelist as to the audience, because nothing has been tailor-made in this. It is touch and go in this case. This case presented with itching recurrently, and I have elaborated this on picture. Let me. Anything you want to tell? Yes,
can it be a tinea like yesterday?
Nothing is there. Nothing is there. Nothing is there. Nothing of that sort. Nothing of that sort. I made it very clear. I pulled the prepuce and showed you something there.
Long prepuce.
Very good. Kavita is good. Kavita is good. There is a redundant prepuce. The redundant prepuce in an individual, thereby a physiological presence of smegma, can itself cause a condition called SIBP, subpreputial belonoposthitis the patient had, and he was recurrently presenting with this symptom of itching underneath the prepuce, whereas after having retracted the prepuce, nothing was seen. So the redundant prepuce can create such a big problem that since redundant prepuce is there, there is an anaerobic environment available, the smegma itself providing as a cofactor for the development of the fusor spirochetes or otherwise the bacteria which are physiological present, thereby creating an environment that may create problems for the person in future having a redundant prepuce, thereby going in for phimosis, and majority of them presents with the paraphimosis later on. That was the problem in this case. Hence I advised him to go for a circumcision, thereby creating the confusion of itching getting reduced. So there is absolutely no history of exposure in this case, and why I have presented this case is often the patient come with this complaint, please see whether there is a disproportionate presence of prepuce on his penis and then decide about the issue in controversy whether there is an STD by having known that he has an exposure or no exposure, and thereby coming to a drawing an inference that it could be just a physiological phenomena, a smegma accumulating underneath the redundant prepuce, and thereby creating this confusion whether it can be an STD or non-STD. Remember all those that, as Venkatesh sir has emphasized, that all those lesions that are present on the genitalia are not necessarily STD. Do not get panicky when a patient with genitalia, with a lesion on the genitalia comes to your practice. Be confident. It need not necessarily be an STD. It can be a physiological phenomena also, as we have seen in this case. Now the second case. This man presented with a macule first. He is an advocate by profession, no history of exposure, married. That is the history and that is the lesion.
So, traumatic lesion.
That is one possibility, true.
One thing is, even in this case, one thing trauma, because acute 5 days duration means any history of any application or contact dermatitis, and mainly the herpes. Even we need to rule out the viral infection herpes also.
Very correct, true. This patient had, if you can see the second slide, see the second one, a grouped vesicular eruption on the glans penis, and associated with a acute pain radiating to the left gluteal region. So remember a lesion on the prepuce, do not get prejudiced that nothing is there under surface. Please, every time when you see a case of lesion on the prepuce, please put an extra effort to retract the prepuce and see. Necessarily there will be some lesion also which will aid you in diagnosis in such a circumstances. See, when you saw the first slide, you were prejudiced that it is a traumatic, but when you retracted the prepuce, then you can see a group vesicular lesions which turned out to be, of course, herpes progenitalis with radiating pain. Thereby I subjected him to undergo a treatment with valsiclovir 1 gram TID. Then that is the result. So the limitation for these such type of cases is you cannot ask the patient to go for a zinc smear and all and try to ask him to come back and show you the lesions again, or to come back with investigation. It's not generally not possible, because as you all know, a patient having a lesion on the genitalia is very, very shy to be present in front of you, and you ask him repeatedly, he may not turn out. You have to pick up the case at the first go and start the treatment, and you must be very thorough with the lesions on the genitalia. Not necessarily it is an STD. He had a episode of herpes progenitalis earlier, and this was the recurrence. Now this case. Panelists, please. Sangeet.
So clinically, we can see a hyperpigmented macule and with a thin ring-like kind of a border on the periphery. So clinically, as it is hyperpigmented, it could be a annular LP, lichen planus, annular lichen planus, and the second possibility, it could be a post-inflammatory hyperpigmentation secondary to FDE. So two possibilities.
Very good. Yes, more scope to the panelist here. Audience can keep their questions ready. At the end of the session, we'll have a discussion for that also. Yes, please. Thank you. Shahana, yes, please. Shahana.
So, as annular LP is more common in genitalia, that could be the first differential diagnosis.
Very good.
You should ask for any history of drug intake, sir. Then you can go for FDA or history of recurrence. That can be ruled out.
Correct.
And pH, as already said, if at all there is any application, you can think of pH also.
Correct. Very good. Yes, anything more? Sir, Venkateshna sir. Venkateshna sir may highlight about this issue, because sir is so good, so considerate that he keeps on posting his private clinic cases in the department faculty, and he doesn't comment on that, but he keeps his comments reserved.
Actually, this case came to my clinic.
Very good, sir.
First I thought of FDE. Next possibility is melanotic macule, lentigens. So I thought of lentigens.
Yeah.
So
yes. True.
Lentigens.
Sir, that is true. See, my request to all the audience, to all the postgraduates is, when you see a case of lesion on the genitalia, please also see if there is a mirror image there. This has been very rightly proved as a kissing lesion, kissing melanocytic nevus. That is how it goes by literature, that there is see, this is an opposed surface. If you bring back the prepuce, there will be a contact of lesion on either area. So it was diagnosed as a rare case of melanocytic nevus called as the kissing lesion, kissing melanocytic. Thank you, Venkateshwar sir, for having such a good case to presenting before the faculty, where the PGs could learn more and more about the genital lesion. Sir is so good, Venkateshwar sir, he keeps on all genital cases, apart from all the routine cases what he sees in the faculty group, makes us learn many things. Thank you, Venkateshwar sir.
May I
for
know
that
the
case.
investigations done to prove it is melanocytic?
Correct. See, Kavita, what happens is we subject them for investigations, they run off, they don't come back to us. That is the problem with the cases with the genital lesions. That's what I am saying. You have to be precise when you are trying to diagnose a case. Venkateshwar sir has already done that and confirmed it as a melanocytic nevus.
Sir, here in this pic,
go back to that case. Yes.
Yeah,
yes,
in last pic, one more finding is there. This patient has got perlipenal papules.
Of course, very good.
Maybe he is not complaining of that.
Yeah.
But usually what I see in my practice is perlipenal papule patient, they notice it after they get some, after the exposure. And they complain that
Very good.
that immediately after that exposure, I have developed these papules.
Very good. A great point. A very good point.
But patient,
Correct.
he doesn't know that he has it before that exposure also.
Correct.
That is, it went unnoticed. But after exposure, he focuses on his genitalia and he develops and he comes with the complaining of perlipenal papule. But here, in this case, what I suggest to the students, juniors is, don't give any treatment. Look, as patient came, let us give some nutritional supplementation and that stop that thing of attitude. Don't give, just assurance is enough for this.
Yeah. The other aspect is, do not try to meddle with the patient which is not complaining of. Please do not go into the details what the patient is not complaining to us regarding any lesion anywhere on the body. Do not probe into the things which are not made as a complaint to you. An ardent request for the postgraduates and the juniors, do not try to meddle with the things which he is not presenting to us.
Suppose patient insists treatment, what could be the treatment of choice in this case?
Yes.
So I should not ask, but
supposing the patient is asking for a treatment. Yes, panelist. Correct. Supposing the patient asks for a treatment. Yes, Sangeet. Now what can be done?
That divided nevus, previous one.
This one. Supposing the patient wants to get rid of this pigmentation. Yes, Sangeet. Kissing. Yeah, nevus.
Sir, first of all, I would just want to do a biopsy basically, sir, to confirm the diagnosis.
Very good. Very good. Now the patient wants to get rid of it.
Actually, I am not convinced with the diagnosis, sir.
True. That is true. That's a point. But see, in established case of melanocytic nevus, a kissing lesion present, prima facie evidence of kissing lesion present, and diagnosed as melanocytic nevus, having a histopathology. Now, how to get it? Yes.
Concern, then QSH laser can be done, sir.
Very good. Yeah, that's a point. QSH laser may be great help to all in getting rid of these lesions.
If it's
Yes.
a melanocytic nevus, but a surgery also can be indicated.
Kavita, let me tell you, anything you do surgery on the genital area, the patient will come back with you with innumerable complaints that he has problems in the future and he will not leave you, remember. So all be very careful for tampering or manipulating anything doing on the genitalia. Be cautious, do not try to. Yes, Manmohan sir wants to ask something. Yes, sir.
About this.
Yes, sir.
About this case.
Yes, sir.
If there is a history of exposure,
of course.
Why can't it be a kissing ulcer of a sexually transmitted nature, which healed with pigmentation?
Yes.
Pardon? Unusually they can.
Sir's doubt is genuine. Sir wants to rule out an STD.
Because there is history of
sir,
exposure.
Manmohan sir, let me ask you what could be an STD of this sort. Because we generally do not see any hyperpigmented lesions on the genitalia associated with STD conditions. Generally we don't see, sir.
Now, sometimes tuberculosis, sometimes other rotavirus infections can also cause that.
Agree. Possibility.
No, I'm kissing ulcers of other natures are also there, no? No, because once you make a diagnosis of a melanoma or a benign,
yes, sir.
so that
Your point is valid, sir. Your point is very well valid, very well taken. But so far in my experience, I have never seen an STD which is presenting with a hyperpigmented lesion, especially of this sort, a mirror image on the prepuce as well as on the glans. I have never seen. But literature so far as kissing lesion is present, I have already made it clear that kissing melanocytic nevus, kissing lesions of melanocytic lesions have been diagnosed. Yes, sir.
And the second point is, you were telling whatever is the patient complaining, you see that. Don't go to the other areas.
Yes, sir.
That I will not agree for that, because the patient may be complaining of something which is troubling him, but he may be having some other thing, like in Hansen's patient, he will say only there is some eczema or something, but you can't ignore the other areas of the body.
What I mean to say is, the patient, if he is not complaining of the lesion present anywhere else on the body, as Dr. Mohanlal presented, that this case has perlipenile polypils. Do not try to probe into things which are not necessary for. That's what I mean to say. Like since Dr. Mohanlal very clearly said, sir, the patient has perlipenile polypils. Yes, of course he has. But never try to meddle with the case which is not presenting. That was my idea, sir. Nothing else. Yes, nothing else. Nothing apart from this. In this context, I said, do not try to probe into the things which are not available for discussion. This case, please. My dear panelists.
Sir, clinically the lesions are on the scrotum and appears to be hyperkeratotic warty papules, mainly on the scrotum. So based on the clinical picture, my first diagnosis, differential diagnosis is angiokeratoma of scrotum. Second is bovenide papillosis, and third is seborrheic keratosis.
How do you go about investigation, Sangeet, in this case?
So we have to do a biopsy, sir.
There is history of multiple exposure present here.
And verruca is a possibility, definitely, but as there are multiple lesions on the scrotum, looks like more of warty papules. So first it is angiokeratoma of scrotum, genital warts, bovenide papillosis, and seborrheic keratosis.
Very good. So far as the picking up of a differential diagnosis is concerned, Sangeet is very good. What are the other investigations you would like to do, Dr. Sangeet? In this specific instance, since he has multiple exposures.
Screening, sir, HIV, retrostatus as well as the VDRL.
Yes. See, inevitably in all cases which has multiple exposures, you must necessarily do a VDR and HIV test, because the patient may present in exclusive lesions of LATA lesions on the scrotum or on the intertriginous areas, and then you may have a VDRL very high titer. We do not know that we are seeing a case of LATA lesion and that we are missing a case of syphilis which is more grave than what we are discussing. So as Sangeet rightly said, the 4 differential diagnoses, angiokeratoma for this. Sangeet, may I request you to repeat this? Yes?
Angiokeratoma of scrotum, sir.
Yes.
And verruca, genital warts.
Yes.
Bovenide papillosis and seborrheic keratosis.
Yes. All these possibilities very rightly said, and the treatment rests on an individual. Now the next case, please.
So it could be a candidiasis, asymptomatic for 2 years, and even psoriasis, flexural inverse psoriasis. MSM means I just go with candidiasis, or even condyloma lata.
Partially treated warts, perianal warts.
Yes. Shahana?
Sir, mostly looks like hyperplastic candidiasis being MSM, but still I can think of even LSA also, lichen sclerosis atropicus, flexural psoriasis, as I already told.
Yes. So far as MSMs are concerned, the repeated trauma, a lesion developing there. Remember, any lesion of chronic nature may turn out to be a psoriasis. This patient was a passive homosexual. He presented to us repeatedly, finally came with this lesion, a plaque on the perineal region, where we were really worried what it could be. Then we went on to screen this patient. He was neither HIV positive nor VDRL positive, and often let me make all of you very clear, these MSMs are very intelligent. They are not presenting with majority of time with VDRL reactivity or HIV positive. They are very, very safe they are when they play the sex. They do know the repercussions of having multiple sexual exposure, especially in the situation of MSMs. They are very intelligent. The majority of the times I have seen that they have never turned out to be VDRL positive or HIV, except for very few instances. You can go back to the literature and see very few cases are showing VDRL reactivity and HIV positivity so far as MSMs exclusively are concerned. So this case turned out to be truly a case of psoriasis and was treated accordingly. This case was given by our professor, Dr. Venkateshna sir. It was really very good case. The patient came to the department of DVL Usmania General Hospital, to the STD clinic. PGs were running from pillar to post. Sir, what is this case? What is this case? Yes. I would like audience to highlight this, please, not the panelist. Yes, sir. Anybody in the panelist can make a diagnosis about the situation. Bhumesh is extraordinarily correct rather, since we have presented this case in CUTICON also, where people were bewildered. How can you have a huge smegma, a bunch of smegma, a group of smegmatous lesions getting accumulated here? This patient, a rather common phenomena, we were trained right from our childhood by our parents that we should clean the undersurface, the prepuce. We as a doctor must also train all the patients who come to us in STD clinics in a DVL department that you must get the smegma cleaned regularly underneath the prepuce. If you find a redundant prepuce or a normal prepuce also, we are forced to tell them to clear. See, it may appear silly, but see the accumulation of smegma for a patient who has not cleaned himself for this is not pictorial, please. This is real, which the patient has come to the department, and that was truly referred by Dr. Venkateshna sir, who then I think Dr. Venkateshna sir was also apprehensive about the case, thereby sent the case to an STD clinic. Though at the back of the mind he also had that this is a smegma present, but yet he preferred sending the case to the department of DVL Usmania Medical College, where my PGs tried. See, we do not go and touch the lesion as we see a case of genitalia, a lesion of the genitalia. We are very afraid, and we go to find a differential diagnosis of a situation which is available for discussion, because this patient presented nil exposure, and to discuss is very difficult. So we keep on asking him whether you had an exposure. We repeatedly try to barge upon his idea of masking that he has not had an exposure. He was very angry and he said, no sir. Then Venkateshna sir, some PG asked him to go and clean and come. Then the patient went and cleaned that and came back to us with this. Really funny, but remember, that's how the case can be. See, all those who are very apprehensive about the practice on the genitalia, do not get perturbed when a lesion on the genitalia is brought before you in the clinics respectively, but be bold to try and manipulate the lesion physically by having yourself well protected. Do not get apprehensive. Do not get scare or scary lesion which is present in the genitalia, that it can be a worst disease. Please do not do that. Everything is possible, right from the physiological phenomena to a pathological disease. So all necessarily must have an idea of retracting the prepuce and seeing the lesion thereby. Yes, Manmohan sir wants. Thank you, sir. Yes.
These kind of cases we have been seeing of late after COVID infection.
Truly,
they are
sir.
getting admitted in the hospitals. They are not taking bath for 15-20 days.
Very good. Thank you, sir.
They are all coming. So that is one thing we should always keep in mind.
So, thank you very much, sir. Sir, yeah, this was also highlighted by Murugan sir. Murugan sir, who is there.
But this patient came back again after 3 months with similar complaint.
Yeah, that is the recurrent phenomena. Yes.
After 3 months, daily, instead of, in spite of cleaning daily, patient
quite possible
is there. Similar lesions came to my clinic. After
Quite
3
possible.
months.
Quite possible. Quite possible. Murugan sir wants to tell something. Yes. Yes, sir. Manmohan sir rightly pointed out, which Murugan sir also highlighted in CUTICON that in COVID era you must be careful. What sir is reiterating in the fact that in a COVID era this is quite possible who patients are admitted. Yes, Burgan sir.
In that case, the previous, that is blackish accumulation, previous to that, as cheesy, yellowish, that is that itself, when you look, it can give a clue for smegma. One thing. Second thing I want to emphasize is, most of the patients, even at the age of 55, never have been opened their genitals, that is prepuce. I have seen, we have seen a lot of people.
Truly, sir is very right. Even at the age of 55, people do not bother to retract the prepuce and clean themselves. This has the problem rightly pointed out by
As
sir. Yes.
moderators tell,
Yes,
we
sir.
have to train each and every patient to how to clean. That is from the childhood onwards. That is very important. Thank you, sir.
Thank you, Murugan sir. Thank you, Manmohan sir, for highlighting the major issue of cleaning the prepuce in COVID era. This is very redeeming point. Thank you, sir. This is how the patient came back, and Venkatesh sir says this patient has had a regular visits to sir for accumulation or collection of smegma underneath the prepuce. Then the last resort will be circumcision. There is na rahe baas na baje bansuri, it is called. So let the prepuce be not be there, and so you do not have the accumulation there. So that get rid of your recurrent problem, Venkatesh sir. I think sir may kindly request the patient to go ahead for circumcision, thereby getting rid of the patient with this kind of situation.
This is a multiple genital MC. You can see extensive even over the medial aspect of the thighs. Actually, ART itself sometimes induces iris, as we all know, where as the immunity increases, there will be a lot of sudden eruption of MC. Continuation of ART itself will lead to improvement in the skin lesions, sir, actually. No need to go for any treatment. We can wait and watch for a few months. Once there is increase in CMI, probably it will subside by itself.
Excellent, Shana. Anything else Sangeet would like to discuss?
As per the history, there initially there were no lesions. The patient has developed these lesions only after 3 months of starting. It clearly indicates that immune reconstitution inflammatory syndrome, where there is a paradoxical worsening of existing lesions or appearance of a new lesions after starting the treatment. And what happens is, initially there would be a flaring of the lesions, but after continuing with the ART, definitely there will be a resolution of the skin lesions.
Very good. What is the diagnosis, Sangeet, here? May I know the diagnosis of two situations here?
MC iris.
That is one. Penile lesions, please.
There are multiple verruca, I feel, sir. Plain warts.
Yes.
Like bovinoid papillosis.
Bovinoid papillosis is a pre-malignant condition having developed after the patient have started ART, rightly pointed out as an iris phenomena. As rightly said by Shahana and Sangeet, that continuation of ART therapy, although we tried with applications of TCA, because we were really afraid that whether these patients will resolve with heart treatment, though the literature is available, but we simultaneously had applications of TCA as well as going ahead with heart.
One more thing, sir.
Yes, Murugan sir.
Cytomegalovirus skin infection also looks like MC. And penicillosis, that is a penicillium, that's also sometimes may manifest as molluscum disease. We have to be very cautious and we have to be confirmed with some biopsy or something.
Yes, sir. Thank you, sir. Thank you, sir. Thank you very much. Now, what is this? The same case? You people said the lesions will go with treatment, but what is remaining there?
Penile lesions.
Yeah, penile lesions. So, what could be the reason? My dear PGs, my colleagues, two important issues in treating cases of heart. Few are CD4 dependent lesions, few are CD4 independent lesions. And heart therapy, MCs are CD4 dependent, hence they have gone. The HPV, which is independent of CD4 count or independent of treatment, this will not go unless you get them destroyed. So what remains is HPV virus, which is not dependent on CD4 count, whereas MC, remember, it is always dependent on CD4 count. Thereby the the prevalence of MCs in a patient when CD4 goes down to 100, where we started heart in this case and continued to give heart to increase the CD4 count. The idea is to kill the virus as well as increase the CD4 count simultaneously, where in this situation we could get rid of molluscum contagiosum, but the bovinoid papillosis, the HPV lesions remain. This is, I made this point because two types of situations prevail in a patient with immunosuppression. One is CD4 dependent lesions, other is a CD4 independent lesion. That was the idea of presenting this case before you all. This case, please.
So, asymptomatic lesions, known case of RVD, could be condyloma lata, sir, VDRL 1 in 256.
With VDRL 1 in 256, no rash anywhere on the body.
And herpes genitalis can also be thought of.
These are the exclusive lesions on the vulva. Then absolutely no lesions anywhere on the body, please. Panelists, please. Is there a possibility of condyloma lata lesion? There is no rash anywhere in the body.
Definitely.
VDR is showing 1 in 256. Then what could be these lesions?
In case of...
Yes, Kavita. Good.
Genitalis can occur like
That is other possibility.
They can manifest only with condyloma lata, sir, without even rash or some evanescent rash which the patient might not have noticed, or sometimes without any rash they can only present with condyloma lata also.
Sir, syphilis DML is one where you can think of, sir, probably. Primary lesion may not be there.
Yes. My dear panelists, my dear audience, condyloma lata often is, yes, Raghavendra sir.
That may be a positive, and I have seen in my experience one case of anomalous presentation, only presentation of the condyloma lata, because this looks like a moist type of lesions or some granulomatous type of lesions that are present.
Correct. The basic dictum, correct sir, thank you sir. The basic dictum is, when you see a lata lesion, often you see them independently without rash. It is the same rash of syphilis which is present on the intertriginous areas,
Sir,
thereby, yes,
minutes,
Padma,
sir.
yes.
Another
Please.
4 minutes, sir, time.
It's over, no? Almost over. Yes. So, see, what I was trying to emphasize is condyloma lata lesions, when you see they are an independent lesions, independent of the rash, you often see them not associated with rash of syphilis because it is the same rash which is present in the intertriginous areas, the rash thereby becoming exuberant and be present because there is a continuous triggering factor that is an intertriginous area, such as those in the vulval region, both the labia, both the lips of the labia, thereby presenting as a persistent lesion called condyloma lata. Truly, Kavita, you are right that it is a condyloma lata lesion. I tried to confuse you saying that no rash present on the body. May I request all the audience to remember the point that lata lesions independently present in the absence of rash anywhere else on the body. Commonly you see them independent of the rash, thereby clinching the diagnosis of condyloma lata in a situation where serologically it is highly positive 1 in 256. Thereby, after treating the case with benzathine penicillin, all the rash vanished, including the lata. This is another case which was posted in, we have a group called TS IADVL Academics. One of my postgraduate presented this. Yes, panelists.
Leukoplakia or hyperplastic candidiasis or even post procedural, any cryo.
Yeah, it is.
Pseudoepitheliomatous, my case is hypercreative plaque also, you have to rule out balanitis.
Yes, sir. Yes, sir. Yes, sir. Now we have less time. This case.
This looks like LS, lichen sclerosis atrophicaus. And even we can think of vitiligo also, sir. As the folds are involved, could be it is vitiligo. If at all there is narrowing of the introitus and all, it could go in favor of LSEA.
I just wanted to make clear from the panelists that whether it's a case of vitiligo or with the case of LSA or an LSA with vitiligo.
It can be coexisting, sir, yes, because it is mostly autoimmune, both can be.
Can LSA lesion occur on the intertriginous area?
Yes, sir.
Can occur.
It can.
Yeah, rightly said, it was a case of LSEA only.
And moreover, vitiligo, there is no age bar because she is elderly female, we can think it of LSA.
Correct. The last question.
Sir, the penis case, what is the diagnosis, sir, the earlier?
LSA only. LSA only. Penile lesion, it was yet to be concluded, please. We could not achieve the conclusion. This is for a discussion only. Yes. This case. Now this is open question for everybody, please. What should we do in this situation? One of my PG came, sir, please tell what to do in this situation which has prevailed now, what to do. It is for everybody, sir, this question. 35-year-old, positive on ARTs in 6 months, he is having unprotected sexual intercourse with his wife. Patient was advised to bring his spouse for HIV screening, which we often do in an institute. Patient did not want to disclose the HIV status to his wife. What is your stand as a doctor in this scenario? What should be done?
Sir, actually the basic thing is it should be a voluntary screening. We should not force the...
As a doctor, you have asked his spouse to come to us, and now what is your stand so far as disclosing the fact to the wife is concerned?
We should ask whether the wife has any symptoms, then that will be very easy. Then we should tell the husband to come with the wife, do the counseling saying that it's a routine counseling with any symptoms if at all there, or you can go for a follow-up also.
Sir, yes, please.
Yes, Murugan sir.
As per the law, we can disclose it to the spouse.
Yes.
Because it is very necessary, it should not come to the spouse in your case. And spouse and doctors, medical professionals can be informed without the consent of the individual.
It's a point, sir. Thank you. Thank you very much, all of you. Thanks, panelists. Thanks, chairpersons. Thanks, all the audience.
So the next session.
Thank you, organizing committee, for giving me this opportunity.
PMTCT.
Thank you.
Sir, the chairperson.
I thank
I
on behalf
request all
of Dr.
the
Chandra Reddy,
faculty members,
thank
please
all
join
the
at photo
organizers
booth.
to give this golden opportunity. Thank you.
So the chairperson, sir, Dr. J. Chandraidu, sir. Sir, please come. Dr. K. Ramdas, sir. Both are senior most dermatologists, needs no introduction. They are familiar to all of us. Hello. No need of it.
Let me turn this off.
Sir, please start the session, sir. Chandraidu, sir.
Thank you very much to the IADVL for making us a chairman for this session, and I congratulate the IADVL because they are doing very well and they are conducting this session. And also I thank Dr. Bhumesh. He works very well for this association and sending so many messages for us. So many people have joined the group. So now the session starts. So I invite Dr. B.N. Reddy for the management challenges of a PMT-CT. I invite Dr. B.N. Reddy.
Dr. B.N. Reddy is working as professor of DVL, Medicity. He is not only faculty, not only teacher, PG and UG, he is a gynecologist plus dermatologist.
Thank you, chairpersons, for my introduction. Audible, huh? So today's my topic is mother to child transmission. You know there is HIV is always a problem, so we should know how it gets transmitted from one person to another person. Usually it is sexually transmitted, and next blood and blood products, then mother to the child transmission, and intravenous drug abuse. So these are the 4 modes of transmission. So here we are concentrating only on the mother to the child transmission. So we should know, since it is blood transmitted, so there is efficient way of transmission. Though the common way of transmission is sexual transmission, but most efficient way of transmission is blood and blood products. So it is, the prevention plays a major role in mother to the child transmission. So our objectives of today's talk, so what is the HIV and what are our special population? The special population is here the mother and child. And how to avoid means, so before pregnancy, during pregnancy, intrapartum, during labor, delivery and postpartum. So these are the various places where we can intervene with the initiation of ART drugs, antiretroviral drugs. And we should also emphasize the importance of adherence. That is very important. So counseling and adherence. And at the same time, once child is delivered, how to prevent transmission further in the postpartum period, and breastfeeding advice also. So these are our objectives. So if you see the incidence of HIV, globally there are about 36 million cases are there still. There is no change. Only thing is the mortality has decreased because of the ART. In India we have got about 6 lakh cases are there, and in these the most prevalent states are Maharashtra, Karnataka, Telangana and Andhra Pradesh. So almost these 4 states constitute 50% of our Indian cases. Now after the starting of ART, the AIDS defining illnesses, they are decreasing since 2000. Even in the number of new infections are also declining. But only thing is, we should be worried more about the development of the recombinant viruses which are developing resistance. And throughout the globe, still women are almost 50% they are suffering. They are innocent people sitting at home. So ultimately the partner will be bringing the infection to the woman. So same thing in pie chart, depiction of the incidence of HIV in these 4 states. And here this NACO estimates of HIV prevalence. This also tells same thing. The maximum number of cases are there in Far East states because there is intravenous drug abuse is more. That is Mizoram, Nagaland, Manipal. So these are all forest states. And the specialty about these states also, there is a Penicillium marnopi. That's again a opportunistic infection. More number of cases are seen. And the state-wise distribution of these prevalence of mother to the child transmission is a 2019 statistics. That also will tell the maximum number of cases are seen in these 4 states, that is Maharashtra, Karnataka, Andhra Pradesh and Telangana. So if you see the prevalence in India as such, it is 0.8%. But since there are so many states where high incidence is there, but in India, in Telangana, the incidence is 0.49%. It's very low when compared to the other states. And in this, we take antenatal clinics. Every year we do survey. That's called sentinel survey, wherever there is microbiology departments are there, and in a tertiary care hospitals. Under the NACO guidelines, they do survey, and Usmania is also one of the survey center. So this bar chart shows clearly, since 2000 there is enormous decrease in the incidence of the HIV because of the ART. So this is very important slide to understand the pathogenesis and where exactly we should involve, because of this slide also tells you that there are 3 types of progressors. That's classical progressor, also called typical progressor, which constitute about 90%. And another type are rapid progressors. 5% they die within short period of 1 to 2 years. And about 5% they are long-term non-progressors because of some genetically determined. So they don't progress, they live asymptomatically for more than 20 years. So here you see this graph, the blue line shows immunity, that is CD4 cells, and the green line shows viruses. So after the entry of the viruses, there is acute viremia. So during that period, there is high viral load, low CD4 count. So that is the time we should actually interfere, because that time patient doesn't know that he is having HIV infection, and also very difficult to diagnose during that time, because we don't have any tests that which will pick up the infection, and most of the time we are actually not, we don't know whether the patient has got infection, and they present with just like any acute viral infection. So those are the symptoms. So acute viremia is very important phase, and we have got very few diagnostic procedures during that period. So once we overcome this acute viremia, then they go into clinical latency. So this period usually it varies from 8 to 20 years depending upon the progression of the infection. Typically it is 8 years. So till 8 years they remain, they balance both the viremia as well as the CD4 count till we reach the viral set point. So once viral set point, that which determines the longevity of the patient, that is typical progressor. From here onwards, they progress very fast with increase in the virus and decrease in the CD4 count, thereby inviting many opportunistic infections. So after understanding about this slide, so you should know the life cycle of the virus also. Only few basic things I will tell, because it's very difficult to cover everything in this class, 15 minutes. So we have got virus gets attached to 2 types of receptors we have, CD4 and co-receptors, CCR5, CXCR4. So there are 2 types of receptors are there on the cell membrane. So So here also we can intervene. That's called fusion inhibitors and attachment inhibitors. So two types of drugs are available here. Once virus makes entry into the cytoplasm of the host cell, so in the cytoplasm we have a reverse transcriptase enzyme specially meant for these retroviruses, where the RNA of the virus should get converted into the DNA. So here we have got two types of drugs, NRTase, RNRTase, and from here once it gets converted to the DNA, it has to enter into the nucleus of the host cell with the help of the enzyme integrase. So here also we have got very good drugs now. Integrase, actually this integrase inhibitors replacing slowly RNRTase. RNRTase usually associated with a lot of complications, and they develop very soon resistance because their genetic barrier is very low. RNRTase in private practice we are not using now. And once it gets integrated, so this virus joins with the host cell DNA and it starts dictating its term. The progeny completely gets changed, so it goes on producing only the viral DNA. Viral polyprotein is manufactured. From here this polyprotein is broken down into the number of variants with the help of the enzyme protease. So there is in between there are some maturation factors again that also in the pipeline, these drugs, maturation inhibitors. Mainly it prevents the maturation from P26 to P24. So we have got various groups of drugs divided conveniently under 7 heads, so constituting about 26 drugs. So these 26 drugs all are available in India, so they can be combined in so many combinations and used successfully for the progression of the infection. So fortunately this is very timid virus, slow virus, and all these chemicals what we use in our day-to-day practice as antiseptics, they will kill except the Dettol. So we got so many newer drugs in the pipeline, and CCR5 antagonist, that's Sencriviroc, once daily can be used, and we got glycoprotein 120 attachment inhibitors, Fostemsavir, these are the newer drugs, and integrated strand inhibitors, Cabotegravir. This is fortunately long acting. These can be used even for prevention, post-exposure prophylaxis, because they are long acting and even pre-exposure prophylaxis. That should be the right term. So then we have got Relpivirin. That's also long acting. It can be given safely in injectable form from between 1 to 3 months. So that is a sensitivity of this drug can be prescribed for pre-exposure prophylaxis along with the tenofovir. Then we have got combination also, Cabotegravir plus Relpinavir, where once daily drugs can be offered, and this Elvicitabine is a substitute for that is Lamivudine and Emtricitabine, because both the drugs they belong to the same group and they develop resistance very fast. So the Elvicitabine is a new hope for us. Then we have got Doravirin used when other NRTIs like Efavirenz, Relpiravir develop resistance. We have got now monoclonal antibodies here also. So that is monoclonal antibody Pro-140 against CCR5 co-receptors and CD4 receptors. The drug is TNX355. These numbers are given when the drug is being developed in the research. So once it goes those 3 trials, 3 phases, then it is given a proper name. Then we have got gene therapy. So intracellular immunization, example CCR5 delta 30 mutation, if there is homozygously absent these genes, the chances of transmission are very remote. So these are the chances of how it gets transformed. and how we should intervene. Suppose if there is no intervention, no drug is given to the antenatal woman, the chances of transmission are?
Only 1 minute is there.
So chance of transmission are, so I will rush to the slides. So this main drugs actually I will talk about which prevents the mother to the child transmission. So these drugs should be started as early as possible, irrespective of their CD4 count or viral load. So the drug which we have got two types of treatments. One is what NACO or under the WHO guidelines, NACO guidelines, what we follow here, and another is that CDC guidelines. CDC guidelines are different. They where private practitioners they usually adopt that because these expensive drugs, just like dolutegravir. We directly start. Okay, we'll discuss in during a panel discussion. I think there are some questions on this mother to the child transmission also. Okay, I stop because. Thank you very much.
Thank you, Dr. Narayan Reddy. Nice presentation. Now, I request Dr. Murugan, moderator, to take up the session. Come on, sir.
One minute. Before the AIDS and HIV infection, when I was a student, there was no AIDS or HIV infection. When I joined in assistant professor in 1980 in Gandhi Medical College, and also there was no infection. When 83 or 84, when they noticed that there is some cases of something different viral infection, and we have no tests at that time in Hyderabad. So only in Madras it have got. Later in 86 you got a test for Hyderabad to do it. So now that HIV become one of the common thing. When I went to Saudi Arabia, there was no cases. When suppose we do the blood test for HIV, if it becomes a positive, they will send the person back to their country. So we have not seen many cases there after my joining as a professor. So that is it.
Thank you, Chairperson. Good morning to you all, friends. At the outset, I want to thank the organizers, the CUTICON team. Thank you very much for giving me the opportunity to meet you all in this platform. Today, my topic is challenges in the management of HIV infection. I am having wonderful panelists with me, 5 panelists. With all, we will have some discussion. First panelist, I invite Dr. Narasimha Rao Neta, our Telangana State CUTICON Scientific Chairman, Professor of and HOD, Dermatologist, Gandhi Medical College Hospital, Dr. Sivarami Reddy, Professor of Bhaskar Medical College, please come over to the dais. Dr. Raghavendra Rao, Malla Reddy Medical College Professor, Hyderabad. Dr. Ramesh Nani Shetty, Chief Surgeon in Railway Hospital. Welcome, sir. Dr. Shankar is not joining with us. Instead of, I am calling Dr. Mohanlal, sir, please come to the dais. Of course, we are having our BN Reddy sir also. Challenges. The once killer disease becomes a well-managed chronic disease by the advent of ART or heart. The course of the disease is perplexing and varying with individuals with regards to acute infection, duration of the asymptomatic period, morbidity, immune recovery, varies. Drug resistance and drug interactions all poses challenges in the management of HIV disease. The challenges may be in the form, challenges in the diagnosis in the window period, in a newborn, challenges in acute infection go unnoticed often. Early progressors, as told Dr. B.N. Reddy, early progressor, long-term progressor, some are progressing fast, some are progressing slowly. Co-infections, TB, hepatitis B, hepatitis C, comorbidities, so many things, CVS, kidney disease, lung disease, so many things, and hypersensitivity, adverse reactions, all poses challenges, intolerance and iris, of course, immune reconstitution syndrome. Challenges in monitoring the toxicities and also the prognosis of the disease. Aging, of course, pill burden, polypharmacy, so many other comorbidities once again. Adherence, drug resistance is also an important challenge. We are not going to touch all these things, we will touch some of the things. Challenges in the diagnosis, one can diagnose HIV infection only with HIV, just with the symptoms alone we cannot say, because most of the symptoms goes with many diseases. So we cannot particularly pinpoint with the clinical picture alone, we have to diagnose with the lab diagnosis only. Only with that we can confirm. And during window period, the antibody test will not be reactive. So what is the right time, what is the right test? And during neonatal period and HIV-2 infections, all these poses in the diagnosis. Tests are available as antibody detection test, antigen detection test and culture, of course. Antibody detection tests are varying number, rapid test, ELISA test, Quick, Western blot, and third generation and fourth generation is a combo test along with antigen and antibody test. Antigen tests are nucleic acid test, P24 antigen, DNA PCR, RNA PCR, qualitative and quantitative. Most of the antigen tests are reactive within a week, even though it is reactive by a week, but it is more confirmatory by 3 to 4 weeks. And P24 antigen will disappear after 6 months. All these things we have to keep it in mind while we are prescribing the right test. So here is a case history. I had a boy, 25-year, unmarried, came to my hospital brought by his mother. He was weeping, melancholy state. He had an intercourse under the influence of alcohol with his friends 1 week back. Somebody told that the lady has some HIV disease. He was weeping, he was having suicidal tendency. The mother was upset. So he was not ready to wait till the completion of window period. Mother was also upset. So at this stage, what can we do? Dr. Ramesh sir, please, how will you handle this patient? What you think the useful thing in this patient?
This type of scenario we generally see whenever the news of HIV being HIV positivity is disclosed to a patient. This kind of phobic behavior generally we come across. But this young boy whose status is yet to be confirmed being positive, he must be already very depressed and psychiatrically suffering patient. So I think we need to bring in the services of a neuropsychiatrist, because we are not competent in dealing with this kind of patient scenario who are intensely suicidal tendencies. So such cases either should be managed inpatient, particularly supervised by a psychiatrist, when they would, apart from the psychodrug therapy, they would also use techniques which would take the mind off from suicidal tendencies from such patients. So some kind of a dialectical behavioral therapy is the thing. Nowadays the psychiatrists use that therapy in diverting the thought process of the patient who always thinks about ending his life for any stressful reason. here the fear of being found positive for HIV with a single episode of exposure, and in spite of being told the rationality of waiting for a certain period before the confirmation of the test could be made, he is prone, the history suggests that he is prone for committing suicide. So that's the most important thing, that you should manage him effectively and not allowing him to enter into such a critical situation again. And we even have to counsel the single parent left, that is mother, also in a very agitated mood. She is also upset. So counseling forms a very important aspect, and this window period, since he has not completed, I think as your presentation said, NAT is the test which can give the result if it is positive. Nucleic acid amplification test is the test of choice, and of course other PCR, P24 tests and antibody tests at a later date can be done. And as I said, the limitations are these tests are not widely available in the semi-urban or rural areas. Only in city, urban place areas only these tests can be done. That's one of the limitations.
Thank you, Ramesh sir. Yes, you are correctly pointed out. Counseling by us is sometimes infutile, so we need to seek the help of psychiatrists. Okay, correct. And nucleic acid test or polymerase in fact test may be helpful, but it is a little costly and as he said, not available. One more limitation is this PCR test will rule out only the HIV-1, not the HIV-2. So HIV-2 also, even though it is very rare, sometimes it may occur. So we have to, that is also we have to keep it in mind. But HIV-2 PCR is available separately. Unlike the antibody test, it cannot find out, we cannot find out in both the thing same.
I want to add one more thing.
Yes.
See, with this, there should be a consultation with good social workers should be there, and it should be in constant observation, because there is a suicidal ideolatry is there, so it should be under constant observation and see the any symptoms, development of the symptoms further. Suppose he might have contacted by, sometimes he may fall this side or that side. He is like a cat on the wall type. So if he fall on the other side, so he may develop symptoms in due course of time, and then likewise we have to go and introduce the treatment with ART and other things also.
Correct, sir. Thank you. But this patient, we were able to convince the patient with a PCR test, he was convinced. This is also correct. Okay, thank you. The next thing is, antenatal mother with a poor adherence with ART, her viral load is more than 30,000 copies, and she was already 34 weeks pregnancy. She delivered a baby. What we have to do with that baby? How would you follow this baby after this in case of breastfeeding? Anybody, sir?
The patient, the mother is if you see the count is more, and she is on poor adherence. That is the main problem. So there is an increase of the viral load is there. So there may be a failure of the ART. We have to think about the first line of drugs if there is any failure, and we have to go according to the second line of the management, because there is increased viral load is there.
What about the baby, sir? So that is very important.
Baby, we have we have to see the first 4 weeks. We have to see under observation and see the any antibodies that are present, because they come from the mother also. Maternal antibodies will be there. So it will work out for at least 18 weeks, and we give a AZT treatment. That is
Yes, we have to start there. If that is mother's titer is more than 1,000 copies, we have to take it. Every chance for the baby would have been infected, as sir pointed out. There is a passive transmission of antibodies from the mother to the child may exist up to 18 months. So in that case, we have to go for that is NAT, nucleic acid test only. So this test, before we have to get the result itself, we have to start the prophylaxis either with nevirapine or zidovudine. That is a must. And immediately we have to test the baby, and then 4 to 6 weeks once again, and after 6 months once again. If it is remain negative after 9 months also, almost it is negative. Suppose in case the baby is breastfed, we have to follow the baby till 3 months after the stoppage of breastfed. So then only up to 18 months we have to follow the baby, then do the test, and when the baby is negative, we can proclaim or we can declare the baby is free from HIV. Thank you. Acute infection, all of you knew, seroconversion illness, and usually manifests as a ordinary flu-like syndrome. Anybody would likely to miss it for ordinary fever. It usually occurs within 4 to 6 weeks after the exposure, and only 50 to 70% of the individuals will likely to have. So here is one case, a 25-year-old lady married since 8 months. She suddenly developed a fits and unconsciousness, and 1 month back, and got admitted and treated in a corporate hospital at Madurai, and she was brought to our place by her mother in an unconscious state. Her HIV-1 was reactive, and her viral load is more than 2,85,000 copies. Western blot also reactive. CD4 count is 254 cells per cubic millimeter. Antibodies for CMV, HSV1 and rubella were detected both in blood and CSF, and she was started on ATT and ganciclovir. ATT, presumptive ATT, as India, our country, tuberculosis is the first has to be choice or ruled out. And patient was on ventilator for 3 weeks because of respiratory failure. Ganciclovir we stopped the ganciclovir after 3 weeks because of severe neutropenia, pancytopenia, and patient was put a tablet valsiclovir 1 gram twice daily. Response to painful stimuli was present. Response to commands variable, unpredictable. She was responding to her mother's voice, not anybody's voice. And patient was put on valsiclovir tablets, cotrimoxazole tablet, all in rails tube ATT. Patient succumbed to death without responding to drugs after 2 weeks. Prior to the date of her illness, she was quite alright, healthy as per her relatives, and no obvious history of previous illness. Her husband was also reactive for HIV-1, but he is not willing for further investigation. He has an act of denial. He looks healthy and healthy in appearance. Now, previously treated corporate hospital, her condition they thought has suspected to be due to CMV encephalitis, so started ganciclovir and presumptive ATT, and there was no response with the ganciclovir or ATT. Instead, ganciclovir toxicity developed, and her parents were non-reactive for HIV, so congenital or parental mother-to-child transmission also ruled out in this case. Now, what is the possibility? Could it be an acute infection? How can we confirm? Could it be acute infection will be so severe? Usually it is a go unnoticed mild flu-like syndrome. Her antibodies to HSV1, CMV, rubella, and could they play a role in this patient? So these are anybody wants to answer? Dr. Reddy Garu, BN Reddy.
Since HIV is a neurotropic virus, there is every chance there is HIV, acute HIV encephalopathy.
Yes, acute encephalopathy. So yes, in secondary syphilis also, mostly skin rashes, condylomalacia. Some patients may go for meningitis. Some patients are vulnerable. Individual vulnerability is there. So this is possible one thing.
So,
and
she comes under rapid progressor.
Yes, good. And one more thing, sir. Could it be any role for CMV in this case, CMV or herpes in this case?
In acute stage of the infection, there is a possibility of the OA also, opportunistic infections. But this is a different stage, because when compared to the AIDS disease, this is a reversible type. When occurs, suppose there is a possibility of acute candidiasis can occur in the acute stage, or some other pharyngeal type of candidiasis can be reported. But they are all reversible type because the patient is good prognosis when acute stage. So like that there may be a possibility of the CMV infection in this acute stage of that is my doubt.
But this is a mostly antibody test. Antibody test not always necessary to be likely to be active infection, but it may be subclinical, it may be flare up, that's also possible. Anything else could be done for this patient?
So we have to start the treatment.
ATT is a
regarding ATT.
ART usually when the patient is very acutely ill, guarding, sometimes the patient may go for iris or some patient may think this is a worsening. So that is when the patient, till the patient gets stabilized, ART, usually acute infection, they are recommending ART, but usually in this case, when the patient is severely acutely ill, till she stabilized, we have to wait. Because of that, we have not started the ART. And one more thing, could it be acute, that is acute infection, how can we confirm?
P24 antigens we can do.
Yes, sir?
P24 antigen.
Yes, any antigen test can prove this. But here, one more thing, adverse thing is, she is also positive antibody test, Western blot also positive.
Yes.
Usually, acute infection, she will be in the window period. So that's also we have to note. So maybe
it may be, she might have not given the previous exposures may be there, we don't know.
Okay.
Because that may be the one thing that will now be precipitating into the present stage of the disease.
Excellent, sir. Thank you, sir. Thank you, sir. Rapid progress, as she was not responded to oral valsiclovir 1 gram twice daily and more than a week. So HSV encephalitis also ruled out. But in this case, we have to rule out toxoplasmosis and cryptococcosis also. We have to screen and rule out. That's also another thing. And this case may be a rapid progressor. A middle-aged male patient who was on ART treatment suddenly developed fits, unconscious disorientation. MRI reveals he is having progressive multifocal leukoencephalopathy. His CD4 count is 500 cells, and we lost the patient also. Another patient, similar patient also, we had PML with CD4 count more than 400. Usually PML is a AIDS defining disease. AIDS defining disease will be occurring when the CD4 count is less than 100, but in this case, both cases, the CD4 count was more than 500 or 400. How can we explain this? And this is one thing. Sometimes AIDS defining disease, the immune fall is not comparatively bad.
As the previous moderator, Dr. Rajiv Singh has told, there is no relation between CD4 count and HPV virus. Same thing with JC virus also. JC virus can make its presence even when the CD4 count is less than 300.
JC virus.
Yes. So even more than 300 also it can make an appearance.
Thank you, sir. Thank you.
And this patient is a rapid progressor.
Yes, sir.
So that may be leads to this opportunistic infection succumbing.
Usually, rapid progressor is less than 3 years, but rapid progressor usually we used to denote the HIV patient rather than, that is AIDS patient rather than the acute infection. But this is also, we cannot rule out that possibility of.
Because there is a progressive multifocal leukoencephalopathy is there, which is the AIDS defining disease and OI disease.
Yes,
so
correct,
we can't rule out this.
Yes, sir. A 28-year-old man referred to me with for HIV positive with extreme cachexia, oral thrush, thin built, difficulty in moving about. He is an engineering graduate. His parents were no more, and they died 10 years back. Could it be MTCT, mothers to child transmission? We don't know exactly. Patient was directed to have HIV infection in 2008 itself. And at that time he was put on cotrimoxazole prophylaxis and multivitamin. ART was started in the 2018, but unfortunately this patient has never taken even a single pill. The patient, he used to get regularly, go to the ART center, but he never took ART at all. As an attitude of denial, I am not having this disease. And the drugs are dangerous to health. Any drugs, I will be managed without drugs. So like that. So this is the thing. Before he got admitted into the hospital with severe symptoms, he had broken all his tablets into off and started tablet off daily, assuming this off tablets is enough for him. So these are the things. And his CD4 count at that time was 30 cells per cubic millimeter, and viral load was 6 lakhs copies. And extensive oral thirst was present, thin built, loose motions also on and off there, and history of fever is there. In utero transmission of the HIV can be detected even after 28 years. That's a possibility. There is a possibility. Most often these MTCT patients thrive well, long-term non-progressor. Disbelief and denial status lead to refusal of the treatment in this case. Modification of treatment on their own, believing that drugs are toxic. What should have been done to this patient? Means of improving drug adherence. Long-term non-progressors are common with MTCT patient. Panelists, please. Reddy Garu.
See, counseling is very important in this patient.
Yes, sir. Correct.
This is a case of actually MTCT.
So, yes,
mother
sir.
to child transmission. Mother should have been given antiretroviral therapy. That would have prevented him, because the chance of transmission are 40% without any intervention.
That we don't know. Yes, sir. That's correct.
See, big range is there, 20 to 40%.
Okay, sir.
Suppose if you give ART, monotherapy also reduces the chance of transmission to the tune of less than 15%. Suppose if you give 3 drugs, ART 3 drugs, the chance of transmission are reduced to 2%. If you combine ART in the mother and with abdominal delivery, the cesarean section, that it should be less, very less, actually less
Yes.
than 1% we can say.
Correct, sir. Thank you. But one more thing is, every patient before starting ART should be counseled, or Dr. Reddy told, counseled. What are the importance of this? What is disease is going to do? What is the drug is going to do? What is the importance of adherence? What is resistance? If failed, what happened? All these things patient has to be explained. One thing. Another thing, it is not doctor's decision. The patient should be ready. We have to prepare the patient, should be ready to receive the drug. So at that stage only we have to start, and we have to prepare the patient. That is also doctor's duty. That is very important.
I too accept counseling is the main part. That's why counsel part is very much required.
Yes, sir.
Same time you have to spend much time. Whether he is really taking or not also, we have to follow it through regularly. That is important.
And this is a bad case of adherence. There is no proper adherence to this case. First of all, that should be improved. And otherwise, from 2008, he stopped the medicine and he took only half the tablet. And it is a classical example of bad adherence.
So because of improper counseling and not adequate counseling, that is very important.
So
Challenges for adherence, drug adherence, that is very important. Everybody should know that intolerance, adverse drug reaction, hypersensitivity reaction, fear of discrimination, denial, I am not having this, I don't have, how can it be? Like that, false feeling of well-being, I am alright. Their doctor is bluffing, the tests are not good. Like that, economy, I am not able to afford, or I am not able to travel to AIT center. Lack of family support, most of the family is not supporting, and drug abuse. The drug abuse people cannot be adhered to the drugs at all, and mentally retarded and mental disorders, laziness, disability to go, to take, and forgetfulness, frequent travelers. So when we are concentrating in the adherence, we have to keep all these things in mind, and accordingly we have to counsel. Our next case is 47-year-old Mr. A recently started ART in the government ART center with the complaints of intermittent fever, severe vomiting, dehydration, weight loss. Vomiting was present since 3 days. He was thin built, found in with a mild oral thrush, and CT thorax and abdomen revealed pulmonary tuberculosis and extrapulmonary tuberculosis. ART was started with tenofovir, lamivudine, dolutegravir. Along with the dolutegravir is a fixed dose combination along with the 50 milligram another OD. So usually when we are starting the ATT, dolutegravir dose should be doubled. So because of that they are given. So it may sometimes induce vomiting. So, and his wife who was free from HIV, children also free from HIV, and denies extramarital or premarital heterosexual relationship, but he was having homosexual men sex with his male. His relationship was there. 15 years back he was promiscuous, and CD4 count was just 37 cells, and ratio was 7.4%. He was on started on ATT, was given TTG 50 milligram twice daily. In this case, sometimes efavirenz, if they have fixed dose reduction, it would have not been occurred because the pill burden is increasing. This is one thing. This patient knew his HIV status since 12 years, but not revealed to his family or anybody. He got married and had children. Fortunately, they were not reactive. And he was also working in an NGO connected with the HIV patients. In spite of knowing all these things, he was not taking he was not revealed this, and he was not come forward to take the treatment. When he felt sick severely, he started treatment. What could be the reason for he hiding his HIV status for years, in spite of knowing better about HIV, in spite of he is working with the HIV patients? What should have been taken up for him?
It's naturally stigma associated with the infection.
Discrimination, stigma. So because of being discriminated, very important role.
He is worrying more about the society rather than himself.
Yes.
That is the main thing. That is why
What others will think of us, think of me like that.
He might be secluded, it may be separated from his family, or he cannot go and earn his livelihood. So many ifs and buts. He has so many questions but no answers.
Exactly.
So as a result of which he is succumbing to such diseases, and most of the people in India is like that.
Yes,
because
sir.
of the bad adherence, one thing, and bad and mal beliefs are making them more non-scientific and non-approachable to the disease.
Thank you, sir.
Even being educated, because of the stigma, what we learn is every patient counseling is a must. Without counseling, we should not start the treatment. That is the basic.
Two things. One is social life. Second is the economics. These are the two things while most of the people making mistakes.
Yes, sir. We'll hurry. And a HIV positive individual with diabetes mellitus was on ART and for more than 10 years was doing well. Due to corona time, he was a false feeling of security. He was being cured. He stopped taking treatment and he developed pulmonary tuberculosis, and ATT and tablet fluconazole along with the antibiotics started. Fever subsided. Ankylostomatitis, dysphagia were better. CD4 count at the time when he report to after the corona period, 34 cells, CD4% is 7.4, viral load undetectable, and patient is reactive HIV 1 only. The test report shows obvious immunological failure but viral load not revealing failure. How can we explain this discrepancy? What are the reasons for dropping out from the treatment in this case? Such cases are reported during COVID times. Dr. Rameshar.
This viral and immunological discordance has a few of the known reasons. Because these CD4 cells, they arise mostly from the tissue lymph nodes or through thymic activity, thymic gland and bone marrow. So before starting the antiretroviral therapy itself, the virus itself by its toxicity can produce damage to thymus gland and the tissue, and delay in the starting of antiretroviral therapy can also lead to sustained inflammation in the body, immune activation and inflammation. That leads to tissue fibrosis in the lymph glands. So the sources of CD4 T cells from the bone marrow and the thymus gland as well as the lymph nodes, everything is reduced. So CD4 count falls down in spite of the cells. Viral copies may be significantly low. That is, virological improvement is there, but immunological improvement is not there. So this could be the reason, apart from the toxicity of ART drugs as well as the co-timoxol prophylactic therapy that we start for pneumonia and other opportunistic infections. So drug therapy, drug toxicity as well as the toxicity of the virus, HIV virus itself could be the reason for this immunological failure.
Thank you, sir. Incompetent immunological systems. Immunology, that is when we start late the ART drugs, already the immune system would have been spoiled, and that is also some reason the immune recovery is not as expected. So that is a very important thing. We have to start as early as possible. This is one thing. And one more thing, when we are seeing a HIV undetectable viral load with a low CD4 count, we have to rule out HIV-2. So sometimes HIV-2 cannot be, viral load cannot be detected undetectable count. So but this case HIV-1 only reactive.
And also co-infections with hepatitis C, hepatitis B, and some associated sarcoidosis, some other immunological disorders might also be there. That also we should look for.
Thank you, sir. Pulmonary tuberculosis co-infection. When to start ART? What to start?
In many cases of HIV infection, so co-infection with pulmonary tuberculosis is common. So here,
sir.
So when pulmonary infection is present in HIV positive individuals, you should start treatment, but mostly the anti-tuberculosis therapy, ATT, should be started. So after starting ATT, after 3 weeks therapy with ATT, you can start ARV also in those cases.
I would like to add something. If the CD4 count is more than 250, then we can straight away start both the ATT with antiviral drugs. If the CD4 count is very low, then better start the ATT first. After the 2 months or so, then we can start the both the ARV, antiretroviral therapy, and ATT both can be started later on.
Actually, this was old concept, sir. Now recently, previously, we have to wait for 2 to 4 weeks till the patient gets stabilized. But now they are telling within 2 or 3 days, within a week's time of ATT, we can start, we have to start. So that is the recent recommendation by CDC and WHO. So that is one thing.
And the first you have to start with ATT,
yes,
and there will be a defervescence occurs, and within 7 days or 2 weeks, at the most 2 weeks, immediately you have to start ART. Otherwise, there is a possibility of, because of the virus, there may be a drug resistant tuberculosis organisms may evolve. That is the thing, and will produce so many problems. And that drug resistant organism will produce and the virus influence the HIV virus, and it will become resistant. So there will be a give and take policy of by both one bacteria and the virus. That is why one should take the ATT immediately without doubt, and at the same time 7 days or 10 days immediately you have to start ART.
Correct, sir. Thank you. and what ART has to be started, what ART has to be avoided. That is also in especially pulmonary tuberculosis co-infection, TB co-infection.
And there is one thing we have to see, not only pulmonary tuberculosis, there may be extra pulmonary tuberculosis, one must be very careful. There is one thing which causes more serious than the pulmonary tuberculosis. That is my experience. So we should look into that also. And the ART, what we have to start is tenofovir plus 3TC and efavirenz should be started. And 3TC should be there because there may be an associated other viral diseases, other bloodborne viral diseases are there. So whatever the regimen you use, you have to add the lamivudine should be there, 3TC.
Yes, sir. Thank you. Thank you. And PI drugs and also nevirapine has to be avoided in the presence of TB because rifampicin is not acting well with. Or otherwise we have to go for some instead of rifampicin we have to go for butane. That's also there. As hepatitis B virus, the ART will be has to contain that is lamivudine.
It is better to avoid rifampicin because rifampicin causes some other enzymatic reactions and they will reduce the vitality of the ART and other things. That is why instead of rifampicin you can use rifamycin or rifabutin, other drugs will be used. And single drugs should be used when compared to the AIC-84 like that. We should not use a packaged drug. We have to use a separate drugs with rifabutin. Individual drugs should be the rifabutin and pyrazinamide. Pyrazinamide must be there, otherwise it will lead to the progressors will be there. So we have to use include the pyrazinamide also.
Here we are using many drugs, polypharmacy. So you need to take the patient into confidence, give him counseling. There is a possibility of drug interaction. Also to the caregiver, family members and all. Because under these situations we see patients, if they get side effects and all, they will stop treatment for months together, years together, they become defaulters. So unless this situationally, we should tell them what is to be anticipated and they have to come back to the therapist. It's very important.
So the seroconcordant couples, that is HIV people wants to have child, whether they can have with the seroconcordant couples, with the serodiscordant couple, what can we do?
Time out. Please finish only.
Oh.
We're nearing time.
We have to stop it.
Oh, no, that is
Which you want which answer? Serocordants or discordants?
Serodiscordant, how can we manage? Seroconcordant, how can we manage?
So concordants, actually we give drugs for both the husband and wife.
Yes.
They should be treated simultaneously, and even before they conceive also it's better to start. That is counseling again very important. Before conception the drug should be ART should be started. Even in discordants also the positive person should be given.
There are two discordants. One is wife is positive or husband is positive.
So when they are both undetectable viral load, they are no longer infective. Nowadays they are having successfully got pregnant, or otherwise
Yes.
the viral load is up, we have to go for in vitro fertilization. Discordant couple, according to the wife or the husband, we have to modify.
Even we have sperm washing
There is
techniques
sperm
also.
washing things.
Sperm washing.
That should be a treatment of choice.
Suppose wife alone positive, husband negative, insemination also can be possible. That's
Yes.
also possible.
Artificial insemination.
Yes. And only dolutegravir, what is the common drug, first line drug, what is the disadvantages? Dolutegravir side effects.
Only the side effects are only common side effects only, like liver toxicity and renal toxicity. These are the adverse drug like allergic reactions. They are common with dolutegravir. And TDF also there is Fanconi syndrome was mentioned, that is renal toxicity, renal tubular
Yes, tenofovir renal toxicity and bone marrow toxicity.
Yeah.
Dolutegravir weight gaining,
Weight
very
gaining
annoying.
in some people.
Another thing is in pregnant women, the neural tube toxicity can occur.
Yes.
Last slide, 1 minute. So HIV2, how can we diagnose?
HIV-2 nowadays, I have not seen any case of HIV-2, but in the diagnosis of HIV-2, routinely it was diagnosed by serological test in the ICTC centers, but it should be confirmed by higher centers.
Tridot is okay.
Mostly the cases are non-progressive.
ICTC, they are doing 3 tests, so we can rely.
Mostly the symptoms are less asymptomatic,
yes,
and they are less progressive, and CG4 count is not declined generally. That
there are special test, antigen test available on request.
Yes.
That's also possible. One more thing, certain antiretroviral drugs are contraindicated for HIV-2. Anybody?
Yes. NNRT.
NNRT are contraindicated.
Excellent, excellent. NNRT and atazanavir are also not good. And yes.
And early use of the PIs are should be there advised in this case of an HIV-2.
Yes, that's good. Thank you, sir. With this, I will close the our discussion. Thank you very much for my panelists for their excellent answers and cooperation. Thank you very much.
Thank you, IADVL Telangana, for giving this opportunity and making successful interaction.
Thank you, Murugan garu.
Already we have met in Tirupati and so many places.
Yeah. Because when we were in the as a professor or assistant professor,
Thank you, sir.
there was no AIDS cases.
Thank you, sir. Thank you, sir. So the next session will be diagnostic markers of CTDS and vasculitis. So the chairperson, sir.
We did not see it. Now that we are seeing
Dr. A.
it.
Durga Prasad, sir. He is a famous dermatologist, cosmetologist of Twin Cities, and Dr. V. Ramesh, sir is a railway doctor. He is also famous. Sir, please come to the dais.
Sitaram. No, Dr. Samani.
Sorry, Dr. V. Ramesh, sir, from dermatologist, cosmetologist, sir. Sorry, sir. Sorry, is from Warangal. Sir, please start the session, sir.
Good morning, delegates. Along with Dr. Ramesh and myself, thank the TS IADVL and CUTICON 21 Telangana for giving us the opportunity. So, this session, connective tissue diseases, there is a talk by Dr. V.K. Somani and followed by panel discussion. May I request Dr. V.K. Somani to come to the dais, please, to deliver his talk. Dr. V.K. Somani needs no introduction. You all know very well. He is a famous dermatologist of Hyderabad. Dr. V.K. Somani is a director of Dermatrends, and for his credit, he has 30 publications and more than 100 presentations he has done. He has many awards, honors and achievements like Vishnu Priya Devi Award, Best Citizen of India Award, and Economic Times has given as to him as Inspiring Dermatologist of India, and he has scientific chairperson. He was scientific chairperson for scientific chairperson for Dermacon 2024, and he was past president IADVL in 2008, and he was formerly professor and HOD of Department of DVL. And his areas of interest is pigmented disorders, acne, psoriasis and phototherapy. And now I request him to give a talk on CTCs and vasculitis.
Well, good morning everybody. Thank you chairpersons for the introduction. The topic given today is a rather very large topic. Before I embark on the journey of connectivity disorders and vasculitis, I must congratulate Dr. Bhumesh and the IADVL team for arranging this excellent conference. Now coming back to the topic, the connective tissue diseases and vasculitis is a very, very large topic. I don't know whether I'll be able to cover that in the next 20 minutes or so. But I'll try to briefly touch upon all the important aspects of these two conditions because they are very, very extensive and very confusing. Now, diagnostic markers, as I told you, we'll be first discussing about the connective tissue diseases and then the vasculitis. So, it's okay. No, it's okay, no problem. Is it okay? Audible? Am I audible? Yeah. Now the group of CTDs is a very, very complicated or complex group where we have got different conditions having almost same clinical features. So it's very difficult to diagnose the CTDs clinically, but we usually have a fair idea because we deal with them in our daily practice. We have to always rely upon the clinical examination, and then we also need to look into the laboratory evidence to corroborate our diagnosis. You can note here the central portion which is showing U1 RNP. This is shows the classic overlap, and that is what is most important finding for the MCTD, the mixed connective tissue diseases. Let us start with systemic lupus erythematosus. Anti-nuclear antibodies is the main investigation because autoantibodies are the major features of all the connective diseases. So autoantibodies, general working knowledge is what is required to deal with these conditions. Anti-nuclear antibodies are present in almost all the cases of SLE, about 98 to 99% sensitivity, but only about 75% specific for SLE, because it will be positive in other conditions also like dermatomyositis or scleroderma. It could be positive in family relatives of LE patients. It could be positive in hepatic disease, in malignancy, and even in normal population, about 15% normal population also exhibit the anti-nuclear antibodies. So it is less specific, but it is very, very sensitive for SLE. We have recently been presented with this criteria for SLE. Earlier we used to follow the 11 criteria of ACR, but now we have this new system of classification which is much more sensitive and much more specific. We have got the first basic most important thing would be to have ANA positivity. We should be more than 1 in 80, 1 in 60, 1 in 160, even better than that. So first condition is that ANA titer should be 1 in 80 or above, and then if it is positive, then we are being given another 22 additional factors which we have to check, and then we have to come to a conclusion whether it's a case of SLE or not. There are 7 clinical domains and 3 immunological domains. The 7 clinical domains are constitutional domain, hematological domain, neurological, musculoskeletal, mucocutaneous, serosal, renal, etc. And then the immunological domains, we have got antiphospholipid antibodies, and we have got complement proteins and the SLE specific antibodies. All these are assigned some points, and looking at those points, we can come to conclusion about the diagnosis according to this criteria. Now these are the domains, and you can see the scores given on the right side, and we must have at least ANA, 1 clinical criterion, and 10 points from the scorecard mentioned over here. But that would make your diagnosis of SLE certain diagnosis according to the latest criteria. If we have, suppose the patient is suffering from, say, oral ulcers, alopecia, and also a malar rash, we cannot count that 2 plus 2 plus 6. We have to count that as only 6 because the highest score is malar rash. So we have to take only the malar rash as the scoring point. The other two we should disregard. So only one score from each category, and that's how this is very, very specific for the diagnosis of SLE. Then we have got other tests to diagnose SLE. We have got skin biopsy, which is very important, and we can see the typical changes in different stages of SLE, whether it's acute, subacute, or the chronic discoid variety. Lupus band test is another very important test, which also can give us a clue about the diagnosis, and it is positive in 80% of sun-exposed non-involved skin when compared to 55% of sun-protected non-involved skin. Systemic sclerosis, another condition which is very chronic and with variety of clinical features. We have two types, limited one and the diffuse one. Limited systemic sclerosis also was earlier known as CREST syndrome for calcinosis, Raynaud's phenomenon, and esophageal dysfunction, and the sclerodactyly telangiectasia. We also have now a classification for systemic sclerosis, and we have to have 9 points from all these different categories to diagnose or confirm the diagnosis of systemic sclerosis. And out of these, the first point, the most important, is the skin thickening of the fingers of both the hands. The finger should be involved right from the tip to the metacarpophalangeal joint. Just one single character will be enough to diagnose the case of systemic sclerosis, because that is given 9 points. And we can have a combination of various other factors to arrive at the diagnosis. So total score of 9 is essential to diagnose systemic sclerosis. Looking at the lab diagnosis, we have got to look at the serum creatinine levels and thrombocytopenia, which are very important markers for the scleroderma renal crisis. So we should always check for these, because that is how we can catch whether a renal crisis is developing or not. Then creatinine kinase, aldolase, lactic dehydrogenase, all these enzymes will be of help when to know whether there is any myological involvement, whether there is any myalgias, or whether myological involvement, muscle involvement. CXCL4 is another recent finding, which is a cytokine, and that is elevated in majority of the patients of systemic sclerosis, and it is also a marker and also a prognostic indicator for pulmonary fibrosis and pulmonary hypertension. Another indicator for early pulmonary hypertension is the N-terminal of pro-brain natriuretic peptide, which is also seen in cardiac failure cases, but high levels of pro-BNP are associated with early pulmonary hypertension. Then normally ESR and CRP is normal in cases of systemic sclerosis, but elevated ESR, elevated CRP are associated with poor outcome. Anemia because of chronic blood loss also can be seen in systemic sclerosis. Then we have got various imaging studies which can help us in finding out the organ damage or organ involvement in systemic sclerosis. We have got chest radiographs which can show the features of basal pulmonary fibrosis, or high resolution HRCT, which will show us whether there are any interstitial lung disease, and then upper GI tract evaluation to know whether there is any gastric motility changes, or whether there is any reflux esophagitis or reflux. And we also should look for diastolic dysfunction, which is very common in cardiac abnormalities. Pulmonary function tests are also very important because they are involved quite frequently in systemic sclerosis. Then we have got nail fold video capilloscopy, which is very cumbersome and a difficult procedure. Not all departments will have that, but that will give us a definite clue about the diagnosis of this particular condition. Histologic findings, as usual, as again are very important. We have got different features in different stages. Later on, we have only sclerotic changes which predominate in cases of confirmed or established cases of systemic sclerosis. The next condition is dermatomyositis, which has got again a plethora of clinical features. We have got the heliotrope eyelid rash, we have got the nasal rash, malar rash. This rash is different from the SLE rash because it will involve the nasolabial folds. Unlike in SLE, it doesn't involve the nasolabial folds. Then we've got lots of signs: Gottron's papules, Gottrell signs, V sign, Scholl sign, Holster sign, so many signs in dermatomyositis. And of course, there is involvement of the muscles also. Muscle enzyme levels are very important to diagnose. We have got all these muscle enzymes which are mentioned here, which can give us a clue about the activity of the disease, and also it will give us a clue about the diagnosis. Then autoantibodies, anti-MI2 antibodies are seen in about 25% of cases. It is seen mostly in dermatomyositis. And anti-Jo1 is usually seen in myositis predominant cases. And this anti-P155 or anti-140, also known as TIF antibodies, are associated with malignancy more often. And of course, ANA positivity is also quite frequently seen. Pulmonary function studies, again important with diffusion capacity estimation, ECG, esophageal manometry, and all investigations to rule out any malignancy, which is very frequently associated in dermatomyositis. About 40% of cases have malignancy, so we need to rule out malignancy because that's a real risk in dermatomyositis. So in that connection, we got so many imaging studies to help us in our diagnosis. We can go for MRI or USG of the muscles, and chest radiograph, barium swallow, EMG, and imaging to rule out malignancy, whether it is the chest or abdomen or pelvis. We just need to try and find out whether there is any malignancy which is lurking. Some procedures which could help us in the diagnosis of dermatomyositis are the skin biopsy and of course muscle biopsy, which gives us a very clear-cut and solid indication, solid confirmation about the disease. Then lastly, I will talk about the MCTD, which is again a combination of the different conditions what we have just mentioned till now. It is a combination of systemic lupus erythematosus, systemic sclerosis, and dermatomyositis. And the most important feature is the U1-RNP, which is seen in 100% of the cases of MCTD. So without that, there is no diagnosis of MCTD. So the patient must have these are the 4 categories recently given by a group in Japan. The common manifestation should be there: Raynaud's phenomenon, puffy fingers, and or swollen hands. Then U1-RNP positivity. Then there should be one characteristic organ involvement, whether it is lungs or CNS or other organs. And there also must be overlapping manifestations of the 3 constituent connective tissue diseases. So a combination would be, the criteria says that we should have one common manifestation, one U1-RNP positivity, one characteristic organ involvement, or 2 features, one each from the 3 conditions. That is, one feature from SLE or one feature from systemic sclerosis or one from dermatomyositis to confirm the diagnosis of MCTD. So one common manifestation, U1-RNP, and 2 features, one each from the constituent conditions. To summarize, the autoantibodies, SLE, we all know that they are very specific antibodies. We have got double-stranded DNA. We have got SM antigens extremely specific for SLE. Then phospholipid antibodies also seen in about 20% cases. Are 20 minutes over? Okay, then I'll try to rush through vasculitis. So we have got drug-induced lupus, which is characterized by antihistone antibodies, dermatomyositis by Jo1 and Jo2. SCLE, of course, is anti-low, so as the case with neonatal lupus erythematosus. And we have got systemic sclerosis, which is topoisomerase 1 for the diffuse variety and the anticentromere 1 for the localized variety. MCTD, as I just mentioned, is U1-RNP. So these are basically the autoantibodies which are very specific and very frequently seen in all these conditions. Vasculitis, even more complex than CTDs. I'll be briefly going through this. I think we have a panel discussion. Dr. Sitaram will look after the gaps what I'm going to leave in the panel discussion. And just this one picture I think is enough for us to, can I have one more minute? You can take 5 minutes because you started 5 minutes late. Okay. Yeah, I'll just try to skim through this. So you can just take a look at this picture. and you can see that there is large vessel vasculitis, medium sized, and there is medium and small and small. These are the four categories. If it is a large vessel vasculitis, you have aorta and the named arteries involved. If it is the medium sized vasculitis, it is usually the smaller arteries involved. Medium and small is a combination of the two, and the small vessel vasculitis, what we commonly see is in skin, is the post-capillary venules or the capillaries which are involved. Depending on the vessel size, we have got the symptoms or clinical features which differ, and also the classification also is based on this. We have got Takayasus, and we have got the temporal arteritis in the large vessel. We have got polyarteritis nodosa and Kawasaki's disease for the medium sized, and we have got the ANCA associated vasculitis, that is GPA, microscopic polyangiitis, and EGPA in ANCA associated. And what we see is the chronic superficial, cutaneous superficial vasculitis, the Henoch-Schönlein, erythema elevatum, and articular vasculitis as the cutaneous vasculitis. It is also known as cutaneous vasculitis, is also known as leukocytoclastic vasculitis, and triggering event we should have at least 7 to 10 days after the triggering event to see the rash. Rash is basically palpable, purpura, or it could be even targetoid lesions or articulated papules, and all kinds of lesions can be seen, and they are mainly on the dependent sites, and they are basically asymptomatic, but sometimes there may be symptoms. And the symptoms what we commonly see is arthralgia in most of the cases, sometimes genitourinary and gastrointestinal. Laboratory studies are required for all these reasons, and these are the general laboratory tests what we commonly should do to look for any inflammatory changes, and we also can take recourse to organ specific tests to find out which organ is involved. And biopsy, of course, would be very informative, especially in Henoch-Schönlein purpura or in cases of polyarteritis nodosa and ANCA associated vasculitis. Autoantibody test, ANCA, P-ANCA and C-ANCA, they are very common in all the three varieties, and the most important is the vaginous granulomatosis or granulomatosis with polyangiitis, where we see about 90% positivity with C-ANCA, and out of them 80% will be cytoplasmic. We need to go for infections workup because infections are a group of conditions which may mimic just vasculitis, and if we treat vasculitis without looking for infection, then we might end up with a lot of steroids and a lot of side effects for the patient. We rule out infection first, rule out infectious diseases, and then manage vasculitis as it is to be managed. Vascular imaging, gold standard for diagnosing vasculitis. Finally, the connective diseases represent polygenic clinical disorders that have overlapping clinical features. There is no substitute for a detailed clinical examination to arrive at a diagnosis. The most commonly requested test would be ANA, if you want to make a diagnosis of CTD. Diagnostic classification criteria have been established for many CTDs now, so the diagnosing and classifying is much more easier and precise now. And ANCA targets cytoplasmic structures also and assesses the diagnosis of cutaneous vasculitis. So working knowledge of the autoantibodies, of the diversity of clinical features, of the several organ systems which can be involved is critical to proper diagnosis and management of CTDs and vasculitides. Thank you very much for your time and patience.
Thank you, Dr. V.K. Somani, for your talk on connective tissue disorders and vasculitis. We all know it's a very tough subject, and you have highlighted very precisely very important points, and you have given very good thing for carry home messages in vasculitis. I request you to be on the dais and occupy the chair for next session. We have next session we have panel discussion on vasculitis, and now I request Dr. K. Sitaram to conduct the next session on vasculitis, management of vasculitis. And I also request him to call the panelists onto the dais.
Good morning. In the first instance, let me thank the organizers of the Telangana IADVL, Dr. D.B.N. Murthy, Dr. Bhumesh, and the scientific chair, Dr. Narsimha Rao Neta. And I'm extremely happy to be here with you all once again after lockdown, as physically in the CUTICON, Telangana. Dr. Somani has given a overview of the diagnostic things about the vasculitis and CTD. So now we will discuss some of the management issues what we face in treating the CTD and the vasculitis. Before that, I thank our chairpersons, Dr. Durga and Dr. Ramesh, so for being with us. Thank you very much for that.
Thank you.
Okay. Now we have our extreme panelists, expert faculty. Dr. Somani, you have already heard. Dr. D.V.S. Pratap, please join us. Dr. G. Manmohan, sir. Dr. C. Sudharani. Dr. A.S. Kumar was supposed to be with us, but he has some family functions today, so he could not join us. Dr. Somani, we have already heard him. He's the, a recipient of the prestigious IADVL award, the Vishnupriya Devi Award. I think it was from the PDLs. Dr. Somani, if I remember correctly, pigmented demarcation lines. Yes. So that was a prestigious award which he got from the IADVL. Dr. D.V.S. Pratap is currently the professor and HOD at the PIMS Karimnagar, and he was former president of the IADVL combined AP. He has done the secretary twice and number of publications and innumerable presentations. Dr. Manmohan, currently the professor and HOD at the Bhaskar Medical College, and 8 years of postgraduate teaching, former professor at Usmania, and he is PG examiner from medical universities, and he was the president of Telangana, and he was the treasurer for the Dhammakan 2006. I think from that only we both Telangana and AP are enjoying the funds which they have saved and contributed to us. So thank you, Manmohan, and for Dr. Gauri Madam also. So he has done excellently well, not only the conference, but financially also. So that was the, I think the first ever Dhammakan which saved more than 2 crores to IADVL. Dr. Sudharani is a professor at Gandhi Medical College and 23 years of PG teaching, and she has delivered many guest lectures and a lot of research experience. So we have an expert faculty here. So, we all see these cases routinely in our OPD. Purpura, a palpable purpura, sometimes with the ulcers. Right. So, when do we suspect vasculitis clinically? And then, if we see vasculitis, is it necessary to label it as a small cell, or a medium cell, or a large cell? And how do we differentiate it? So, I would like to hear from the extreme panelist. Dr. Somani, you have started our vasculitis, so can you just enlighten us?
Will you please repeat the question? The vasculitis, am I audible?
Yeah, please,
yeah,
go ahead.
So, vasculitis, as I was telling earlier also, it depends on the caliber of the vessel involved. If it is the small vessel vasculitis, we normally see only skin changes, and that also will be visible in the form of palpable purpura or urticarial papules, vesicles or targetoid lesions. And the constitutional symptoms will be rarely seen, not very often. But if we go on to medium-sized vessel vasculitis, then we have to look for involvement of the other parts of the body, like the nasal sinuses or the lungs or the kidneys, and we need to look into the systemic features of the condition. If you're looking at the large vessel vasculitis, we need to look at the pulses, whether they're present or not, whether there is a lot of changes or fluctuation in the BP, or whether there is any claudication patterns. And in addition to that, the clinical features, like we have got nodular lesions or we have got ulcerative lesions in cases of the bigger vessels, but smaller vessels we normally don't see nodules and ulcers, but in larger vessels we can see ulceration, necrosis and nodular pattern. So basically, clinically we need to decide, I mean, how are we going to proceed and when to suspect. But basically, the skin will show features of purpura, either elevated or macular, and other changes, either it's a retiform purpura or it's a livedo racemosa or other changes, what we can conclude from those lesions.
Hello?
Yes.
Okay. Okay. Even though there is an overlap, so the palpable purpura, the petechiae, the hemorrhagic bullae usually indicates a small cell, and then the nodules, the livedo usually indicates a medium vessel vasculitis. At times there is a overlap. But why is it important, Dr. Manmohan sir? Why should we differentiate it? A small cell or a large vessel, medium vessel?
Basically, you have to we have to decide for the etiology. So there are two classifications. As now it is going on a small vessel, mid-sized vessel, and then large vessel vasculitis. Previously we used to classify as infiltration, lymphocytic, neutrophilic, mixed, combined, kind of. So
Okay,
that will
fine.
tell us.
I just want to know, how is it clinically important for us? What happens? Is it small vessel or medium vessel? How does it matter?
The treatment differs and the systemic problems will be more in
So
the
that's the point. See, as the medium vessels are involved, the systemic organ involvement will be much more, and we may have to deal with a very aggressive treatment. Whereas in a small cell, maybe we don't require that much aggressive treatment. So there is a reason why we have to definitely, both clinically and the laboratory and the biopsy wise, we should know whether it is a small vessel or a medium vessel. Right. So, of course, this already Dr. Somani has shown us.
Said one thing.
Yeah,
Shall
please.
I share one thing, sir? Before sir mentioned all the details, but still small vessel vasculitis we have to take sometimes serious, sir. When Pratap sir was the HOD and Submani sir, we have that national conference. That time we had one systemic vasculitis case in Gandhi admitted, only with cutaneous lesions. And when Geeta madam was the HOD, we had one more case, sir. Clinically, they present with purpuric lesions and hemorrhagic bullae. You mentioned that one. That is the most significant. Regularly, we get only ecchymosis, petechiae, papules, papules and papular lesions, macules. But hemorrhagic bullae associated with intense edema of the lower limbs, and that is sometimes indicates systemic involvement, especially systemic vasculitis, because we are not aware of the internal problems. That patient we lost, sir, actually. She complained headache for 3 days. We couldn't diagnose actually. She presented with only bilaterally symmetrical hemorrhagic bullae with intense edema. Subsequently, when CT was done, there was intersusception, cerebellar coning. Within 3 days, we lost that patient. So even small vessel vasculitis can suspect sometimes the systemic lesion, systemic vasculitis based
Agreed.
on the
That's what
morphology of
exactly
the
I said, ma'am.
Yeah.
It's not a mandatory thing to, these are the things that will give us a clue either it is a small vessel or a medium vessel, and many surprises may be there in the biopsy once you do that. So that's why the important is the biopsy is very, very important whenever you do suspect a vasculitis. Right. So now I request, yeah, please.
Yeah, one thing, sir, about as she said, most of the times we get lesions, small vessels only in our practice. But to share my one case in the beginning of my practice, she got purpura on the legs, and then I gave some regular steroids in a lower dose. Ultimately, the patient landed up with CRF and kidney transplantation. So that is one point. Second, my own classmate, she developed palpable purpura and she died of DIC. So I think we get only these palpable purpuras, so we should be a little cautious in evaluating, and we cannot take it, and we don't see pain abdomen and all that will not come to us. They may go to surgeon and all with intestinal ischemia and all that. So that should be always, our side is only vasculitis, so we always look for systemic also.
Yes, agreed. Well taken point. Yeah, Dr. Pratap, I would just like to know how important is the biopsy. That is already we discussed. It is important. You should know whether small vessel or medium vessel. What are the precautions, and where do you take a biopsy, and when do you take a biopsy?
Actually, if we search literature and then this thing, the biopsy is not needed because clinical picture definitely decides.
First point. Second point, the biopsy, we should take early lesion and then only we'll see the typical histopathological changes. We rarely, how many, as of now, I never referred or taken biopsy from vasculitis. Clinical, then very rare cases and any doubt, then you have to cut it out.
Anybody else would like to comment on that?
I think I differ from Dr. Pratap. Biopsy is a must to make a diagnosis, what kind of it is. If you don't do biopsy, DIF, how do you know it is Chanoxion or something else? Because their IgA, we can give Dapsone and treat it. Why to give unnecessary steroids?
I agree with Manmohan sir, and yes, biopsy is definitely a must. Yes, Somani, please.
Yeah, like Dr. Manmohan mentioned, the purpura can be a feature of from the smallest vessel to the largest vessel. You can see purpura or purpuric dermatitis, purpura-like lesions in all across the spectrum of vasculitis. So purpura itself is not a point or a feature which suggests that it is small vessel vasculitis.
Exactly.
Purpura can be seen anywhere. So purpura, you are looking at it, but you must also investigate or ask about the history and find out if there is any organ involvement. And for that reason, if you go for a biopsy, it will give us a clue whether it's just a small vessel or a small with medium or a medium vessel vasculitis. That will give us a proper clue as to investigate further and find out the organ damage, organ involvement.
Correct. So that's the reason why exactly we need to take a biopsy. So never underestimate the biopsy in the vasculitis. As we already, Dr. Sudha has pointed out that the small vessel vasculitis, which looks like clinically, may turn out to be a medium vessel vasculitis, and where you require, as we said, a highly aggressive treatment. Yes, we do need a biopsy. So only thing is, whenever we do a biopsy, always do in very, very early lesion. That's very important. Always a small vessel, you need a punch. And a medium vessel, if you are suspecting, always do a wedge biopsy. Don't go for a punch biopsy. And the suitable site is purpura, anywhere in the lesion you can take. Whereas in the libido, racemiosa, take always from the pale center. Ulcer, take from the edge, which can show the inflammatory infiltrates. So that is the most important thing when you take a biopsy. All right. Someone has already mentioned about the ANCA just. So clinically, can we suspect ANCA-associated vasculitis? Or when do you do an ANCA test in a suspected vasculitis? Dr. Soman, would like to say something on that?
Sure. Like we know the three major conditions in ANCA, the GPA, the MP and the eGPA. We know the involvement pattern of all those conditions. So we need to suspect ANCA when we have skin lesions with purpura or purpuriform lesions, also some amount of necrosis or nodular lesions, what we can see. Nodular lesions or bigger lesions would give us a clue that we are dealing with medium-sized vessels maybe. And then if we have involvement of lungs or kidneys, that will be a very big clue to look for ANCA, because the sinus, the lungs and the kidneys are very frequently involved in ANCA-associated vasculitis. So I think I would proceed.
I think yes, that's the primarily when you are looking for the lung involvement and the peripheral nerve involvement. Always. So nowadays anyway, as a screening, we are all doing that, but especially when the lung is involved and the peripheral nerve involvement, we should do the ANCA
Dr.
testing. Yes,
I would like to put it the other way. When, this thing is there, so ANCA first we will perform, ANCA. Then we will decide C ANCA or P ANCA is that. Then we can proceed further systemic. There is no end for all these systemic investigations. So if we take a clue from ANCA, P ANCA or C ANCA, because this has revolutionized the diagnosis and clinical improvement or management.
So why since ANCA associated is only we have three conditions, sir, which is not that common, which is very, very rare, and the other vasculitis are plenty, what we see routinely. So
but
right,
and
so
other things are there.
Fine. You can do that. It's not that. Only I am asking the clinical suspicion. When will you do? That's it. That's what Dr. Somani has already cleared. So well taken, sir. Thank you very much for that. See, I mean, don't think that only we are discussing it here. It is open to for you also. You can comment in between. You can say. You can question, or you can write on a piece of paper and please send it to me. We will address to the panelist. Please don't hesitate. Participate. Let us be interaction. Yes, please say.
Epistaxis has to be asked in all the patients, especially if you are looking for ANCA. And I want to ask about cryoglobulins. Okay. Cryoglobulins also, do you do it, or what is the role?
Dr. DVS was just telling me about the cryoglobulin. Would you like to highlight that?
Yes.
Cryoglobulinemia, please.
Yes, yes. Actually, this again Gandhi case. I have seen leukocytoclastic vasculitis. They have diagnosed and they treated, and then they have treated efficiently or properly. The thing is, it has come to our Pratima hospital with the leukocytoclastic vasculitis, and the rheumatologist has suspected cryoglobulinemia because cryoglobulin. Then it was negative. ANA was positive, and then the other. Then we have extended the investigation profile, saying that we need a HES test and other things, CT, BT, and then we have done also this autoerythrocyte hypersensitivity syndrome. Then we have injected RBCs, and then it was found to be positive. So leukocytoclastic vasculitis had suppose progressed to this autoerythrocyte hypersensitivity syndrome.
Okay, so
yes, I am Dr. Anand. So, ANCA, is it positive in all cases, whether you clinically strongly suspect like EGPA or vaginous or PAN? In all cases, do you see that is compulsory, is a positive? In how much % of cases you will see the positivity?
Yeah. Anybody? Yeah, please.
Yeah.
So, see, basically,
it will be positive, as I told already, that in GPA, the Wegener's, it will be positive of 90% of cases. And it is very frequently seen in case of macroscopic polyangiitis, and it's about 40% positive in case of EGPA, that the Churg-Strauss.
The ANCA, actually, it is an early sign, and then we can, if you see ANCA positivity, that is, we know the disease is going to come, and then next, it correlates with the disease activity also. Once disease activity is there, is not there, ANCA disappears.
See, basically...
Anything you would like to add, Anand?
Yeah, that is the reason. Is that
you want to add anything to that?
Yes, it's absolutely true, is almost 60%.
Thank you very much.
So, but I think you moderators have agree with Dr. Pratap saying that ANCA should be done first.
No, that's why I deferred. We deferred that.
I defer that.
We deferred that.
Of course you can.
So, right,
No,
fine,
you can.
Fine.
No,
so, how to differentiate? So, let us go to the connective tissue diseases. How to differentiate psoriasiform lesions from psoriasis? We do see the psoriasiform lesions in SCLE, isn't it? So, is it psoriasis or is it a psoriasiform lesion of SCLE? So, because the treatment differs, right? So, if you give PUVA, the other thing may definitely increase. So, how do we differentiate it? So, any light on that, Manmohan?
Yeah, psoriasis will have the classical features of scaling and then Auspitz sign positivity and other things. And by and large, psoriasis never heals with any scarring. Even SCLE also or psoriasiform
doesn't.
No scar.
Yes.
But Auspitz sign and other things are classical for this. And dermoscopy will definitely show the changes what you classically see in psoriasis.
Biopsy?
Biopsy, of course. Biopsy.
Even before, clinical picture also varies, because the psoriasis lesions, even though they are present in photosensitivity areas in SCLE, they are also seen, if it is psoriasis case, scalp and other changes also may give a clue.
Okay. So, that is it. The other site involvement, here mainly the sun-exposed areas, and then there may be biopsy will definitely be useful. And sometimes, why with important is because the therapy changes, sometimes there may be a coexistence of both, and it is reported in the literature, they can have both. So, you please closely examine the case and let us see whether it is a psoriasis or a SLE lesions, and if necessary take 2 biopsies and confirm, and then accordingly we should manage the things.
Sir, one point here, sir.
Please.
In the slide, there is slight scar is present in the center you are saying, but actually classical teaching is
Correct.
SCLA doesn't heal
Correct.
with...
Agreed. Agreed. Normally SCLE doesn't. So, right. We do see many cutaneous lesions in LE. So, what is the prognostic importance of each type of thing? Like we see timidus, we see malar rash, we see profundus, isn't it? So, what DLE? So, what is the prognostic value of these lesions, Pratap?
DLE, of course, chronic LE, there is no problem. The other thing is, nowadays the present papers and literature, if you show, the TEN-like lesions occur in SCLE. And TEN, of course, we have to differentiate between these two, because TEN is an emergency, and acute LE lesions can present TEN-like lesions, and then that there the prognosis also differs. So, if you see, if you look at the SLE part of it, if there is acute SLE and presenting with bulle or ulcers over the face and acute early, then the prognosis is, we have to take care of that condition.
Sudha, anything would like to add?
This DLE lesions in a SLE patient, that is a good marker that prognosis will be good. Second, bullous lesions, tumid lesions, they are all suggestive of severe SLE.
Sir, already sir mentioned that specific lesions in a cutaneous LE, one is as such DLE lesions and SCLE lesions, they are good prognostic signs, sir. These two, whenever we see, prognosis will be good. And what you mentioned is tumid DLE and as well as lupus profundus. Relatively, there also the prognosis is good. But if you come to SLE, we have two types of lesions. One is LE specific and non-specific. Specific lesions are macular erythema, photosensitivity. Under ARA criteria, we have oral ulcers and alopecia. They are bad prognostic signs. And acute onset, that TN-like lesions, and anyway, it helps in the diagnosis only. It doesn't indicate the disease activity. Whereas the non-specific lesions mentioned so many, they occur in the course of disease and they indicate the disease activity. So if you find one type of lesion, usually the prognosis will good. In the recent articles they mentioned 2 or 3 types of lesions, they indicate the disease may be more active. So non-specific lesions indicates the disease activity, whereas the specific lesions for diagnosis.
So that is it. So as Dr. Sudha has mentioned that the tumidity, it seems almost nothing to worry about the systemic lupus erythematosus. So all others have various percentages. The malar rash has the highest and the subacute around 50% or so. So that is the importance of the identifying the clinical lesions in LE. Right, this is what another thing people do nowadays, specifically the ANA patterns. We know there are 4 types of patterns. So is it anything important to know these patterns, or if you know just ANA is 1:160 before, now 1:80, the recent ULR criteria, Dr. Samani has brought it out now. Dr. Samani sir, please, anything would you like to say on that?
As you said, yes, I would go with your second opinion that titers are more important. The patterns are also important in a way because there is association between, say, speckled or the homogeneous pattern with SLE in men and women, and with other kinds of patterns with other conditions. But I would mainly request for a titer-based investigation, because these will give us a clue, but those are not solid clues or pakka clues. So that's why I would go more with titer than with the pattern.
So titers definitely help for diagnostic.
Basically, sir, if you see our IADVL textbook, older versions, they used to give all this. The new textbook, I think they have removed this pattern part of it.
No, it's coming back again. There are many studies now saying that even the pattern itself can give a specific diagnosis. True. And the homogeneous with a rim exaggeration or the rim pattern, it is there, it's coming. Even without titer, you can say the diagnosis of the lupus now. It is coming back.
And also, I want
Manjunath is here. Dr. Manjunath, I have seen him. They themselves have done one study and showing the significance of the ANA patterns in CTD. Yeah, you are there?
Sitaram.
Yeah.
Especially homogeneous, if a pattern is there, that is histone. So drug-induced SLE, that will definitely have some prognostic or the etiological impact. So like that, centromere, of course, SLE alone. Of course, as I said, the speckled pattern is seen in almost every condition.
I request moderator, sir, what ANA test you are advising to your patients?
Good question. If you want me to answer, or anyone would like to? I will ask somebody
because
he has dealt with the ANA.
Already answered.
Huh? No. Yeah, please.
I will ask.
Excellent.
IF method or some other methods. So that method I am asking. Because sometimes labs are sending back konsa method chahiye.
I will ask only for ANA titers.
No. Titer only, there are 2 methods, IAF and ELISA.
Yeah, I know.
Which do you prefer? That's I think question.
Generally IAF I write.
IAF is the one now, ELISA is no longer done. IAF is the test which you have to specify, saying that do IAF. So that is the thing which you have to do now. So thank you.
Next is substrate also plays an important. Substrate. ANA negative SLE, that is another, of course, chapter. Of course, I don't go into the details because there is no ANA negative lupus now. previously,
You have to, previously it was there.
No, previously we have reported, and along with me, so many have reported ANA negative.
Correct, because if now if you want to say lupus, it has to be positive. That is one of the entry criterion. So there is no ANA negative lupus now.
Basic criteria.
Correct. Okay. Any importance of anti-phospholipid antibodies? Yeah, you are the master. You have presented cases of in South Zone.
In Guntur South Zone, I have
Yes,
presented
yes.
5-6 cases of antiphospholipid syndromes. Definitely, when you see clinically libido, there are two types, racemosa and the arches which are broken. That is, what is that?
Libido reticularis and libido racemosa.
So the broken circles will
Is racemosa.
That is
Racemosa.
racemosa. And then areas of necrotic skins here and there, that also prompt us. And other than that, history of recurrent abortions
Yes.
in the patient below 10th week multiple times, and then also there are some vascular thrombotic phenomena recurrently occurring. All these things should tell us that probably we are dealing with an well, that's what.
Thank you. Thank you for bringing out that. Dr. Sudha, this is for you. We are the master of dermoscopy.
Sir, actually, our PGs are doing one of the PG, and as such, it has some value, sir, for diagnosis as well as prognostic, means in the disease activity also. So regularly, nail fold capillaries are they are uniform in diameter and regular U-shaped or hairpin shape, and homogeneously distributed. Size, shape and distribution is homogeneous. But whereas in systemic sclerosis, in the recent papers, they mentioned this theory, sir, I didn't see personally. They have shown some pictures also. So this one, they mentioned early scleroderma features, active scleroderma and late scleroderma. So as such, the nail fold capillary lesions are seen at least 6 months before the onset of systemic disease. So that is an early indication for the onset. And as sir also mentioned, Somani sir, video capilloscopy, which is difficult, but regularly now we have dermalite we are using regularly in the OP. In that they have mentioned one is capillary enlargement, one thing. Second one is hemorrhages and loss of avascular areas. So these three things, depending on that, we can decide whether the disease is active or not. And another thing, we can differentiate primary Raynaud's and secondary Raynaud's. In primary, the capillary abnormalities will not be there. In secondary means due to underlying connective tissue disorders, we can diagnose that. And SLE, even dermatomyositis also, some changes are.
Manmohan want to say something.
No, this is basically dermoscopy now, this dermalite or whatever is available, they are really good. And then it's almost, they say, equivalent to doing a biopsy. In fact, in these connective tissues, dermoscopy and videoscopy are much more, even 30 years back.
It's an upcoming subject. People are now identifying various features and trying to link with the diagnosis as well as the prognostic value. So this is just to learn what is happening around to us. So even though most of them are non-specific, as Dr. Sudha pointed out, in certain cases of systemic sclerosis and dermatomyositis, we may have some features. So some new words, that's why I just want to share it with you. Here is some prominent subcapillary plexus and meandering capillaries. I don't know what is that meandering capillaries. So I just checked it. There is nothing but a loop pattern, which you have shown in the top. That is a loop pattern, the spherical helical things, that is how the meandering capillaries are suggestive of SLE.
And dropouts,
this she has mentioned.
Dropout also is mentioned. Dropouts.
Dropouts we are coming. Dropouts here. Meandering is only a helical structure. And this is the SSC. She has already mentioned dilatation, hemorrhage, and then the necrosis. And this is dermatomyositis, very ragged cuticles, which is an indication of a severity of the cutaneous disease. Even though if you can't see nakedly, put over dermoscope, if you observe that, that indicates the severity of the cutaneous disease. And that is the dropout capillaries here. So red lunula is non-specific, seen in most of all the STDs, CTDs, connective tissue diseases, and then that is the severity. You can see the 6 months before, mainly it indicates the organ involvement in systemic sclerosis and dermatomyositis. So it's an important tool for us to have a look at the nails in all connective tissue diseases.
Sir, can you please go and tell us, your dermoscopy is so expensive, 80,000 to 1 lakh rupees. Is there any other alternative? Because we used to do with the cedarwood oil and then ophthalmic fundoscopy.
Yes, fundoscopy. Previously we used to use, but not like only capillary dilation will be seen, but that mandolin and dropouts may not be visible with fundoscopy, probably.
I think depends on the magnification. Magnification.
Yeah, share that your point, what you are telling.
The magnification is important. So we need to check whether its magnification is as good as the dermoscope we use. I think dermoscope uses much higher magnification than the fundoscope.
But this is the only place where you can see vessels is eyes and then nails, where you can visualize the capillaries or in smaller vessels that will guide us so many things.
Yeah, have a look at this case. It's an 8-year-old girl with acute early rash, of course SLE, fever, leukopenia, renal involvement, and specific test positive. So what is our role in the management of this case? How much we can manage this and what to give in? Is a child, 8-year-old, Manmohan.
Yeah, sir, this is an acute SLE where you can get almost the presentation like a Steven Johnson's or a toxic epidermal necrolysis. They should be admitted and then we have to involve the other specialists also in this. That is very important. You just can't give steroids and keep the patient with us. So it's always a multisystemic disease most of the times. And if Dr. Somani remembers, we heard Dr. Malavia in Nizam's long back. So he was presenting those days acute drug reaction like SJ, like TN, like now that it comes in our books also, that classification is Gilliam's classification or whatever.
No, why I brought this is this child is managed by us. We gave her HCQs, we gave her systemic steroids, we gave her azathioprine, not responding, and then we shifted to mycophenolate and myrfitale, and within 2 weeks she developed leukopenia, so I had to stop the mycophenolate and myrfitale. I have stuck with. So I thought, any opinion from the
Sitaram, we have got nowadays rheumatologists. Of course, rheumatologists are, they can guide us probably. Rheumatologists, they give whatever acute SLE or LE is there, they immediately load with methylprednisolone.
What is that?
Methylprednisolone. Methylprednisolone, they give. The other things, they, of course, they act afterwards. First they give 3 days or 4 days, whatever the period is there, they give methylprednisolone, loading those.
Prednisolone means we also give, sir. What do you mean methylprednisolone? They give pulse?
Pulse,
or they give the
yes, higher dose, pulse.
May I, Dr. Sitaram? I recently remember one case I saw. Childhood SLE is actually very rare, actually, you don't see so often. But a girl child came to me 10 years old who came with lesions which are persistent on the cheeks and on the upper back, which are erythematous, kind of indurated and necrotic. So, and she has been going around all the dermatologists and all the physicians applying all kinds of steroid creams and doing all the kinds of antibiotics. But I suspected, and then it came as positive. I referred that patient to the rheumatologist for further advice. He straight away put her on tacrolimus, mycophenolate mofetil, and steroids. Actually, I treated the patient with hydroxychloroquine and sunscreens, and that's how I wanted to manage. But he straight away gave all those things to the patient, and patient recently came back to me with severe herpes zoster on the thoracic area, severe. But just to mention that they give all these drugs immediately, even if it's a child, they start giving it.
So, sir, in that case, was other investigations like antiphospholipid and all were negative?
Negative, yes.
Negative.
APL was negative.
And what was the cause of, you lost the patient, you said, no?
No, patient is still there.
Still there. So, not responding, still she is getting the lesions.
We are giving her steroids, little come down, again increase the steroids and come down. But because we are unable to see, if the child is on 20 mg, she will be okay, fine, no fever, no rash come down. Little reduce the problem. Then added immunosuppressants, developed some side effects, go back to steroids again. So how to relieve it? My question is, does rituximab have any role in the SLE? I would like to ask Naeem, who is a specialist of rituximab, if he is here. Can you throw some light? Yes, please. He has a rituximab collection quite heavily.
Sir, good morning, sir. Though I did not hear initial part of your question, I do get this question. What's the experience overall in SLE? Sir, my personal experience is in only one case. So that was again a refractory case, and the patient was given 500 mg 2 doses at a gap of 14 days. And I did not see as much benefit in SLE as much as in case of pemphigus, sir. That's my experience. And I would still fall back on the conventional therapy for SLE rather than rituximab. So that's my personal experience, but I don't have a huge collection in SLE, sir. I should admit.
Sir, in this particular case, cyclophosphamide, because the renal involvement is there, nephrologist opinion, cyclophosphamide pulse or...
The other specialists are already there in the loop. It's not that managed by us alone. They are there, but these are the problems we have faced.
Cyclophosphamide pulse therapy also is indicated, I think.
We have not tried cyclophosphamide.
Tacrolimus, like sir was mentioning, tacrolimus is also a good option, but renal we have to check.
So we are thinking of rituximab. So in the child, we thought of adults anyway, they are giving a lot of dose. So we are just thinking of rituximab at present. Okay, so we have less time, less than 4 minutes. So a patient of SLE, well managed, treated, under control, remission. But the problem with the steroids, he developed the avascular necrosis of the hip. The orthopedicians have said that hip replacement. So he came back to us asking, now we are giving all these drugs, what should I do with these drugs? Shall I stop? Shall I continue before I am going for the surgery? Sudha, any comment on that?
Which stage? This one depends on the stage of avascular necrosis. So if it is stage 1, they can go for decompression therapy. Stage 2 and 3 osteotomy.
They decided to go for hip replacement.
Hip replacement.
Now they want to know about the SLE treatment.
SLE we can continue the search because steroids are not always associated with, compared to pemphigus we have seen many cases of avascular necrosis. Sir. Here also steroids are one of the cause for avascular necrosis. As such, SLE activity is also could be the reason. So literature also they mention without steroids also patient develop avascular necrosis. Even after stopping steroids, 10 years after stopping the steroids also they have given. So little bit by gradual tapering they can undergo the surgery.
Sir, I feel any surgical procedure in a SLE patient, we should see the status of SLE, how much it is, involving the systemic or it's only cutaneous. Depending on that, if the patient is not on immunosuppressives, they can
so
be
that's a very good article in the JAD. I thought I'll share that with you. So that was the article, and they said the consensus is if severe SLE, don't stop the drugs, just continue whatever he is taking. If he is inactive, then stop 1 week before the surgery and then restart it after 14 days. And steroid increase, as we think that any stress dose, surgeries are there, increase the steroid and then it's not necessary. That was the consensus of that article. And definitely the surgery will have some impact on the disease process also. There may be some exacerbation, there may be hypercoagulability, and there may be less wound healing. This of course you have to take care in the future. We have less than 2 minutes, so we will skip all this. So, this is another thing which we come across routinely problem in the pregnancies with the CTDs. They want to become pregnant, and a patient of SLE or a patient of systemic sclerosis, dermatomyositis. Okay, now disease is controlled, so I want to become pregnant. So how do we advise Dr. Somani?
Disease
Well, depends upon the condition. For example, in SLE cases, we should always be on the lookout for any renal involvement, mainly look for antiphospholipid antibodies. We know that the incidence of eclampsia, preeclampsia is very high in SLE. So monitoring all those things, we can allow the patient to go for look out for the pregnancy. If the disease is quiescent for the last 6 months or so, there is absolutely no issues, patient can go for it. But if still the patient wants to go for it with low dosage, low medications for controlling of the SLE, we can go ahead, but we need to check for antiphospholipid antibodies more frequently and check for the renal parameters so that the patient doesn't land into any complications. In case of dermatomyositis, systemic sclerosis, most of the patients have successful pregnancy outcomes even while continuing the treatment. So we can maintain the disease in remission or with low medications and then try to ask the patient to go for pregnancy. So successful outcome is usually recorded in the other two conditions, dermatomyositis, scleroderma. But in case of SLE, we need to be more careful in managing this case.
Sir, in SLE, the problem is the effect on the child also, as the effect on the lady also during pregnancy. So their child may be, as we have reported one case of neonatal SLE with small skin lesions, and then when we did, there was a bundle branch block and heart problems. Lady was actually negative, I mean, she was only ANA positive but no symptoms.
So we will conclude that the thing is the CTDs and pregnancy, every pregnancy with the CTD is a very high risk, and appropriate conceptual diagnostic procedures are necessary, and we should have about the renal flares and the as Dr. Samani sir mentioned, the antiphospholipid antibodies, pulmonary hypertension, and the drugs what we are going to use in managing this patient. We should be very careful and cautious and know about these drugs and drug interactions with the pregnancy and the effect on the fetus, and then counsel them about the risks. In general, in inactive dermatomyositis, we can go ahead with the pregnancy, and in inactive systemic sclerosis also we can. SLE, you have to be very, very cautious. So thank you very much for that patient listening and participating in that. Thank you very much, sir. Dr. Samani, Dr. Durga,
Thank you.
Dr. Pratap, Dr. Manmohan, Dr. Sudha, for a very good interaction. Thank you very much.
Thank you very much, sir. Sir, the next session is about dermatopathology. Sir, please come to the photo session and mementos. The next session will be dermatopathology. The chairperson, sir, Dr. Aruna Madam.
Excuse me, I just want to bring a point about ERC-CRP ratio in SLE patients, please. If ESR is very high and CRP is mildly elevated, then that is lupus flare. And if CRP is mildly elevated but ESR is mildly elevated but CRP is very high, then that's infectious in SLE patient. So the treatment differs. So if you can just check ESR CRP ratio in SLE in Google, and whatever the first article comes, please go through it. Thank you.
Thank you, thank you, sir. Dr. Aruna Madam, Dr. B. Janardhan, sir. Sir, please come to the dais. Madam.
Some remarks is there, but there's no PPT.
Okay.
Madam, please start the session.
A very good afternoon to all the delegates. Coming to the session 5 of the Day 2 conference on the topic dermatopathology. I myself with Dr. Aruna Madam will be chairing the sessions on the topic clinico-pathological correlation of rare and interesting cases by Dr. I.S. Reddy sir. I request Dr. I.S. Reddy sir to please come on to the dais. Dr. Geeta can join us on the dais.
Shall I start? Just help. Where to move the slides? Show me. I want to go back. This is to go back, is it? Okay, this and this. Okay. Thank you, chairpersons. At the outset, I would like to thank my friend Dr. Murthy and Dr. Bhumesh for giving me this opportunity. Today my topic is CPC of clinico-pathological correlation of rare and interesting cases. Before starting, I would like to say an important thing. The word rare I have used. The rare may not be rare for others because we have here in the audience, we have the faculty who teaches postgraduates and we have senior dermatologists who have been practicing since many years, and some of them, they might have seen these cases. So it may not be absolute fact that what I am going to present are extremely rare, but for the sake of benefit of the budding dermatologists, I think this particular presentation will help them. To start with, this is the first patient I have seen, a 50-year-old female. She presented with itching, scaling, hair loss from the scalp of 8 months duration, and she was not on any medication and she did not have any other symptoms. Clinical examination, she had diffuse non-scarring alopecia and fine scaling all over the scalp, and she had multiple discrete follicular papules over the frontal and parietal areas of the scalp, and important thing is there is no skin lesions elsewhere on the other areas of the body, and oral mucosa and nails were within normal limits. Here you can see the clinical photograph, the diffuse non-scarring alopecia, and then if you look closely you can see some of these scalp, you can see some follicular papules. Here you can see, appreciate it better, you can see the very prominent follicular papules, and there is a pigmentation, and you can see significant hair loss in this area. So based on this, my differential were seborrheic dermatitis, sebum psoriasis, lichen planopilaris, and DLE. So I did the biopsy of the papular lesion over the scalp. This area I have taken the biopsy from one of these papules. The biopsy was a real surprise. Here you can see the infundibulum of the hair follicle. The infundibulum shows numerous spores within the infundibulum. The other areas of the hair follicle is completely normal, and there is absolutely no inflammation around the infundibulum of the hair follicle. The close-up view, you can see multiple spores involving the entire infundibulum of the hair follicle. Absolutely, there is no inflammation. The diagnosis of pathologist diagnosis was endothelic type of tinea. I never suspected clinically. I thought of so many other entities. I didn't suspect tinea. Tinea capitis, as it is very commonly seen in children, very rare in adults. I have seen only one patient, a patient of HIV, wherein apart from the scalp, this patient had lesions over the nape of the neck as well as in the retroauricular area. This patient is HIV negative, not a diabetic, no skin lesions elsewhere. Even the scalp around the hair margins also, the skin around the over the retroauricular area, over the nape of the neck, completely normal. So this particular patient I thought it's a little rare entity. And endothelic type of tinea capitis, causative organisms are Trichophyton tonsurans, Pseudonense, Violatium, and Yawundi. Unfortunately, I could not do the culture for this patient. Had I done the culture, the workup would have been complete. And then I treated this patient with itraconazole 100 mg, 2 capsules daily for about 5 weeks. And this is the result. You can see all those follicular papules completely disappeared, and then there is a fairly reasonable amount of regrowth of the hair in this area, frontal area. Earlier the area was completely, the particular part of the scalp was completely devoid of the hair. There is a total regrowth of the hair. More than that, the follicular papules have completely disappeared. Patient 2 is a 35-year-old male, asymptomatic papules, nodules and plaques over the scrotum and pubic area, since 10 years. And he had an asymptomatic cauliflower-like growth over the scrotum 3 years. It started as warty papules over the side of the penile shaft, and then slowly it has grown to reach a cauliflower-like growth, and he denied pre- and extramarital high-risk sexual behavior, and HIV, VDRL, TPHA all were negative and non-reactive. This is the lesion. You can see the huge cauliflower-like growth involving the penis has completely disappeared, and then involving the scrotum. In the scrotum you can see sort of hyperpigmented papules involving the scrotum. This particular thing is a burn scar he sustained when he was a child. The close-up view, you can see this nice cauliflower-like growth over the scrotum. These are the differentials I thought of: verrucous carcinoma, squamous cell carcinoma, and Buschke-Lowenstein tumor, otherwise known as giant condyloma acuminata. The histopathology, you can see as clinically, histopathology also you can see hyperkeratosis, very irregular acanthosis, and papillomatosis. You can see very significant papillomatosis. And then you see the basal layer is completely normal. The basal layer is intact. This is another picture. You can see prominent papillomatosis. And then here you can see few vacuolated cells. This gives the clue about the diagnosis. You can see few vacuolated cells here. Here you can see lots of vacuolated cells. And then this is the papillomatosis. Here you can see the vacuolated cells, otherwise known as coelocytes. The coelocytes are nothing but viral inclusions. You can see an eccentric hyperchromatic nuclei surrounded by a this empty space. It is due to the presence of cytoplasm, and these are all coelocytes. And then you can see significant hyperkeratosis here. The close-up view of the coelocytes, you can see the nuclei surrounded by cytoplasm, large cells. These are all the high power view of the coelocytes. This is the diagnosis, is Buschke-Lowenstein tumor, otherwise known as giant condyloma acuminata. The patient was referred to a urologist. When they put the patient in the surgery table, and they could, when tried to explore that huge cauliflower-like growth, the whole such a big swelling was attached to the lateral aspect of the penis through a normal, very small, tiny pedicle. They could excise it with just surgery was over within a matter of 10 minutes. And then this is the outcome after the surgery. All those lesions also started, that hyperpigmented papules over the scrotum, also they started regressing after the surgery. Patient 3, a 56-year-old female. She had skin lesions with severe burning and pain over the limbs, abdomen and back of 2 months duration. She had pain and burning over the tongue and buccal mucosa. In addition to that, she had profound weight loss. She underwent distal pancreatectomy and splenectomy for a neuroendocrine tumor of the pancreas. 1 year later, she developed a recurrence of the tumor over the head of the pancreas and with metastasis in the liver. Dermatological examination, she showed multiple well-defined annular and irregular erythematous plaques over the extensor aspect of the limbs, and periphery of the plaques were elevated and crusted, and diffuse erythematous non-scaly papules over the back of the hands, forearms and abdomen and back, and oral mucosa showed diffuse erythema, tongue and buccal mucosa devoid of the tongue devoid of the papilla, and maceration of the angles of the mouth, something resembling angular stomatitis. This is the clinical lesion. You can see erythematous plaque, the margin showing peripheral margin is very prominent, and it's showing crusting. And this particular area, the lesions looks more like a pellagra-like rash. Erythematous papules involving the back of the hands. And this is the back of the thigh, lateral aspect of the thigh. You can see this huge erythematous plaque, the periphery showing crusting, crusted papules. Here you can see a well-defined annular lesion. The margins show the papules, and some of them are crusted papules. The biopsy was taken from this area. The biopsy shows hyperkeratosis and a lot of crusting and granular layer, little prominent granular layer, and psoriasiform hyperplasia, and the upper dermis doesn't show anything significant inflammation. Here you can see parakeratosis. Here you can see the granular layer is not so prominent. This is the important change we see in histopathology. You can see lot of vacuolated cells here in this particular area. Here also you can see vacuolated cells. This is the clue for the diagnosis. Presence of vacuolated cells in the upper stratum malphigiae. Again you can see these vacuolated cells, and then there are few inflammatory cells, mostly neutrophils here. This is one of the pictures I have taken from the textbook. This is the florid, what I have shown earlier, they are very subtle. This is a very classical florid presentation. The entire thickness of the upper stratum malphigiae is showing these vacuolated cells, and pallor of the epidermis also, and there is overlying parakeratosis. So the biopsy of the skin, the report was given like this: show few vacuolated keratinocytes, occasional apoptotic keratinocytes, and overlying parakeratosis. Features could be consistent with necrolytic migratory erythema in view of the history, because the patient had a pancreatic malignancy, done surgery twice, and then there is a recurrence, liver metastasis. Based on this particular report has been given as necrolytic migratory erythema. Necrolytic migratory erythema, virtually pathognomonic of alpha cell tumor of the pancreas, which secretes glucagon. If this typical eruption occurs in the absence of pancreatic malignancy, this is called pseudoglucagonoma syndrome. Pseudoglucagonoma syndrome is seen in conditions like chronic pancreatic insufficiency, liver cirrhosis, celiac sprue, and inflammatory bowel disease. Treatment: resection of the tumor, intravenous somatostatin. This somatostatin, nothing but it acts as an antagonist for the glucagon. It's otherwise known as octreotide, and supplementation of zinc, amino acids, and fatty acids, and chemotherapy. Ultimately, after 2 months or after 3 months, patients succumb to our illness. Patient 3, a 40-year-old male, asymptomatic solitary sessile skin-colored nodule over the left ala nasi since 10 years. The nodule was firm in consistency and showed few telangiectatic vessels. This is a clinical picture. You can see a large nodule over the left ala nasi, and maybe the distance you may not appreciate. It shows some few telangiectatic vessels. Clinically, I was not sure what exactly is the problem. I referred the patient to a plastic surgeon. They excised the whole thing. This is the histopathology. Epidermis is normal and atrophic, and the dermis, entire dermis, starting from the papillary dermis to the reticular dermis, you can see multiple islands of basaloid cells. And then you can see few horn cysts also. This is the close-up view. You can see the horn cysts. These are all basaloid cells. And then you can see nice peripheral palisading also. You can see peripheral palisading here. And then you can see these horn cysts. This is a close-up view. You can see the peripheral palisading and horn cyst. And this one important feature about this histopathology is this particular appearance is known as papillary mesenchymal body. It looks like something like a hair follicle, the root of the bulb of the hair follicle, wherein you can see these cells, and then this is a mesenchyme. This particular appearance, if you can see in the tumor island, it is particular type, this particular appearance is known, this particular feature is called papillary mesenchymal body. If you can see papillary mesenchymal body in the tumor islands, we can confidently diagnose trichoepithelioma. Histopathology report came as a trichoepithelioma. Sometimes it's very difficult to differentiate between trichoepithelioma and keratotic BCC. The only differentiating feature is in trichoepithelioma, we can see this papillary mesenchymal body, whereas papillary mesenchymal body is absent in basal cell carcinoma. And usually trichoepithelioma presents as multiple lesions. This is very unusual, single lesion. Single lesions have been reported but very rare. This is a classical case of trichoepithelioma. You can see multiple lesions in the central area of the face, or the forehead, or the root of the nose, or the sides, and over the upper lip. This is what clinically we can confidently diagnose trichoepithelioma. When the case presents as a single lesion, we have a problem for the diagnosis. The fourth patient, a 30-year-old male, asymptomatic, progressively enlarging, hard, that is important, hard sessile nodule over the back of the elbow since 7 years. Pilomatricoma was suspected clinically because of the hard consistency. Any tumor, skin tumor, if the consistency is very hard, we have to suspect pilomatricoma. Excision biopsy was done by a surgeon. This is a close-up view. This is the excision biopsy of the histopathology slide. You can see this is the epidermis. It got little turned upside down. You can see the nice capsule, and there are two types of cell, dark staining cells, and these are all basaloid cells, and these are all eosinophilic cells. There are two types of cells, basaloid cells and eosinophilic cells. You can see, appreciate it better. This is the capsule. These are all the basaloid cells, and then this is the eosinophilic, otherwise known as ghost cells. You can see the transition. Here you can see the transitional zone. This is called transitional zone, and then the ghost cells, they lose the nuclei. That's why it is called ghost cells. Here they're all nucleated. Here you can see the nuclei becoming smaller, and then here the nuclei is completely absent. These cells, which are devoid of nuclei, they are known as ghost cells. Here you can see little calcium deposits also, which gives that hard consistency for the tumor. This pilomatrixoma, otherwise known as calcifying epithelioma of Malab. The last case is a patient 5, a 40-year-old male, known case of amyopathic dermatomyositis on oral steroids, mycophenolate mofetil, since 1 year. Developed a new rash in the form of hyperkeratotic, verrucous, scaly patches and plaques all over with more prominent lesions over the palms and soles with severe itching. I suspected psoriasis in this patient. It's a case of dermatomyositis on very long-term immunosuppression. Unfortunately, I don't have the clinical photographs of the patient. I suspected psoriasis. I did the biopsy. This came a real big surprise. You can see the epidermis, and then little lichenoid infiltrate, something here in the stratum corneum. You can see better. This is a body part of the mite, scabies. It's a case of scabies. Scabies mite. The pathologist gave the diagnosis as scabies. This is a Norwegian scabies in a patient. Because of the immunosuppression, this patient developed Norwegian scabies. Subsequently, so many other family members also developed symptoms of itching. We had to treat all of them. Ultimately, the patient became all right. This is another picture I have taken from one of the textbooks. You can see the mite larvae, and then you can see the excreta of the mite also in the stratum corneum. This is the last case, the last slide. And I would like to thank all my pathology colleagues who give me a really lot of help whenever I prepare any presentation like this. I must owe a lot of thanks to them. And last but not least, I thank everybody for patient listening. Thank you very much.
Thank you very much, Dr. I.S. Reddy sir, for excellent talk on dermatopathology. Now I request Dr. Geeta, dermatopathologist, to give her comments, concluding remarks.
Good afternoon. At the outset, I would like to thank the organizers for giving me this opportunity, and I thank Dr. I.S. Reddy sir, who is the senior most dermatologist, and I'll consider him as a dermatopathologist because he has explained everything very crystal clear. But I would like to add some points because I'm a dermatologist as well as a pathologist. First case, this tinea capitis. So we have seen some cases like sir has explained, and in our sections we could see some arthro spots. Sir has explained some spots are there, and in some very few patients we could see hyphal elements in most of the follicles, and associated lymphohistiocytic infiltrate was there in our sections, but sometimes they may be there or they may not be there because it could be a long-standing lesion. And sir has explained very well about the papules, and we have to take a differential diagnosis because papules of the scalp usually we don't consider tinea capitis, but here sir has explained very well. And regarding the giant condyloma accumulata, coilocytic change, it was very prominent. So if we see coilocytic change, we have to suspect this viral particles, and we have to suspect this condyloma accumulata. That's very well. You have explained very well, sir, for the sake of PGs, postgraduates, as well as for people like me also. And coming to the this third case, glucagonoma syndrome, I think, sir, because there is alpha cell neuroendocrine tumor of the pancreas. So the clinical scenario is characteristic of that, sir, burning sensation over the face and extremities as well as oral mucosa. And we'll see abrupt necrosis, sir, in majority of the cases. There will be necrosis. But you have explained very well, sir, vacuolated cells and apoptosis clinching the diagnosis. So there is abrupt necrosis of the upper layers of the stratum spinosum. And how to rule out pseudoganglionoma syndrome sir has elaborated well. If there is no pancreatic tumor, we have to think it as pseudoglucagonoma syndrome. And coming to the pilomatrixoma, for juniors, you should think, if it is hard, you should think there is calcification. In 70% of pilomatrixoma, calcification is usually there. And apart from that, you have to concentrate on two types of cells. The tumor islands consisting of basophilic cells, and apart from that, you are saying ghost cells, shadow cells, which are devoid of nucleus. That clinches the diagnosis. And apart from in-between calcifications, if you have doubt, you can do special steins like Vancosa for calcium. And scabies, it is very clear cut. I'm really appreciating sir for taking that photograph. And trichoepithelioma. So how to differentiate this from BCC? Usually in basal cell carcinoma, we'll be seeing some artifact, some lacuna, some surrounding, there will be a gap of the islands, like you'll be seeing basophilic cells, nests of cells. So that is artifact. There is a clearing zone is observed in BCC. Whereas in trichoepithelioma, you don't appreciate any clearing zone. It is tightly packed and there will be fibroblasts surrounding the tumor. And thank you very much for giving me this opportunity. Thank you, sir, I.S. Reddy sir, and all the organizing people and the chairpersons. Once again, thank you.
Thank you, Geeta, for your concluding remarks. We thank organizers for giving this opportunity.
So this is followed by lunch. To avoid the crowd, the faculty lunch is on the beside and the delegate lunch in the another hall. So we'll reassemble at 2 o'clock sharp.
valuable lecture on the leprosy.
Thank you very much, Chairpersons, for the kind words and the words of introduction. I hope I am audible. Yeah, I think it's always, post-lunch sessions are always difficult, more for the audience and less for the speaker. But I try to keep you, like they said, try to keep awake and active. Yes. Perception about leprosy and facts. I thought I'll take this talk, or rather I chose this talk specifically because of, I thought this is important that we should look at the perception we have about leprosy and how we can, probably there is need to change them or look at them differently. What is the definition of perception? Let's start. The perception is a way which something is regarded, understood or interpreted, and the way we think about something. So I think leprosy always had perceptions about the disease as well as the management issues and the treatment. And the definition of fact is that the truth about the events as opposed to the interpretation, and most importantly the second part, something that is known to have happened to exist or something for which proof exists or about which there is information available, but are we using that information to change our perceptions? Leprosy is a special disease because it's an ancient disease of mankind. We can look at this book which is of leprosy in Byzantium, the title of which is called Walking Corpses. So such is a kind of title which leprosy can have, a book of leprosy can have. It's an age-old disease where manifestation left many a negative imprint on the human psyche. And mutilation of leprosy unfortunately is not limited just to the human body, but also it has invaded and impacted the mind. So much so how we perceive has been defined by the disease itself and its mutilations. Look at this picture of a Nigerian mask of leprosy marks from Africa. We can show how it is grossly made. The specific clinical, political and institutionalized choices made in the leprosy control over the decades and probably centuries have highly significant in shaping the attitudes and approaches to the leprosy. So the perceptions of leprosy are all made by these images we have, or the beliefs we have, all the things we have understood and seen over the time. And even the most fair-minded of us will have at times harbor irrational stereotypes of people who are in some way different from us, and of course leprosy also a disease which is different from us, others. Possibly it's time to change some of them, and let's look at them. And before we go further, let us also look at, I just want to look article, a path to acceptance, how we accept new concepts or ideas. The advancement of scientific knowledge is an uphill struggle. Same is with the changing of perception against accepted wisdom. Here is a mask, a very famous mask of a king who ruled Israel, who had leprosy, and he had to wear this mask. Of course, supposed to be a very benevolent king, but then he had to wear this mask to appease people. Perception. I am going to talk about just 4 perceptions. The first one is leprosy is disease of poverty and disease of poor. Leprosy is disease of poverty. Yes, leprosy is disease burden highest in the countries with poor people, in the lower income and also in the developing countries, Africa and Asia. Poor living conditions can act as a breeding ground for disease such as leprosy or exacerbate symptoms of existing ailments. But so does other 20 neglected tropical diseases. Leprosy is just one of them. There are 20 listed tropical diseases, neglected tropical diseases according to WHO. Leprosy is one of them. Leprosy is nothing special about it, that it particularly affects poor people, but the concept has been evolved. But the fact about leprosy is that the link between leprosy and poverty has been suspected, but very difficult to demonstrate in national, communities as well as individual basis. There are no clear correlation between national GDP levels and leprosy new cases. For example, in the Brazil, which is much high advanced compared to Benin, a country in Africa, the leprosy is higher. Big questions currently hang over the public health approaches to leprosy control based on this concept of poor leprosy patients. And other facts is that social determinants of leprosy have been poorly studied. What exactly is that determines leprosy? Not just poverty, but maybe it's overcrowding, maybe the soil, maybe the environment, and need to be addressed in countries where leprosy incidence is still high, such as in India and Brazil. The presumption that all leprosy patients are poor is depriving them of access to available medicine. This is very important. I think I will just want the audience to have a understanding of what I am trying to tell. I hope I am able to connect with you. Let's look at the previous figure. This is a kind of a splint. And such splints for leprosy, how many of us are prescribing for a leprosy patient? While how many of us are doing PRP? How many of us are offering radiotherapy, radiofrequency? How many of us are doing peels? But how many of us are actually offering such kind of a splint? You must be wondering how much this costs. This costs something less than 1,000 rupees, such kind of a splint. And most of the time we think that this is supplied by Lepra India or government. But they are very much available readily to us. I just looked for a finger splint, just one finger splint. Finger splint for leprosy, when I typed it in Google, I didn't get any results. But finger splint I typed, I get finger splint for rheumatoid arthritis, finger splint for injury, finger splint for trigger finger. We get number of finger splints. So many so, I just Google and finger splints, you get best prices. The cost of a finger splint is just 100 rupees. A person with 4 fingers needing splints, the cost for him is 800 rupees. I'm sure every patient of ours can afford this kind of splinting. But are we offering it? Are we asking him to buy Amazon, through Amazon? It's available. I'm sure when we can buy things from Amazon, even a patient can buy. But we are not offering it to him because we presume that the leprosy patient is poor. He cannot afford these things. He can well afford all these gadgets. Some leprosy patients are poor, but many can afford to pay for their additional medicines. If you want to give extra medicines, they can buy, apart from government MDT. They can also have additional investigation if you like. They can also buy orthotics, which I just showed, and also immunoprophylaxis, something like MAP vaccine. Suppose you give MAP vaccine for the patient, you have to give 2 doses or 3 doses in a year. Even if somebody buys Septivac, I'm just discussing one of my students here, it just costs maybe about 5,000 rupees once in 3 months. He can easily, many of the patients can easily afford it. Are we offering him what they deserve? So this is a question. I just want the audience to think about it. Another perception is all leprosy patients should be managed with free MDT. Yes, this is come into existence, and Novartis has been supplying medicines free of cost to MDT from 1983 onwards. From year 2000, they have already supplied medicine 7.3 million leprosy patients, which is very laudable. And Novartis has pledged the medicines up to 2025 as of now, but not up to 2030. They want to revise the strategy. It is an excellent gesture, very laudable. However, surely it will cease in few more years, if not by 2025. There is a need to look at the options post 2025 right away. What is the downside of Novartis giving free medicines leprosy? The other day I was actually discussing with Novartis managers of this issue. There is a downside to it. Because Novartis is a single company which is supplying all MDT, no other company is coming forward to supply medicines. While one more concept is, while something is given free, we always know how we treat a person who comes and takes anything free from us. We give less respect to the guy who receives medicines free. Anything given free, is the person receives less respect. And complacency sets in the program because already giving something free, why do you want to give something extra to him? Already the medicines are free, and the attention also goes down. It has curbed the involvement of other pharma in NLP, as I already said. For example, number of pharma work in other diseases like tuberculosis. And Government of India are also very reticent in involving private healthcare providers because Novartis is already involved and Novartis is already giving medicines. Self-sufficiency in national leprosy drug management is inadequate. It's a time probably we all start looking at what is next after and beyond Novartis. Need to self-sufficient in leprosy is, we all face it, all dermatologists. We all know the periodic non-availability of dapsone and clofazimine in the market when you want to prescribe to the patient. Why is that not available? Because government presumes that all leprosy patients should go to government agencies and buy them. In fact, number of patients of leprosy patients are treated outside of government agencies. Nor availability of rifampin syrup in child leprosy patient. This is a serious question. For even a child leprosy patient, they can't swallow rifampin capsules, but rifampin syrup is not available. It's a time to look beyond, and for example, Cipla, Macleod, Hetero, and Lupin are a part of national TB and HIV programs. Who is there for leprosy? We are not involving anybody yet. It's a time probably we do so. The third perception I'm talking about is fixed duration therapy for leprosy is sufficient for all the leprosy patient, whatever WHO prescribes. Yes, the people get fixed duration therapy for 6 months or 12 months as per the program, and they think the FDT is sufficient. A defined number of MTT blister packs are made available by Novartis WHO, and suddenly some patient increase, there is always a short supply of the strips. The purpose is to stop the community spread, but it is not specifically about an individual patient. But the fact is that we all know that FDT is only for field and community, but it's not designed for individual patients. It's a time the individual patient is taken care of or considered, because the leprosy prevalence, which was about 14 million, has come down to 200,000 all over the world. In India, the prevalence is around 87,000 as per government figures. We can take care of individual patients at these numbers. And we have also got necessary finances, both government, private, as well as the patient. For example, in UK, USA and Japan, and many other countries such as Singapore, they use regimens beyond WHO MDT for their country's own good. Maybe it's a time we also look at it. And also, most important, treating all smear positive patients till smear negativity is the only way to ensure the prevention of transmission in the community. As long as we treat the patient and bring down from 4+ to 3+ and leave them in the community, the leprosy is going to spread. Yes, it is going to spread. Only way to treat them to smear negativity, it has to be taken note of. Lastly, the last point I'm talking about is new drugs are not needed for leprosy patients. Government always gave 3 drugs for leprosy from year 1983 when it was launched. Right now we have fluoroquine. And because the burden has fallen significantly, leprosy patients and BL patients, so we need probably stronger regimens. Guidelines need to be, the bottom line is guidelines need to be developed on how to use modified MDT or extended MDT or second line drugs effectively in leprosy. Finally, the post-RFT patients do not need surveillance. This is the issue which is also important. Leprosy patient after completion of MDT, the 12 months are released from treatment and program cleans the resistors, and there is no surveillance to post-RFT patients. But the fact is that most leprosy complications arise year after MDT. Drug therapy of MDT, which is for 6 months or 1 year, is a very small part of the first part of the leprosy patient management. The management extends beyond probably 5 years or 10 years down the line. Administration of physiotherapy, self-care advice, rehabilitation are much tougher and resource intensive compared to MDT. So here probably government and all of us should focus on how to help these patients. There is a need to include care after cure of leprosy patients in the program in a big way as of now, which is lacking. Note, there are more than 3 million leprosy affected people in India with disabilities, and they all need attention. Other perceptions, I'm just closing down next 2 slides. The presence of grade 2 disability is important, but grade 1 disability is not. Probably we have to look at this concept, whether it is right, because every neglected grade 1 disability leads to grade 2 disability, just matter of time. It is a ticking time bomb. Child leprosy deserves attention. We have about 8 to 9% of child leprosy in India, whereas leprosy in old people more than 60 years of age is about 19%. These are the reservoirs of leprosy in India. Negligible number of leprosy patients are managed and treated outside NLEP. So our study of DermLab study has thrown up that maybe about 50, anything between 50,000 to 1 lakh leprosy patients are treated outside of NLEP all over India. Lastly, to all of us, we can look at the crowd, it's slowly filling up. Leprosy is always kept at the end of the conference. Last part, post lunch, because leprosy is not important for dermatologists because it's almost eliminated. In summary, I like to say it's important to understand the needs and requirements change with time. Maybe they were right in 1983 about MDT and 3 drugs, but this is 2021 and we have, compared to 14 million, we have 0.2 million leprosy patients, and we need periodic re-evaluation based on the numbers and the type of leprosy patient you're getting and revamping. It's important to ask questions as why should we stick to the old regimen, and how we can improve the old regimen to existing regimen, how we can improve with the new drugs. This is needed. Only way to improve is by innovation and adapting with times, and we, the dermatologists, need to invest time. The biggest thing probably we can give is please invest time and think on these issues to understand the issue of leprosy, because we are the people who study leprosy. We have a complete understanding of leprosy, clinically, also pathology and all its manifestations. We only people we can, once we understand, we can find solutions. Thank you very much, and before I wind up, I invite you all to the 21st International Leprosy Congress going to be held in our city, Hyderabad, next year, November, from 9th to 11th. In fact, we have advanced by 1 day. We are going to start from 8th November to 11th November in High-Techs. Registration right now open here, just in the veranda next to that. Mr. Ajay is sitting there. Anybody interested can register. We are offering a discount registration rate around, it costs around 14,000, about 160 for physical registration, but you are offering a 13,000 discounted registration here. And now somebody wants to register online only, it's going to cost around 6,000. For this CUTICON, special discount is at 5,000. There is also special rates for postgraduates. You can look at this and probably we can avail them. I request all the members to avail this chance to register and make this a success. And also seek your cooperation in all our efforts to conduct this conference. Thank you very much for your patient hearing.
I thank Dr. P. Narasimha Rao for his crisp and lucid presentation. I think it has enlightened us a lot to think more about leprosy beyond treatment also. Thank you.
Thank you, sir. Thank you, sir. Next part we have final discussion, management challenges of leprosy by Dr. Sujay Sunita. And yeah, Dr. Sujay, he is a moderator for this session.
Sir, I also kept this paper if they ask. Okay. Just use the side.
Good afternoon, sir, and chairpersons. Thank you very much. We're going to have a panel discussion on management challenges in leprosy, case-based discussion. I request our panelists, Dr. D. Indira, Dr. P. Padmaja ma'am, Dr. P. Narasimha Rao, Dr. Colonel G.K. Prasad, Dr. K. Uday Kiran, and Dr. S. Anant Reddy to join the panel.
Yes. Thank you.
This is Dr. Indira ma'am's CV. She's Associate Professor at Usmania Medical College and Usmania General Hospital, Hyderabad. Teaching experience for 22 years. This is Dr. P. Padmaja ma'am's CV. She's Professor of DVL at Usmania Medical College, Hyderabad, with over 20 publications and presentations. Her interests are listed. This is Dr. P. Narasimha Rao's CV. He's Professor of Dermatology at Bhaskar Medical College and Coordinator for the SIG NTDs of IADVL. And his interests, we already saw, include sports. Dr. K. Uday Kiran is from Usmania University, trained in Karigiri as well as in the US in Carville Leprosy Institution, and I acknowledge that he taught me leprosy in 1984 and his area of interest is leprosy. Dr. Colonel G.K. Prasad, Professor and Head DVL at Medicity Institute of Medical Sciences and 25 publications, and he graduated from the AFMC Pune. His interests are leprosy, psoriasis, atopic dermatitis and lasers. So I welcome all the panelists to this panel discussion. Welcome to all of you and good afternoon. Can I go to the first question? What Dr. Bhumesh, and I want to thank the organizers, Dr. Bhumesh and all the team for this opportunity to moderate this panel discussion. And it is titled as case-based discussion, so I've tried as much as possible to make it a case-based scenario. A patient presented with 5 well-defined plaques on the trunk and limbs with asymmetrical nerve involvement. Slit skin smears were negative and histopathology reported as BT leprosy with a rare AFB in the dermal nerve. How would you classify this patient clinically? I want to leave it open if anyone has an opinion on this. 5 well-defined plaques, skin smears negative, histopathology, BT leprosy. Dr. Kiran, please.
Thank you. As there are 5 well-defined plaques and as there is asymmetry, even though the skin smear is negative, we have to consider it as MB, even though the histopathology is BT. So we have to treat it as an MB patient, though histopathologically it is BT, and based on the biopsy and the skin smear and the number of patches, it fits into MB MDT.
But any other opinion on that?
Well, the question says, how will you classify the patient clinically? There are 2 aspects to it. One is classification and one is management. Classification, both clinically as well as histopathologically, it remains BT. However, from the management point of view, I will treat it as with MB MDT because there is widespread involvement, nerve involvement is there, and even as per WHO recommendation, more than 5 lesions, 5 or more lesions, we treat it as MDT because the load is more, the effect is. But clinical classification will remain as BT.
Thank you, sir. Anybody else would like to say anything?
I think the NLP mentions in some of his documents that if the number of nerve trunks are 2, more than 1, it becomes MB.
MB.
So it fits into MB even by the NLEP classification also. Number of patches, and if one nerve, more than one nerve, then it becomes MB. So as per that classification, it becomes MB.
Okay. So, yes, Dr. Indira ma'am.
Ideally, we should do a lepromin test to know the spectrum. That will give us the exact whether which classification he'll fit into.
Yeah. Yeah, I think, yeah, there are two aspects here. One is classification as well as therapeutically. And I think there was both Dr. Kiran and Colonel Prasad mentioned that you tend to treat it with MBMDT. Would you agree with that or?
According to WHO, we take only slit skin smears into consideration, and the patches are 5. The nerves are 2, but this is not mentioned. When the patches are there, we take only patches into consideration. So I feel we should treat with only paucibacillary leprosy regimen.
But I think Dr. Narasimha just now mentioned that one of the documents mentions if there are nerves involved, then there is we need to take it for therapeutic purposes as MB Hansen's. Yes, ma'am.
Therapeutic purpose is more than one now means actually now we have to treat with the multibacillary only. And the patches also, if the more than 2 patches, multibacillary. But clinical classification we can keep under tuberculosis type.
Yeah. Thank you, ma'am. Okay, I think we covered this area also. Do you think the government's, yes, the government choice may be PBMDT because of the number, like Indira ma'am is saying, because of the number of patches, 5 patches, choice-wise at a field level may go in, if there is a leprosy field worker, there's a chance that he would choose the PB regimen. But understanding the disease, the extent, the number of nerves, I think it will be wise to manage this case as a MDT. Yeah. Panel, can I move to the next question, panel? Yes. The second question, a new case of BL leprosy was referred to our Center for Skin Smears this week, and the average BI was 3.5 with the highest BI of 5 in both earlobes. He is due to be married in February 2022. What will your advice be to the patient regarding marriage? I know this is kind of not directly a medical kind of question, but with implications. So does anybody have an opinion regarding, can he go ahead with his marriage in February? Yes, ma'am.
MI, sir?
Pardon?
The BI is 5+, but MI is not mentioned.
Yeah, his histopathology had solid
and more importantly, he may be impotent. I went out of my way to LA's fears on both counts. I said, you are as such a negative case. He is a tuberculoid. And I told him to go ahead, plan his marriage normally, because he's been under treatment for more than 2 years. And I said, it's
Has he been kept his marriage properly? His wife has stayed with him?
He's unmarried. He's unmarried. He's
Oh,
asking me
unmarried.
whether he can go in for marriage. And I told him, please go ahead.
Okay.
I think there is no contraindication for marriage. So, because there is no contraindication for pregnancy also. So, why should the marriage should be postponed? There is no need to that any infection diseases, person is suffering, are we stopping somebody from getting married? Tuberculosis or HIV maybe for, that is different issue. But yeah, I don't think any other infectious diseases, we are not advising them to postpone the marriage. So I don't think leprosy is one of the least infectious of nature. As rightly pointed, once you start taking treatment, and here in about 3 months' time, is going to be quite almost what should I say? All the bacilli may be dead by the time.
The other thought that came to me was that many years ago when I worked with Dr. Uday Kiran, we were looking at sperm counts in LL, and we found declining sperm counts with LL patients because of orchitis, and so therefore at that time we used to advocate early marriage and having 1 or 2 children. Yes, Dr. Narasimha Rao.
Yeah, that study was very important, and we encouraged people to get their children, and we found that people who were azoospermic did have children and did have leprosy before, and their sperm count gradually falls down over a period of years. But that usually happens if they are associated with ENL reactions. We found that there is a correlation between ENL reactions that the patient has suffered and the azoospermia. But it happened over a period of few years. How did we know? We knew when he had his leprosy, when he got married, when he got children, and when he became azoospermic. So by taking the graph into consideration, we were able to say that azoospermia does occur, but after a prolonged period only. And those who suffer ENL reactions are more at risk for such kind of a situation.
Dr. Narasimha Rao and then Dr. Anant Reddy, please.
Wonderful study, but azoospermia or normal spermia is nothing to do with marriage. Marriage is an event in life. Many azoospermic normal, for various reasons, they get married and need normal life. So
very true.
I think this is not, this is not a question to be, probably we don't need to ponder about those things. While we know as scientists, we should understand them.
Yes.
These are not to be applied to the patient.
Yeah. Thank you, Dr. Narasimha Rao. But also I consider marriage, in a marriage relationship, they also are very keen on having children.
How many times you are testing a person for his sperm count before marriage? Normally. Are we? So the point is, what is special about leprosy that we go start checking his sperm count? I don't think it has no sound basis.
Thank you. That's not a take-home message, in other words. Yeah, Dr. Anant Reddy, please.
This question, as I take it as a field man here, 2 things we have to think here. One is a stigma, other is the medical complications. When you put these questions, alternative regimen and all that, that means it is there something, clofazimine is causing black pigmentation that causes some stigma. Before marriage, as a clinician, as a field man, I always advise the people to talk with the parents, to talk with everyone. And if they agree, reveal their disease and reveal their medications. then if they agree, they can go ahead. That is field person. Second is, we have seen many patients in our experience who are taking MDT regimens as children's. That is the one thing is.
Thank you, Dr.
Sir,
Anand.
I want to add.
Dr. Indira, please. Ma'am.
So the spouse can be given single dose rifampicin. That can also help after marriage. The spouse can be given single dose rifampicin as a chemoprophylaxis. Anyway, conjugal leprosy is very rare, 5% only chance. Most of us are resistant to leprosy. Only 5% conjugal transmission will be there. And treatment of the patient himself, that will reduce the chances of transmission. Single dose of rifampicin will kill 99.9% of bacilli. So the chances are very less, and over that we can give single dose rifampicin also.
Thank you so much, ma'am. Dr. Padmaja, ma'am, would you like to say anything on other questions here? Yeah, I think the third question was on post-exposure prophylaxis with single-dose rifampicin. And
single-dose rifampicin or ROM therapy also we can give single ROM therapy. But if the patient is about to marry, which means clofazimine we can avoid because of the stigma of this pigmentation and all. Other regimens we can try.
Thank you, ma'am. We've just done 2 questions. Can I move to the third question panel? Indira, ma'am. Yes, please.
Instead of clofazimine, patient is worried about pigmentation, then we can give ofloxacin in place of clofazimine.
Okay. Thanks. Question number 3. In a recent nationwide survey carried out by SIG Leprosy, it was found that a significant number of MB patients present with post-RFT complaints to dermatologists. Some of the issues included persistent skin lesions, BI, persistent BI in smears, and reactions and neuritis. So the question is, after completion of 12 doses of MBMDT and with the above problems, what should our approach be?
I think the question was partly answered by Dr. Nasira in his talk. 12 doses for individual patient may not be sufficient. These 12 doses were intended for field work and to stop community spread.
Sir, hold the mic
closer,
sir.
Individual patients, when they come to us, have to be treated on individual basis. And what I personally do is total clinical inactivity. I treat till then. I don't stop at 12 doses. Number 1.
That's a good point. Total clinical inactivity.
Yes. And if he was positive, skin smear positive, I treat till skin smear negativity.
Yes.
At an institutional stage. I'm not talking about field.
Dr. Padmaja ma'am, and then Dr. Uday Kiran.
Actually, this 12 dose MDT in the field workers, sir, actually in a tertiary care center, I would like to continue the medication till 24 months, or otherwise BI becomes less than 2.
Yeah, thank you, Padmaja ma'am.
I agree with the panelists, and what was done in the past, keeping in view the national program and the numbers involved and the cost involved, they brought it down from 24 to 12. However, there was no obstruction to be given little more, that is 24, basing on the clinician's perception or his way of treating it. So, the 24 doses is not to be debated or found fault. But what I would like to explain here is persistent of the skin lesions in a cured case can be for many years, point 1. Point 2, BI in the smears can be positive for 10 years or 8 to 10 years. And reaction and neuritis can happen before treatment, during treatment, and up to several years after treatment. These 3 reasons need not be made important for increasing the duration. However, 12 to 24 months MDT sounds very good because the numbers have come down, money is not an issue. However, to treat him for a longer time would mean that he would be thinking that he is a patient. If a patient is taking a medicine, he will think he is a patient. So we can't, for our own reasons, we can't make him to think that he is a patient for 10 years. It may take 10 years for the skin smear to become negative. So these two things have to be weighed in its correct perspective in the interest of the patient.
Dr. Anand Reddy, I think, ma'am, did you have, and then Dr. Anand Reddy, please. No, Dr. Narasimha Rao, yes. Yes,
So
ma'am.
in majority of the cases, 12 months treatment is enough. Only we face problems with a very small percentage of cases which with all this persistence of the lesions and reactions. So for that small percent, we don't have to introduce at a WHO level. The duration need not be increased. We can individualize the treatments at our institute level. If the patients are referred to us, we can individualize the treatment. And for that small percentage, see where the BI will come down after many years. It takes many years to come down. So we don't have to treat them till negativity, because majority of the patient they do not need any further treatment.
Okay,
Only
but I want to pose a question to the panel, unrelated. I mean, do you think that the continued transmission of disease, I think Dr. Narasimha Rao, I think mentioned it, I'm not very sure in his talk, but do you think the continued transmission of leprosy in India is also related to inadequately killing the M. leprae and leaving them when they are still have a higher BI?
Yes,
is a question that we have to really think of.
Yes, sir. That's why we should pay more attention to high BMI patients. If we like more than 2, if we take more care of those patients, all patients should be, like WHO now has removed slit skin smears in its protocol, but if it is included and all the patients with more than 2, they should be followed up carefully, and if required, they should be given more duration of treatment should be increased in them.
It's interesting that you said more than 2, because there are some studies of more than 3 BI, average BI, and more than 2. And both of them say that these are the patients who are at higher risk of both relapse as well as post-MDT reactions and disability. So, Dr. Narasimha Rao and then Dr. Anand Reddy, please.
Yeah, I mean, the guidelines for this are actually not really well delineated. I think the discussion goes on. But now I think many of us who were thinking that 12 months is sufficient, now presume, like all the panelists, one way or another said that with more than 3 plus or 2 plus or 4 plus, 24 months is fine. I think that's probably one thing. But as rightly said, pointed by Dr. Kiran, that the point probably we should understand is that therapy is the first part of the management of leprosy patient, that is chemotherapy of drug therapy. The actual management of the patient should continue, and we should keep the patient under surveillance for other things, like whether it could be late reactions or disabilities or patient developing ulcers or grade 1 disability progressing into grade 2 disability. All these things are going to happen, and the drug therapy is not the end of the leprosy patient management. Leprosy patient management begins with therapy and then it continues much beyond the MDT. Of course, government is also probably looking at it. As of now, recently we published an article on this in the Derm Survey 3, which is going to come up in IADVL article. We looked at government policies. Government policy has no surveillance as of now, officially. While the patient is discharged and made RFT, the patient is told a list of things. If you find these, please come back to us. Rather than the responsibility is shifted on the patient, rather than surveillance mechanisms are done by the government. So government may have a relook at it, but as of now, the patient is educated about self-care and look for signs of activity or signs of grade 1 disability, signs of increasing our nerve function impairments. They are supposed to come back. But I think attention has to be paid by all of us many of us treat leprosy patient in our clinic, that after drug therapy is over, the patient still continues to be followed. Periodically, we ask him to come every once in 3 months.
Would you recommend every 3 months or
Yes, every
6
3 months I think is what I recommend in my clinic. Initially after post treatment maybe once in 2 months, and then 3 months, and after once it probably after a couple of years we can go for once in 6 months.
6 months, okay. Thank you. Dr. Anand, yes, Dr. Anand.
When you started MDT in 1982, we have given 14 days rifampicin daily, followed by 2 years of MDT. The relapse rates at that time is the same, and the symptoms are persisting same. After that, we started giving 24 months. Then the symptoms are the same, the relapse rates are same. Now they reduced to a year. Most of the time, the symptoms are the same, and the BI, as you know, everyone, that it takes 0.8 to 1 per year, that's it. The transmit, then that is, the symptoms always remains when you treat for 1 year or 2 years. As long as a baseline load is present in the body, these reactions are bound to come. Second thing is, now transmission, and as Narasimha sir and Indira madam, other panelists said that the surveillance, yes, when after stopping of the 12 months of the treatment, you do vigorous, or once a patient is released from treatment, do 6 months follow-up, do regular smears examination. When there is a relapse, once the smears are increasing in size, then restart whatever you want, MDT or second line of drugs. Second thing is, the patients who are transmitting the disease after 3+ or 4+, still we have chemoprophylaxis is there. We are starting now the chemoprophylaxis. Start chemoprophylaxis, the household contacts, and around 20 to 30 houses around that, you treat PEP or whatever may be, PEP plus, and that is Government of India or anyone should keep a surveillance, the program of surveillance. The contact survey should strictly be done every 6 months. Smear should be done every 6 months, or at least if smears are not possible, examine the patient at least once in 6 months and these contacts.
Thank you so much, Dr. Anand. And if you permit, we'll quickly move to question 4. A patient classified as LL was given a full course of MBMDT and BI did not fall during follow-up. Drug resistance testing revealed resistance to dapsone. Similarly, an elderly gentleman with suspected drug resistance was found to have resistance to both dapsone and rifampicin. How will you manage the first patient? What regimen will you prescribe?
The first patient can be treated with ROM. Rifampicin, ofloxacin, minocycline can be given, or because dapsone we are not giving. Clofazimine can be added also.
Daily ROM, sir?
Daily ROM.
Daily ROM.
I have given daily ROM in such cases. But then daily ROM I could give because it was free. Otherwise we can add clofazimine.
Yeah. Dr. Narasimha Rao, please.
I'd like to say a little bit, go back on this. Drug resistance to dapsone is presumed to be present in all patients as per the program. When WHO started this program in 1983, the presumption was, one of the presumptions is that why are giving 3 drugs is that dapsone resistance is widely prevalent.
Correct.
That is the reason they went for 3 drugs. So dapsone resistance itself doesn't tell you anything, that it is already existing, so we are getting other 2 drugs, clofazimine, rifampicin. So the first one probably doesn't merit so much of attention. The second one, dapsone, rifampicin merits attention. Once the resistance to dapsone, rifampicin, what we do? There is certain regimens proposed by 18 months regimen proposed by WHO for it, but few people are following it, because many times by the time we get rifampicin resistant, the patient is already finishes, or we only suspect it after he completes MDT. But technically there is a regimen recommended by WHO on it for those patients.
Will you spell it out?
I think the 6 months of intense therapy with 3 drugs, minocycline, clarithromycin, and rifampicin, I think. and if I'm right, not rifampicin, no, ofloxacin.
Choice.
Clofazimine. And yes. After that, I think we have to go for other substitute, because I'm not remembering it because I hardly ever practiced. I mean, only very few people practice it, because very, very high intense therapy. Even one more thing I want to tell you is, even Government of India is not practicing it. And Government of India is not even advocating it as of now. Frankly, the guidelines how to manage rifampicin resistant suspected patients is not there in the program. Probably somebody should look at it. And also, lastly, I'll say one more word. The regimen proposed, this 18 months regimen, is purely theoretical regimen proposed in 1998 in the WHO technical manual of 1998. Why it was proposed, the basis is not at all given. It's just a very empirical one. So somebody has to look at it seriously whether really it works. Whether we really need such an intensive one for 18 months.
Dr. Narasimha Rao and other panelists also, do you have in your experience found any other alternative regimen or alternative drug very useful in a suspected case of drug resistance? Any of you have used any drug to good effect without much side effects? Dr. Indira ma'am. Yeah, okay. Padmaja ma'am.
Not the resistance, but the dapsone sensitivity also we can try for the ROM therapy, daily ROM therapy also.
Okay, thank you. Indira ma'am, you had something?
I have tried ROM-C therapy, monthly doses, only monthly doses, along with MDT, in a naive case, untreated case, and I found very good results. It was a case of BL with extensive lesions, multiple lesions, and
so you gave MDT. So you gave MDT as well as pulse ROM.
Once a month ROM-C.
You gave along with MDT. You gave pulse ROM.
ROM-C with clarithromycin.
Has anybody else used such a regimen?
I would like to just comment here. See, all of them are right. All of them are competent dermatologists who like to give additional drugs. Also, in my talk I was right, there is no standard regimen.
Yes.
There is no directive or there is no recommendations, because the lack of recommendations is making everybody, somebody gives ROM once in a month, somebody gives ROM every day. Somebody like me will start a 4th drug. I prefer to start with 3 drugs. I start daily rifampicin. I continue 4 drugs for 12 months in the case of suspected rifampicin. I found that such a regimen will give better result.
But
the point is, as long as you are a competent clinician, you are a qualified nephrologist, you can go beyond MDT.
But I brought up that point, Narasimha Rao, because you yourself said that Government of India 18-month regimen is too heavy, and therefore there is a need for alternatives. So all of you are excellent dermatologists and treating leprosy, so I took that freedom to ask you that opinion of any other experience with other drugs.
Opinions, I mean, will come probably. I think we have to, somebody has to study it in a controlled situation to find and record the results and come out with evidence how it is working. That's what I was trying to say.
Thank you. Okay, Chairman, sir, how much time do we have? Another 10 minutes? 10 minutes, okay. A patient diagnosed as LL Hansen's with a BI of 4+ in 2007 completed MDT and was RFT'd in 2009. Patient came back with complaints of tightening of skin and clawing of both hands. Smears were negative, chest X-ray, PFT, barium swallow were normal. ANA was negative and patient had thickening of skin over extremities and abdomen, difficulty to retract lower eyelid. GERD symptoms were also present. And this is a case presented by Dr. Indira ma'am. So I'll ask her to describe this case. These are the clinical photographs. Would you like to say anything else? I'll ask Dr. Indira ma'am to say that.
Yes, this patient initially came. He was a defaulter initially, but later he completed the treatment. Initially, he did not have any other, only he was a leprosy case, no other symptoms or signs of systemic sclerosis. But later when he came, after many years, he has developed tightening of the skin, only mainly on the extensor aspects of the arm and chest and eye, face. And he has no other symptoms like Raynaud's phenomena or any other symptoms. And investigation wise also, he had mild GERD, except for that, there are no symptoms. But when we took history again, when we went back and asked, he said initially, at the beginning of the disease, he gave something suggestive of Raynaud's phenomena. But otherwise, he was, no other symptoms are there.
So what will your question be to your co-panelists, ma'am? Okay.
Not only the one case, sir. Actually, we reported 2-3 cases like this. Actually, a completion of the MD-MDT patient. After that, they came with the sclerosis of the hands and other thing. And after biopsy, that's a more histopathologically it is coming as a sclerosis or the morphia like that. Underlying.
So, Dr. Indira, again back. What will your question be to your panelists?
Actually, ANF.
Tightening, is it reported with leprosy alone?
Any other question?
There are reports in the literature saying that it is mistaken for systemic sclerosis because of the acral symptoms, acral sclerosis and absorption of the fingers. It was mistaken for systemic sclerosis. But as such, leprosy and systemic sclerosis is not mentioned. Combination is not mentioned.
So
it can be due to autoantibodies. There are many autoantibodies like we know SLE, DSD and ANA and all are known to occur in leprosy.
Okay.
Maybe that has a role.
May I ask you a question, please?
ANA profile is negative, sir. What is the opinion, sir, Dr. Nasim?
May I ask you a question, please?
I don't think we should, I mean, two diseases can occur in one individual. That is one possibility. So, because Usmania is such a tertiary care referral center, all complicated cases only end up there. Maybe a patient developing sclerosis, acral sclerosis, or scleroderma-like features in a patient leprosy. That's probably we should consider as it is. We need not try to find a relationship between these two. Second thing, if you want to find relationship, yes, the patient will get reaction hand or recurrent type 1 reactions. Probably some people can end up with sclerosis. But if you get ENLs, actually you will end up with enotoderma in loose skin rather than tight skin. But only reaction hand you may get a sclerosis. Whereas in other conditions you actually get a loose things or Buddha ear lobes. That is happens with the ENL. So I don't think, as long as I think we should take it the case as it is. Probably investigate for incipient scleroderma in these patients. Yeah.
So what was the? May I ask a question, please?
No, not necessarily. I mean, probably we have some form of first cases or cases in the transient.
Dr. Sujay, can you ask a question, please?
Yes.
What is the occupation of the patient?
One is a female, sir, actually housemaker.
Okay.
And this person actually some laborer or something.
Okay. No, whether he was working in a polyvinyl chloride industry or
no, not like that, sir. We inquired for all the things, sir, actually occupation and all.
Okay. Pseudoscleroderma was
pseudoscleroderma ruled out, sir.
Can I, now that the session is coming to a close, I had 2-3 more questions, but if there is 1 or 2 questions from the audience to the panel, are you willing to take 1 question from the audience, 1 or 2? And then we'll close the session. Any question from the audience, please? Okay. Any word, pardon? Continue. In the last 3 years, more than 50 patients with signs and symptoms of peripheral neuropathy and no skin lesions were referred to our center with a clinical suspicion of PNL for investigations. Are you seeing an increase in patients with these symptoms? Or so is it a part of a changing profile of the disease? I want to just ask the panel whether the cases that I'm seeing is usual or it's unusual. Are you also seeing any PNL cases in your departments?
Actually, we We did ultrasound for these nerves studies, sir. Actually, there's one PG is took up the thesis like this, pure neurotic type of leprosy with before the treatment. Ultrasound is, we can, to some extent, we can see, but clinically, actually we cannot find out the bacilli and all the things, sensations.
So you are you seeing more cases like this? No, you're not seeing.
We have not observed. It's like in the same.
It's
like
a usual.
we used to see pure neural, like quite a number of cases. The same is continuing.
Yeah, okay, fine. And I think Padmaja ma'am talked about ultrasonography. Does any of the panelists have any other way that we can investigate PNL?
Couple of cases, I know some very close people with
Sir,
similar
talk into the mic,
with similar peripheral neuropathy. No clinical signs other than neuropathy, and then the neurologist went in for a sural nerve biopsy, reported as vasculitic autoimmune polyneuropathy, and is now being treated not with ALT but being treated with mycophenolate mofetil and steroids. So these cases also have to be kept in mind. Just because he's got mononeuritis multiplex and pure neurotic leprosy, we cannot label all of them as pure neurotic leprosy without a nerve biopsy, at least. That's what I feel.
But my question to you, sir, do you think that sural nerve biopsy was the last word on that case?
No.
In the sense because it could be a lateral popliteal nerve involvement and you can't biopsy that, so you do sural believing it will reflect leprosy. But can you also miss...
Two biopsies were done.
Two biopsies.
They did sural nerve and also I think either popliteal or radial nerve was done. Radial cutaneous.
Thank you, sir. Any other comment on that? Or? Anant Reddy, sir.
I think neurologists attribute mononeuritis and more to vasculitis, in their opinion, because they see a lot of vasculitis cases presenting as mononeuritis. For dermatologists, when patients who come to us, mononeuritis or mononeuritis multiplex is more leprosy. So, and unfortunately, the biopsy findings of vasculitis and leprosy also overlap a bit unless they are doing a special stain for leprobacillus. So there is a bit of confusion there, unless that's why probably suggests clinical correlation. The pathologist always writes there. So probably we should always in such cases always ask them to go for a special stain for leprobacilli.
Yes. Dr. Anant Reddy.
Diagnosis by exclusion. It's by exclusion, but nowadays we have good modalities like treatment, investigations like ultrasound and nerve biopsy and EMNG, they all help us.
Yeah.
It's basically a diagnosis by exclusion.
Yeah. Thank you. Thank you, panelists, for this. Any other comments from the panelists? Would you like to give a closing comments to the audience, or any one take-home message from each of you?
Yes, I would like to say that when you want to consider a case as resistance or a regimen to be not effective, it would be necessary to think that it is not the persistence of the lesions or neuritis or the BI, but what one should look at the relapse rate. So the relapse rate, if you can calculate, that is a gold standard for the efficacy of that particular regimen.
Yes, I think I have an objection to you, Dr. Kiran. See, when we looked at 45 years later a relapse, you know, it's very difficult to base your success based on that a regime was successful 45 years later. So I think we need to look for closer markers to say that this regimen is effective to kill M. leprae. This regimen is effective to clinically treat leprosy? Because when we treated 4 million in the world, it was okay to look at a relapse rate 5 years, 10 years down the line. But today I think we have more molecular tools where we can say right now, is this drug working for the patient? And so I think there should be a balance between relapse rate and more modern tools.
I totally agree with you. There is no confusion in that. But I was just thinking of a situation where, going away from leprosy, if you see typhoid, you know, you treat typhoid, yes, it gets cured, but there is a subclinical or carrier state or something, and there is about 10% or 20% of relapse of the typhoid. But that doesn't hamper you from stopping the regime at a particular point of time.
Yeah.
When you come to relapses in leprosy, they are so low. And if you think in the last 25 years, if our regimens were not as good as they were supposed to be, that I would have seen too many relapse cases. This is just my thinking offhand.
Excuse me,
Yeah,
sir.
thank you.
One last query from my end. Actually, recently I was faced with the same dilemma. Actually, I've been consulted by a pediatric patient of age around 12 years, and just seen a P. alba type of lesion, but I have noticed some granulomatous skin changes. So luckily I did a biopsy and it was showing some perivascular and perineuritic that infiltration, and then I started on multibacillary leprosy, seeing the thickness of that nerves on the neck, greater ocular nerve thickening. Then I was again queried by the patient's attendant. Sir, actually the two diagnoses were given for the biopsy report. One was saying it as a probable leprosy, and one was giving it as a chronic inflammatory infiltrate. So why did you start my child on a multibacillary leprosy treatment instead of making other standard diagnostic techniques? So even they asked the slide for cross verification, and which I usually not encouraged, but still they might have approached and sent it for a cross verification for the slide.
Thank you. Would anybody like one answer to that question, and then we'll close the session. Chairman, sir, we'll close after that answer.
I think it's a difficult situation like that happens, but best thing is that you have done biopsy. Had we started the treatment without biopsy, problem would have been more. But you have taken the biopsy, and biopsy gives an opinion based on which you started. Yes, there can be, the biopsy always stays at the end for suggested clinical correlation. You have correlated the clinical finding with the biopsy, which is in suggestive of Hansen's. Maybe whether you start at PB or MB is probably, that's probably one question, probably you thought wise to start MB. I think it is fine. I think there may be some questions. If they want second opinion, they can always take it. You can always stop at that level and say, you go for a second opinion, come back to me. I think we should always try to handle this patient with carefully with kid gloves, because that kind of tension is always there with the patient. Especially in private practice, we should always think twice. If you want, you can always take other opinion. Fine. I think these things happen. I think we need to manage. We need to learn to manage these things. But I think you are on the right track. That's my
legally,
comment.
if I start on my MB treatment, is it okay because he is a child, and if it is a female also, should I add clofazimine?
No. If the single patch is there, probably unless the PI is positive, probably PB would have been fine. That's
Now thickening is noted actually, but
one now thickening is
subjective.
fine. That's
Okay.
what. So looking at it, in child mostly single patch PB is sufficient unless it is a floral lepromatous leprosy.
And one fast query. Actually, one
PB.
of my
No. One now, one patch. Fine. That's it. No. More than 2 thickened nerves. 2 or more thickened nerves is the criteria. 2 or more thickened nerves with 5. No. For PB case. PB. Yeah.
one of my colleague father also has faced foot drop, and he was diagnosed. He was sent to me for cross verification, whether you can consider it as a pure neurotic Hansen's or something by a neurosurgeon. But even I accepted genuinely that I couldn't find any symptoms of Hansen's in this case. And I know him, as per his social profile also, I haven't suspected Hansen's, actually he is close to me. So in that case, can we proceed with nerve biopsy since already there is a foot drop, and is it advisable and how far is it judgmental? I mean,
If I can, the foot drop, the nerve biopsy is done for sural nerve.
Sural
it has
nerve.
nothing to do with foot drop. I mean, it won't aggravate foot drop. You can always go for it. And also, please don't, social status has nothing to do with leprosy. Okay.
I already noted.
I think, yeah. Thank you.
Thank you.
Thank you. Thank you to all the thank you chairpersons for this opportunity, and thank you all the panelists for being such amazing panel, answering the panel's questions. And thank you to all of you attentive audience, and thank you to the organizers for this focus session on leprosy. Thank you.
Thank you, Dr. Sunita, and all the panelists for the valuable input about various aspects of leprosy. Thank you.
Thank you, sir.
Now we'll move on to the next session, 7, on panel discussion, fight the topical steroid misuse. I would like to invite the chairpersons, Dr. G. Sukumar Reddy and Dr. K. Lakshmi Narayana onto the dais, please.
Good afternoon, and I welcome you all for this panel discussion, Topical Steroid Misuse, Present and Future. And I call upon Dr. Rajda Damashetty to the dais for this moderation of this panel discussion.
Yeah, please. Which one?
Topical steroid. No. Where is it? This one. Yeah, okay, you can project it. Good afternoon, dear chairpersons, seniors, faculty members, friends, and representatives of the pharma people who I see lurking behind. So, may I invite my esteemed panelists, starting in the order of seniority, Dr. Putta Srinivas, Dr. P. Narasimha Rao, former National President of IADVL, Dr. Manjunath Chennai, Dr. P. Navneeta Reddy, and our guest faculty for today, Dr. S. Srikant Bhatt, who is a pediatrician, to please come over to the dais. And may I request all those backbenchers to come in front. You can be a backbencher sitting in the front row as well. I have been one. I am at heart a backbencher, but I always sat in front because I was too naughty to be allowed to sit behind. So, would you all indulge me, please, by coming forward? Am I audible right behind? Yes, please, that's the way. Right in front. Thank you so much. Would the chairpersons do the honors of doing the introductions of the illustrious panel? No need. Dr. Narasimha Rao says okay. Dr. Srikant, thank you so much for being with us. Dr. Srikant is the professor of pediatrics in the recently started Siddipet Medical College. Sorry, Suryapet Medical College, and apparently he's a colleague of Dr. Bhumesh. He's very keenly interested in stemming topical steroid abuse, which is why he's decided to honor us with his presence. And Dr. Navneeta is not as well known, but she's a rising star, and she is also very, very keenly interested in joining this crusade. The other three, of course, need absolutely no introduction. I hate cliches, but this is no cliche here. Dr. Putta Srinivas, Dr. P. Narasimha Rao, and Dr. Manjunath Chennai truly need no introduction. Now I see why they say that South Indians are shy. In spite of such repeated appeals, still I see people right behind. Now, if you are pharma people, I personally don't mind you all coming in front, and if you think you don't belong, you may leave the hall. Is that okay, sir? PNR, sir? Yeah. because when there are seats in front, somehow it is not nice to leave them. So over the next 30 minutes, the chairpersons, do I have 30 minutes, sir? So I am hoping to take you all, oh, sorry, I forgot the mask, removing the mask, it's become such a habit. Over the next 30 minutes, I thought I'll begin with setting the context and then taking you all through these bullet points. So I'm going to jump right in. These are rather recent publications spearheaded by former chairperson of ITATSA, Dr. Shyam Verma, and very dear colleagues who've written extensively about what changed the genotype of our very familiar trichophyton. So trichophyton rubrum was something that was leading for decades, and suddenly trichophyton mentagrophytes crept up, and now we have exported this as far as Bahrain and Germany as well. So this second paper here speaks about how a Bahrain family was holidaying in Germany and their infant was found to have the type 8 Indian type with the extended ITS genotype, and we understand that topical steroid abuse has some role to play in the transformation of this genotype. And I'm going to go back to Dr. Manjunath Shenoy for his expert opinion on the fungal transformation. So we call this the current Indian epidemic, which predated the global pandemic of COVID-19. And when we come to the magnitude of topical steroid damage phases, in this landmark study that was initiated by IADVL, it was found that 90% of people who were abusing steroids on the face were using either potent or super potent steroids, which is a huge tragedy. And it was found that around 60% of them did not have any sort of prescription. I am not talking about valid prescription which is time sensitive. I am talking about any prescription at all. That means they bought it at the behest of either the person at the point of sale. We cannot call them pharmacists because many of them do not possess a degree in pharmaceutical science, or they either listen to their servant maid or friend or beautician or things like that. So, and it was also found that 90% of these people who were using steroids on the face indiscriminately were suffering from adverse events. So you can imagine the magnitude of the problem of topical steroid abuse. So, and this one product here, and this is something that is unique to India, this one product made 270 crores in 2018 before the COCATE committee had banned it. Now, of course, it is back in the market, and you might wonder why we are so unique that we have mometazone containing modified Kligman's regimen. Is it because of some kind of a trial in India that showed that Indians are very thick-skinned? We are thick-skinned, no doubt, but do we have evidence to say that we tolerate mometazone furoate containing modified Kligman better than others? No. It happened because mid-level drug controller in Pondicherry way back in 2005 decided to give a manufacturing license without a marketing license being given by the Drug Controller General of India. So this started, this manufacture and this menace started very sadly for me, because Pondicherry is where my alma mater JIPMA is located. So it started with a permission there. Now strangely in India, if you want to prepare a new drug formulation, you don't have to get permission. Of course, legally you should, but you can go to any local drug controller and somebody who's done maybe a BSc, and you know how to get them to give permissions. All of us know in India how things are done in our bureaucracy, and they got this permission, and then this went on to become a huge brand. Not Nepal, not Bangladesh, not Sri Lanka, not even Pakistan have a mometazone containing formulation. We are unique and we are ashamed of this. Now this was another huge bestseller, a brand which made around 200 crores or so, give or take a few, and it was banned by the COCATE committee in 2016. And then what happened? Then our very innovative pharma industry, in case those behind, I can't quite see them, in case you belong to the pharma industry, feel proud of this. You are so innovative that you decided to replace the plus, which was representing the CUT combination, the clotrimazole, ofloxacin, ornidazole, and terbinafine, with the Panderm NM plus, which is just one molecule less. And now, of course, we are fighting the itraconazole menace. So itraconazole, clobetasol combinations are abundant in the market, and again I'm going to go to the seniors, particularly Dr. Manjunath Shenoy, about his opinions about what itraconazole in the topical form in combination with a super potent steroid like clobetasol can do to our patients' skin and tinea. So this is how the situation stands as of now. And this is a very recent paper. So on one side, we are struggling to give a name to the Frankenstein monster that we have created. So I'm going to move on from the background to asking our elite panel, what makes one a rational topical steroid prescriber? And I'm going to start with the former president, PNR sir.
One is, I think, Bhumesh Kumar declares us, first of all, I think we became rational. So that is one thing, just a pun intended. But the point is that, yes, I think every dermatologist has his own rationale how they prescribe steroids. Yes, there are a number of us, unfortunately, who also prescribe steroid antifungal combinations right now, today, yesterday, and tomorrow. They have their own reasoning, they have their own rationale. But as a body, as a president, past president, when I was, at the helm of the affairs, we used to, only thing we can do is educate them to prescribe less, don't prescribe wrong formulations, try to avoid steroid antifungal combinations as much as possible, and also stop steroid usage on the face and the sensitive areas. So as to put the answer in one line, I think the dermatologists have to be rational in their prescription of steroids. We can only advise them, we can't force them to do, and we can't prescribe them any particular model except by trying to educate them about the harm which can be caused by the irrational combinations. Thank you.
Now, I know that PNR sir was always talking about cleaning our own house before we pointed fingers. I know this has been his pet passion, and it's sad that some of us have to claim that we are rational topical steroid prescribers when every single dermatologist should be one. So I'm going to go to Putta Srinivas sir. Sir, you've been a teacher, you've been a DME, you've been held very high positions. So do you think the average dermatologist of today is a rational steroid prescriber, very honestly?
I think the answer lies in the generation of dermatologists basically. The classical teaching was that there is no role for the steroid to be combined with antifungal as such, unless some area which is got to eczematous and all that. Otherwise, there is no role for antifungal to be combined with steroids. Coming to steroids and the molecules, see, we used to have the molecule which is mild potent, moderate potent and all that. But at every prescriber or a dermatologist must decide what lesion for he is prescribing. Is it a dry lesion? Is it a wet lesion? And how long to give? And what type of steroid? Sometimes small overlooking points can have adverse effects. For example, flutivate, fluorosilicilamide has got ointment and cream. Cream is different class, ointment is different class. Similarly, mometasone furoate, Momate or whatever it is, a brand name. Momate cream is a different class, Momate ointment is a higher class. So these type of small differences we all have to note. To prescribe rationally, choose the proper steroid, correct condition, correct indication, and duration of treatment and amount of application also equally important. Just you can't just saying the prescribing the ointment or a cream of a steroid, ask them to apply, leaves them at the mercy of the chemist, at the mercy of pharmacist. Many times I see patients asking the chemist how to use, how long to use, and the frequency of application, amount of application. So unless we as dermatologists spare time to tell this quantity, like the fingertip unit, how much it contains, on the face, how many fingertips, on the legs, on the hands, on the lesion, should be explicitly informed by the dermatologist himself. So he should not be at the mercy of the pharmacist or internet to assume and follow whatever they like. Then the quantity. And nowadays we get, family packs like, toothpaste and shaving creams. You get 30 grams pack, you get 50 grams pack. No wonder for them it's a business. But for the dermatologist, you must specify how long to use and how many packs, 10 grams, is it a 5 grams tube, 10 grams tube, and how many to be purchased. And most important is when to stop or when to have review also. Many a times, patient feels better after 4 weeks or so, then he will try to use the same medicine forever. So this can be reduced only by proper counseling by the dermatologist to the patient that I am giving a so-and-so steroid, this so-and-so potency. At the end of 4 weeks, you will have definitely relief, but you should not continue this further. I have to reduce the potency of steroid to a much milder variety before tapering out to which much milder variety. These 2 points should be informed by the dermatologist himself.
Thank you so much, sir.
And one small word. See, we have to balance between steroid misuses and also steroid phobia. It has to be balanced. We have 2 types of people who are over anxious or not bothered at all. So some people maybe they see the net and they see their neighbors and they say, don't prescribe steroids. That's also not correct. We have to balance between the real fears and unnecessary apprehensions about steroids, which are safer drugs. Topical steroids are much safer compared to systemic steroids. The margin of safety is higher in topical steroids, but provided to the condition that it should be adhered to the period of prescription, the duration of prescription, the amount of prescription, and the condition to be followed as told by the dermatologist. Thank you.
Thank you, sir. So I'm going to discuss steroid phobia in a little bit, depending on the time available. And ITATSA has always fought naysayers within our fraternity because many of us have been accused of propagating steroid phobia. And I have seen steroid abuse and steroid phobia in the same family. So I once had a patient who's been using Betnavate for her facial rosacea for almost a decade, and when I had to give her son a prescription for fluticasone, she was like, this is a steroid, doctor. So, you will have to talk them out. Now I'm going to go to Dr. Manjunath Shenoy, who's also a very illustrious professor in addition to the being the former head of ITAT and the amazing work he's done on fungal infections in India speaks for itself. So as a teacher, how do you teach your postgraduate students to be rational prescribers, Dr. Shenoy?
Yeah, thank you, Dr. Rajita, for wonderfully setting the context in very brief word. There are 2 major epidemics which we are facing in the last 10 years. One is topical steroid deformed face and other parts of the body, and topical steroid modified tinea, which are interrelated to each other. Now, coming to this question, what makes one rational topical steroid prescriber? Now, I just modify the question, who can prescribe steroid? If that is the question, it would have been MBBS. Anybody having MBBS can prescribe a steroid, anything from hydrocortisone to clobetasol. Now, the thing is, our teaching is so poor in undergraduate level at MBBS regarding what is hydrocortisone, clobetasol, other than dermatology, I think this knowledge is very much meager. Even in dermatologists, after periods of practice, probably we also, unless we keep on update then. So what we can do for the students is, what I teach is, there are 3 I's I teach them. This, I think, itself will speak. Number 1 is indication. So does this particular condition requires a topical corticosteroid? It could be an approved, or at least it could be off-label. For example, in a xerotic in winter, you can manage it with just moisturizer, unless there is a frank eczema. So, but still, to give a quick relief, probably somebody could use a clobetasol or a combination of clobetasol moisturizer. I feel it's irrational. We just need to counsel them a little better, saying that it would take a little longer time, but keep using a moisturizer. So that is a rational indication. Irrational becomes when we unwantedly use a topical corticosteroid. That's one indication. Number 2 is an instruction. Have I given sufficient instruction to the patient? How much to use? When I know that there is a case of psoriasis, there is a case of eczema, how much to use? Have I told them you should not exceed 50 gram per week? That's this thing. So these are the conditions to second thing. Have I given sufficient? And number 3, when it comes for follow-up, have I looked for the adverse effects? That means the third I is investigation. Have I examined him properly? Have I look for adverse effects that has happened? Have I, if required, sometimes, many a times you tell many things, but patients often tend to use excessive steroid. That is our experience. We have seen it. So these 3 things, if I followed, I think I am a rational topical corticosteroid prescriber, and this is what I teach my students.
A wonderful answer. Now, on that note, when would you suggest a 8 AM cortisol assay for somebody you think has been using way too much topical steroids?
I think you took up this topic because I was involved in one of the trials, clinical trial, wherein topical corticosteroid efficacy in, it was a phase 2B trial, clobetasol versus clobetasol in lower concentration, 0.025. Currently it's available in India. It's marketed in India by one of the pharma companies. Indeed, I was surprised to see, because it's a blinded study, I didn't know which is 0.05, which is 0.025, probably in both the groups. Even after within 10 to 14 days of using clobetasol propionate in the recommended concentration, that is 50 gram within a week, at least 20 to 30% of them had a decline in the early morning the serum cortisol levels. So that means, of course, they recovered. In fact, post-co-syntropin test, that is after giving ACTH, in fact, many of the patients did not respond. That means their HP axis was already suppressed. So even with the topical corticosteroid used in a recommended dosage, even that could produce suppression in HP axis. So which means, I think we need to have the red flag continuously, flying high when I prescribe a clobetasol kind of preparation. That means potent corticosteroid. So which means, I think anybody who has used beyond what we are recommended, so definitely conditions like psoriasis, eczema, they definitely need to be used for months together, sometimes years together, they keep using it. Although we try to substitute in between with the, say, calcium, vitamin D analog or things like that, it doesn't often, because patients' follow-up is not so good as it should be. So it just does happen. So in such patients where they have used excessively beyond 50 gram, I think we should indicate and tell them, see what's happened. So I think that's a good thing, but yes, it involves cost.
So, friends, Dr. Shenoy has made 2 very important points. One is monitoring and ensuring that you do not exceed 50 gram per week of potent topical steroid like clobetasol, and also keeping your antenna and your suspicion high for suppression of cortisol and HP axis even within the recommended doses. So, I'm going to share with you a small tale. This is courtesy a dear friend from Chennai, Dr. Shweta Rahul. So, Shweta was called to the ICU to help a patient who was in a coma, and this patient had skin lesions. For internists and sad to say probably pediatricians as well, skin lesions are skin lesions. They're not quite sure whether it's eczema or a tinea or a psoriasis, and a lot of my friends still say, what do? You all prescribe steroids all day long, when we are trying to fight that myth. So then she realized, so this person was actually in a Addisonian crisis because he had acanthosis nigricans. Some guy in a pharmacy gave him a clobetasol containing thing for the underarm, so he started using it. Then he developed tinea, and then he started using the same thing because obviously the clobetasol, the quadruple combination, the CUT combination, I don't know which brand it was, helped relieve his symptoms. And when he started using one tube every other day, which is basically 20 grams in 2 days. So in a week he was using 70 grams or so, and he did this for almost 6 years. And then he went to somebody like us. He went to a good dermatologist. And then this good dermatologist told him to stop the topical steroid combination, which any of us would do. And then this man went into Addisonian crisis and ended up in the ICU. So this is a tale that I learned a lot from, and I hope you will take away as well. So what are the telltale signs here? Those broad livid striae of Cushing syndrome. So those are the giveaway. So remember, friends, that topical steroids can cause major systemic side effects, like Dr. Shenoy rightly pointed out, even if it is within the recommended dose, if it is for prolonged period. So don't hesitate to refer to an endocrinologist, to do a 8 AM cortisol, or even refer for a ACTH stimulated test. So these are the host of articles that speak about the iatrogenic Cushing's because of topical preparations. I'm not going to read all of those, but it is not as rare as we think it is. And now I'm going to go to Dr. Navneeta, who's been sitting quiet all this while. Dr. Navneeta, I know that you are a faculty member in a medical college. So when you teach your PGs, do you all talk about the fingertip unit?
Yeah, definitely, ma'am. Actually, we'll consider age also. Age of the patient and weight and educational background also. So we literally show them how to, and we ask after prescription, we ask the patient to get the medicines, and we'll show them where to apply, how to apply, and depending on the
So what I do is, I don't wait for them to buy the tube and come. I have some moisturizer or something, and I use it to just demonstrate. Now, I realize that I am still in slide 12. I have 76 slides and obviously not that much time. So I'm going to go a little faster. So if there are any PGs at all here, I suggest you either look up Wolverton or take a picture of this. This talks about the maximum amount of steroid to be used per part, per week, or per month. So make sure you talk about that. And this is the quantity in children. I'm going to go to Dr. Butt here. And Dr. Srikanth, would you tell us what are the challenges a typical pediatrician faces when they deal with skin problems? I'm going to go back to a very basic, not about steroids or anything.
Good afternoon, everyone, and I thank organizing committee for giving me this opportunity. Particularly coming to children, as all have mentioned, now the problem is simple. Day one, the mother or grandmothers identify from day one of neonate, the mother or grandmother identifies even small dot as something abnormal, which are physiological to us. They want some medication for that. Like majority, what happens, some medication they'll get through, like you mentioned, like OTC counters, many prescriptions are available, and their family members, relatives, whatever they mentioned, whatever they have used, they will apply the same thing on the same children. So, which is a practical problem. And coming to sometimes, like in infant also we see scabies, which is majority of doctors may not identify. Sometimes they apply all the whatever should not be done, they'll do everything and they'll come to us. Then again, proper history only will give us a clue of regarding that particular scabies or any condition like that. And hypopigmented patches also, which are very common in infant age group. Many irrational ointments or whatever is available in market, they'll be applied. So overall, coming to pediatric conditions, pediatric dermatosis, which is atopic dermatitis, which is more common with lifestyle, and so many medications are used. There are also like chronically, even the treating physician also sometimes may not have high index of suspicion that whatever treatment we are giving, will it cause some adverse effects with the treatment also. So these points should be like kept in mind as a pediatrician. And I want to, that first slide reminds me that in even IAP, Indian Academy of Pediatrics, we are using this rational antibiotic prescriber, like rational steroid prescriber, we are bringing more awareness of this irrational use of antibiotics combination. And like pediatric cases, these scenarios we see.
So if I may sum it up, a diagnostic challenge when it comes to pediatric dermatosis.
True, madam. Both undiagnosed and misdiagnosis. Both things happen.
So do you think that if we teach our undergrads better about how to diagnose what is common and what is uncommon and undiagnosable, refer of course, and if we can teach them what steroid is super potent, what is mild, what is okay for an infant, do you think that will make sense?
Definitely. This majority of physicians or pediatricians, they don't know the classification of steroids, which is class 1, class 2, very potent or mild potent. Majority, whatever like these medical pharma people or whatever they come with this product, they'll prescribe. And classification is also majority of doctors. I think they don't know, and they don't classify also before prescribing, they don't classify, and they don't think about the adverse effects of those particular steroids also.
So I personally think that if we can teach people, if they're not sure whether it's tinea or eczema, giving a trial of a plain antifungal and then referring, would it?
No, no.
It's a oversimplified thing probably.
It should not be. Like antifungal, better emollients can be used. At least they can take, they can buy some time by prescribing emollients or any mass.
And refer, of course. So this is a patient information.
Rajita,
yes, please.
I just wanted to add one thing. Last
Yes,
time
please.
during, I think, PNR sirs only, in the IADVL UG classes, in fact, topical steroid chapter was added separately. And in deemed university like mine, it was very easy to upgrade the curriculum. In fact, in the curriculum, for 1 hour, we have exclusively kept for topical corticosteroids. That's one thing which has been implemented with the efforts of IADVL. I think it's easy in a deemed university because we can directly interact, but it may be for a larger state universities, it may be. Sir, you can put a word on this.
Yeah, I think I agree that, most of the UG curriculum, undergraduates or general medicine or pediatrics, PGs, they are not aware of the importance of the grades of potency of steroids and its impact on the usage also. So that thing we need to focus in those areas.
So improving the curriculum, and 1 hour might not seem like a lot, but when total undergrad teaching curriculum is what, 20, 30 years?
30 hours theory class. And
30 hours out of
6 weeks of clinical postings.
So if we can increase that, then I'm sure it will make some difference. Now this is a patient instruction handout from Dwalverton. Obviously there's no way we can make our patients read this unless they Google it themselves. If you give it as homework, they're not going to do it. Yes, please.
Second. Recently the NMC has introduced what is called CBM, that is competency based medical. Unfortunately that chapter is missing. In fact, that should be a competency for them to recognize which is potent and which is low potent. That I think would make a lot of sense.
And diagnose basic things like scabies and tinea and eczema?
They are already there. They are already there,
Yes.
obviously.
So what I personally do, because I cannot give these handouts to my patients and make them read, I just have a seal which says, steroid cream do not use beyond prescribed duration. This takes me like 2 seconds, and I would suggest that all of you adopt this. Now, I don't think we have much time. The chair, how much time do we have, sir? Done? Close? Okay. So, okay, I'm going to take maybe 3 minutes extra with the permission of the chair. So, I'm going to go back to Narasimha Rao, sir. So, how do we make these awareness activities meaningful and effective? Because what we see is, yes, in our WhatsApp groups, there's a lot of awareness. But when it comes to general public or even other specialities or even people who sit in the pharmacies, is this awareness creeping till there?
Yeah, because of the efforts of ITATSA and all of you from 2013 onwards, I think from 2016 and 2019. Actually, when I was, I think in 2020, I gave a small presentation for which I was trying to get information from pharma. pharma industry in 2020, February told me that the sales of the commonest steroid drugs have dropped by 10 to 20% compared to 2018 by 2020. They have attributed it to the public awareness campaigns IADVL and other bodies have launched. So what we did was that we are not only trying to educate our own colleagues, but also trying to educate other branches like pediatricians, gynecology, general physicians, and also rural medical practitioners. In 2019, I think more than 50 such interactions are, well, maybe 100
300 plus, I believe, sir.
300 interactions were done.
250, 300.
And also we had radio, I think Radio Mirchi and I think we had small 2 minutes announcements, like two people talking and conversing how they should avoid. And of course we also got videos made for YouTube. They had good number of hits, but I think we can only do these things by bringing in public awareness, number one. Number two, awareness to our colleagues. Number three, wonderful thing which you're talking about, awareness among the students, adding in the curriculum, and probably periodic CMEs to educate ourselves about the potency, dosages, schedules, and the ranges, and how we can avoid, and what are the, in case we find them, how to correct them, how to re-educating ourselves. I think, but education is the only way by which we can dissipate the knowledge, and I think so. I think, but people are receptive to it. What I found is that we are thinking they are not receptive is wrong. They will understand once we tell them. Maybe we have to tell them repeatedly, not twice, maybe 3 times, 4 times. Yes, thank you.
No, even the RMPs, the non-MBBS people, when they are told that this can cause harm, then they are actually not going to say that, you know, I will prescribe a combination, they are ready to switch provided we teach them. Yeah, now, this is something that was shared by Dr. Navneeta. Would you very briefly tell us, and this is going to be the last slide for discussion.
Actually, it was challenging for us to diagnose, ma'am. We did biopsy also. So initially we thought it's PRP. Later on, biopsy showed positive for fungus, ma'am. So she responded for antifungals.
So this is an erythroderma-like presentation, and you gave her what kind of antifungals?
Both oral and topical antifungals, ma'am. Terbinafine we gave actually.
Terbinafine.
Yeah.
Now I'm going to ask just one question to Dr. Shenoy. With the advent of trichophyton mentagrophytes, and I've read some papers where they said that 90% of the isolates are actually mentagrophytes. So though I don't know if this is pan-Indian data, and I have a feeling north and south are different in this. So would you think terbinafine is okay to give, and do we updose very quickly?
I think it's a pan-Indian data with Dr. Ebert and Dr. Verma sir and Petroninoff, their publication. In fact, there were samples from entire, I think even my own institution, I'm in South India in coastal region, we have almost 85-90% is mentagrophyte. That is as for the conventional identification. Of course, we need the molecular identification will tell it better. I think it is happening, and terbinafine resistance is prevailing. At least in vitro resistance is definitely there. But I think we have to take this in vitro results with a pinch of salt when we always take it in clinical sense. It's not a bad idea to use terbinafine. It does work. It's not that. But yes, terbinafine resistance seem to be prevailing. At least in vitro seem to be prevailing. We are also doing this study in vitro. It looks like it's rampant. And I think it's because of the mentagrophytes only, the mentagrophyte, which has undergone several, taxonomic transformation. I think currently it's called as Indotinia. Trichophyton Indotinia is a recent name for that.
Adding India to the name, such a shame. So one last word. Is there any role of tapering off the topical steroid combination in such a situation? Dr. Shenoy.
I think, yes, we need to assess how bad the situation has been. As a clinician, we definitely can assess it. If there has been a thing, I remember one patient with extremely bad steroid-induced. In fact, we coined that term called, he used that one very famous preparation, not just the clobetasol with salicylic acid. We called it as propysalism. So since I think you have chased all the pharma people, it's fine from here. So that kind of people, yes. In fact, we had to substitute him with the oral corticosteroid for some time. Not just the tapering of steroid. In fact, for a topical, he had such a bad use. I think 0.2 202, that low nanogram level of cortisol level was very, very low. So when we substituted with the oral dexamethasone for a short while, when we were dealing with the tinea case.
Thank you so much. So another strong take-home message, if you think that there is HPA axis suppression, give an oral steroid but do not give a topical steroid. Stop the topical steroid cold turkey in all these people. Would you agree? In topical steroid damaged face, I keep saying this repeatedly, it is not one entity, it is not a diagnosis, it is more like a part of the diagnosis. So there are so many kinds of TSDF, and anybody, including this software engineer, can fall prey to it. So she had PCOS and recalcitrant acne, for which she was using 4-derm that was given her by her family doctor who was an MBBS person. So use dermoscopy, find out why they're using, and remember to diagnose. Of course, these stories, unfortunately, I don't have time to share, but decide whether it is because of acne or melasma or PDL or rosacea or tinea. TSDF due to tinea is something we see a lot, and seborrheic dermatitis, and treat the cause. That's what we have been talking about. Now, I'm going to move on. I don't have much time. So, this is our 5-pronged strategy, advocacy to bring about change in legislation, and I am super proud that I have had the privilege of writing the first draft of our PIL, the public interest litigation that IADVL has lodged in the Delhi High Court. Initially we went to Supreme Court, and Supreme Court directed the Delhi High Court to take care of this, and we are acting on the awareness part of it. We are working on creating a nationwide network of Itatians, and what we have been able to do so far is get the red label in place. Red label because now topical steroids legally cannot be sold without prescription. Between legal and actual, there's a lot of difference, and all of us have to strive hard to fill the gap. So thank you so much, everybody, and I hope all of you join the crusade. Thank you.
Thank you, Dr. Rajata. And we laud the effort of ITATSA for bringing that awareness and fighting that, 20,000 crore lobby with, what IADVL is. Congratulations, and really
ITATSA is us. And I'm hugely privileged and very grateful to Dr. Mumesh and Dr. Murthy and team for giving me this opportunity. And I pay homage to Patnaik sir. I hope he is going to be happy with our efforts.
And Dr. Nasiro for during his tenure, the theme was, topical.
He made it theme of the year and drummed up the awareness to a different level. Thank you, sir.
Thank you, Rajita, for a fine discussion and panelists also. Now we close the session.
Now we'll move on to session 8, the Professor R.P. Patnaik Gold Medal Dissertation Award session. I would like to invite the chairpersons, Dr. D.B.N. Murthy sir and Dr. R.V. Satyanath sir, onto the dais.
Yeah, this is a first Dr. R. Professor R. Raghunath Patnaik Gold Medal Dissertation Award. So, I request Dr. Putta sir, Dr. Manmohan sir, Dr. Ganesh sir, please come on to the dais. Dr. Ramesh sir, please come on to the dais just for garlanding. Neta sir, come. Padmaja madam, Dr. Indira, Dr. Padmaja, Sudharani, please come. Putta sir, PNR sir, PNR sir, Rajiv sir, Venkata Krishna sir, please. అందరు ఎట్లా వస్తారు ఇది కాదు ఇది చెప్పు అది అది పెట్టు అదే నువ్వు ఇట్లా ఉంటుంది నువ్వు స్టార్ట్ చేయండి Now it's over to chairperson to start the proceedings of this dissertation award.
లిస్ట్ ఇక్కడ ఉంది జనాలకి లిస్ట్ లేదు Good afternoon. I think this is the last session below the valedictory. I thank you all for staying with us with great patience to this award function which we are going to institute in the name of Professor R. Patnaik Gold Medal Dissertation Award session. I am honored to be the chairperson along with his son, Dr. R.V. Satyanath. Dr. Patnaik was my teacher, mentor, philosopher and guide. I miss him a lot, at least to keep him remembering throughout every CUTICON. We have instituted this medal and we have decided to name one hall in all CUTICONs as Dr. Patnaik Memorial Hall, at least continuously for 3 years, and afterwards we'll take another decision again. Now, I ask Dr. Satyanath to take care of the proceedings.
Thank you, sir. I presume all the speakers are ready. I invite Mehar Prasanna Kumari
And also
and the judges. Okay, judges are not being revealed. So I call upon the first speaker, Mehar Prasanna Kumari, It's comparative evaluation of microneedling, chemical peeling, that is glycolic acid, and TCA cross in management of atopic scars.
Good afternoon, everyone. I'm Dr. Prasanna Kumari, and my topic is comparative evaluation of microneedling, chemical peeling, and TCA cross in the management of acne scars. Acne is a chronic inflammatory disease of pilosebaceous unit characterized by formation of comedones, erythematous papules, pustules, and less frequently by nodules and pseudocysts, and in some cases it is accompanied by scarring, and scarring may be an at-risk factor for suicide. According to the grading system proposed by Jacob et al., it is of two types, hypertrophic and atrophic. Atrophic scars is of three types, ice-pick scars, box scars, and rolling scars. This study is done using locally available chemical peels like glycolic acid and trichloroacetic acid and simple surgical procedure like microneedling. The aims and objectives of the study is to ascertain various types of acne scars in both sexes of different age groups and to compare the efficacy and side effects and safety of chemical peels, TCA cross, and microneedling. It is an open evaluation of 3 different modalities on 60 patients of acne scars. Written consent were taken and details of symptoms, size, duration, history of treatment with isotretinoin, anticoagulants, any history of keloids and family history, any presence of active inflammatory acne or active bacterial viral infections, and locally evolving dermatosis was recorded, and photographs were taken before and after the treatment. This is an acne scoring system used for this study, and it is given a score of 1, 2, and 3 based on 3 parameters, that is nature, depth, and size. The individual lesion score is depth multiplied by nature multiplied by size. For the total score, it is sum of all the individual scores. The improvement was calculated as patient initial score minus patient score after treatment. And the degree of improvement is as follows. No response, it is 0%. If it is less than 15% response, it is weak response. 15 to 30% fair response. 30 to 50% good response. And 50 to 75 very good response. And excellent result if it is more than 75%. Patients were divided into 3 groups of 20 each. Group A with microneedling, monthly 1 session for 5 sessions. Group B, trichloric acid cross, monthly once for 5 sessions. And Group C treated with 70% glycolic acid fortnightly for 2 minutes for 5 months. And photographs were taken at the end of 3rd, 4th, 5th, and 8th months. Priming was done with 6% glycolic acid cream. Pre- and post-procedure sunscreens and moisturizers were prescribed. Statistics, descriptive statistical analysis has been carried out. The results on categorical measurements are presented in number, percentage, and significance is assessed at 5% level of significance. For comparison between treatment response and different groups, ANOVA test was employed. Results, the common age group of our patients was between 21 to 30 years with 36 patients, that is 60%, whereas 41 to 50 years constitute only 2%. Among 60 patients, 32 were male and 28 were female. In this study, based on duration, 17% has less than 1 year of duration, 23% has less than 1 to 2 years of duration, 33 patients had duration of between 2 to 5 years, and 27% had duration more than 5 years. This is an age distribution. In Group A with microneedling, majority of the patients are in 21 to 30 years category, whereas in Group B, it is 40% in 10 to 20 years and 40% in 21 to 30 years, and Group C, majority constitute 21 to 30 years. Gender distribution, Group A has 12 members of males and 8 females, whereas Group B and Group C has 10 males and 10 females. And distribution of type of acne scars, 80% of people has box scars, whereas 70% rolling and ice picks in 25%. These are the acne scar scores at 0, 3 and 5 months, 5 and 8 months. Comparison between treatment and reduction in score. The reduction in score is more in case of Group A, that is treated with microneedling, that is 47%. Between treatment and percentage reduction, in Group A there is 45.25% reduction in scar scores compared with the baseline, whereas in glycolic acid group it is 32% and TCA it is 33%. Comparison between treatment and response with glycolic acid peel, 10 people has achieved good results, whereas in microneedling 5 people has achieved very good results and 10 people good results. TCA cross has 2 people having very good results and 6 persons having good results. At the end of the study, the percentage reduction in acne scar score was highest in case of Group A, that is 45.25%, when followed by Group B, that is TCA cross 33%, and Group C 32%. In our study, microneedling showed a significant improvement compared with TCA and glycolic acid. And 4 patients out of 60 reported adverse effects like hypo and hyperpigmentation. Hyperpigmentation due to improper or inadequate use of sunscreens, and hypopigmentation in case of TCA cross at the site of spot application. Majority of patients found 30 to 50% improvement in disease burden. This is a response between before and after treatment with microneedling, with TCA cross and glycolic acid. Discussion. In the study, 60 patients have been randomly divided into 3 groups, 20 each, treated with microneedling, glycolic acid, and TCA cross. According to Cole et al. And Zani and Carl Goodman, in his study reported that acne scars affect around 14% of female population and 11% of male population. In the study, as reported by other authors, many of the patients present with more than one type of acne scars, although atrophic scarring appears to be the most common type associated with acne. The average baseline scar score in Group A is 105.25. At the end of the treatment, the reduction in score is 47 and the percentage reduction in score is 45.25%. In a study by Sunil Dogra et al., there was a significant statistical decrease in mean acne scores after 5 sittings of microneedling, and photographic evaluation showed 50 to 75% improvement. The average baseline scar score in Group B is 88 and reduction in scar score after 8 months it is 29 and percentage reduction in score is 33%. A study by Jung Bokley et al., patient treated with 100% TCA cross experienced a good clinical response when compared with the group receiving 65% TCA cross. In Group C, the baseline acne scar score is 82 and at the end of the treatment the reduction in scar score is 25 and the percentage reduction in acne scar score is 32.3%. In a study by Zulal Erbakci, in 58 patients repeated short contact 70% glycolic acid peels provided superior results in 23 patients when compared with other groups receiving daily topical application of 5% glycolic acid and placebo subject. The average reduction in Group A is 47, Group B 29, Group C is 25, p-value is less than 0.01. The average percent reduction in Group A is 45.25%, in Group B it is 33% and Group C 32%, and p-value is less than 0.01 significant. Conclusion, scarring is an unfortunate complication of acne vulgaris. Early and aggressive treatment is vital to minimize, if not prevent, its occurrence. Rolling scars were better managed with microneedling, whereas box scars and ice pick scars with TCA cross. Glycolic acid peels was effective only for superficial acne scars. Overall, maximum improvement in acne scarring was found in Group A, that is treated with microneedling, it is 47%, followed by Group B, TCA cross 33, and Group C 32%. These are my references. Thank you.
Thank you, Prasanna Kumari, and it was well in time. And your study appears to give the lasers a run. Thank you. I call upon Shahida Begum, a prospective comparative study of merits and demerits of intralesional MMR vaccine and intralesional vitamin D3 in treatment of verrucate.
Good evening to one and all. I am Dr. Shahida Begum and my thesis study title is a prospective comparative study of merits and demerits of intralesional MMR vaccine and intralesional vitamin D3 in the treatment of verrucate. Intralesional immunotherapy is an emerging modality where injection in a single wart causes resolution of the distant wart as well. It is also helpful for numerous lesions, recurrent wart, calcitrant wart, sites like periangual, genital and palmoplantar warts. Both MMR vaccine and vitamin D3 has recently emerged as a new treatment. There is a paucity of the studies comparing the efficacy and safety of the above modality, hence this study was undertaken. Aims and objective aim of the study is to compare the merits and demerits of the both therapies. Objective to compare efficacy, adverse effect and cost effectiveness of intralesional MMR vaccine and intralesional vitamin D3 in the treatment of warts in terms of decline in the number, diameter of the lesion and time taken for the individual lesion to resolve completely. Patients and the method, it's an open label randomized prospective comparative study done in the DVL OP department of our college. 100 patients requiring immunotherapy were included in the study, whereas pregnant and lactating women and patients where immunotherapy is contraindicated were excluded from the study. After obtaining approval from the ethical committee, these patients were grouped into 2, A and B, with 50 patients in each group. Group A received 0.5 ml of IL MMR vaccine, whereas Group B received 0.5 ml of IL vitamin D3, arachidol 6 lakhs units, into the largest ward once in 2 weeks for a total of 4 settings. Response was assessed by direct inspection and photographic assessments. Results, out of 100 patients, 82 completed the study with 42 in Group A and 40 in Group B. Male to female ratio was 1.1:1 in Group A, and in Group B it was 1.2:1. In both the groups, students were in maximum number and within the age group of 21 to 30 years. Mean duration was 5 months and 4.43 months respectively. In both the groups, palmoplantar type of wart was majority. Complete clearance of the injected was observed in 45.2% in Group A and 47% in Group B. Recurrence was seen in 12% in Group A and 12.5% in Group B. The most common adverse effects were injection site pain and swelling. Vitamin D3 was more effective when compared to the MMR vaccine. This is the tabular column. This is the tabular form showing the results with side-to-side comparison. Here we can clearly see the mean reduction in the number of wards, that is 3.02 at baseline to 0.738 mm in group A, whereas in group B 2.87 at baseline to 0.85 in group B. And whereas when we can also see the mean reduction in the size of the largest ward, 11.48 mm to 2.79 mm in group A, and in group B 9.9 mm to 2.64 mm in group B. The complete clearance was seen in 45.2% in group A and 47.5% in group B. 85% of the MMR patient had incurred a cost of about 700 compared to 75% of the patient with an INR of 214 vitamin D3 group. These are the graphical representations showing the age distribution, type of ward and occupation, mean reduction in the number of wards, mean reduction in the size of the largest ward, response, cost for group A and group B. These are the clinical picture showing the response in IL-MMR before treatment and after treatment, complete clearance at 8 weeks. This is also for IL-MMR before and after treatment. This is for IL vitamin D3 before treatment and after treatment, complete clearance at 8 weeks. This is also for vitamin D3. These are the adverse effects: bleeding with pain in IL vitamin D3, and the right side picture shows swelling with pain in IL-MMR. When coming to discussion, in both the groups, 21 to 30 years were in maximum number due to the fact that majority were student and due to the cosmetic appearance has opted in for the procedure. Males were in majority compared to the Jaiswal et al. Study. Students were in majority in both the groups, attributing to the fact that they are more prone to the spread of viral infection via the classroom environment. There was significant reduction in the mean number of wards in both the groups, implying that both are effective. There was significant reduction in the mean size of the largest ward at 8 weeks compared to the baseline, implying both are effective. Recurrence rate was similar in both the groups. The complete clearance in group A was 45.2%, which was more than the Saini et al. Study and less than the other study, as shown in the graph at the right side. The complete clearance in group B was 47.5%, which is compared to the Singer et al. Study and less when compared to the other study, as shown in the graph at the right side. Pain, bleeding and swelling were some of the adverse effects. Pain was most common adverse effect in both the groups, and it was about 57% in group A. And in group B, we have used in prior intralesional lignocaine in order to ease the pain, but still 70% of the patient has experienced pain. In various other studies, as shown in the graph on the right side, the pain percentage was more than our study. The cost incurred is directly proportional to the number of settings required and the cost of the individual drug. In our study, 85% of the patient and 75% of the patient has incurred a cost of about INR 700 and 240 in group A and group B respectively for the complete treatment. So there was, the vitamin D3 group was cheaper because of the fact that vitamin D3 is cheaper when compared to the MMR vaccine. When coming to conclusion and summary, the present study compares the merit and demerits of intralesional MMR and vitamin D3 in the treatment of verrucate. There was significant reduction in the mean number and mean size of the largest wart in both groups, implying that both are effective. The complete cure rate was 45.2% in group A, and group B it was 47.5%, thus indicating that both the therapies are equally effective, as the p-value was insignificant in our study. Vitamin D is more painful but cheaper compared to the MMR vaccine, but overall both are equally effective in the treatment of verrucate. So thus, treatment of verrucate with the immunotherapeutic agents like IL-MMR and vitamin D3 has been emerging as a safe modality. These are some of the merits and demerits comparing both group A IL-MMR and group B vitamin D3. So the take-home message is immunotherapy is a safe modality for difficult to treat warts in which IL-MMR and IL vitamin D3 both are effective, safe and economical. These are some of the references. Thank you for patience listening.
Thank you, Dr. Shahida Begum. That was an interesting study. Now I call Dr. Logeshwari, a study of STS among pregnant women attending STD clinic in a tertiary care center. Dr. Logeshwari.
Good
Good evening to one and all present over here. My thesis topic is on study of sexually transmitted infection among pregnant women attending STD clinic in a tertiary care center. Introduction: sexually transmitted infection have profound impact on sexual and reproductive health. The prevalence of STI is not uniform, as culture and tradition tends to differ between the individuals as well as between the subgroup of a population. Therefore, antenatal patients were used as a reference point for STI prevalence in women. Gestational alterations such as relative immunosuppression, anatomical and hormonal changes have been postulated to influence the course of STI. Mostly these infections are asymptomatic, hidden and hence underdiagnosed. Hence the study was taken with the main aims and objectives to know about the different types of sexually transmitted infection among the pregnant women and to study the clinical pattern of these infections with socio-demographic data like age, socio-economic status and education. Materials and method. Study population, all pregnant women attending our STD outpatient department over a period of 18 months was taken, and it is a type of cross-sectional observational study. Method of data collection. After appropriate consent, a total of 110 patients were included in the study, and detailed history was taken along with serological investigation was done for every patient, and swabs for potassium hydroxide mount, gram stain, Giemsa stain and culture were done if required. Results and discussion of this study and age-wise distribution. Most of patients were in the age group of 21 to 25 years, and this is similar to Sultan et al. Study where they also belong to 20 to 24 years. But in William et al. Study which was conducted in US, their age group was more than 25 years, and almost all STI in this study were prevalent in the age group of 21 to 25 except Trichomonas vaginitis, which was common in 26 to 30 years of age. And education-wise distribution, majority belong to primary education, and which is similar to Sultan et al. Study where more they belong to illiterate, and William et al. Study where they belong to higher class of education. Socio-economic status. According to modified Kupasamy scale, most of the women in this study were from lower middle class, which is similar to Sultan et al. Study where they also belong to lower class, but William et al. Study where they belong to lower middle class. Socioeconomic status appears to have a bilateral effect. The upstream effect of poverty increases the STI risk, and downstream effect of STI on the economic productivity and healthcare expenditure. Marital status. Among 110 women, 107 were married and 3 were divorced. This signifies the importance of screening the partners during their antenatal visit. Sexual history. In present study, 105 had only marital contact and 3 gave history of extramarital contact. This forms an important factor because those who have multiple partners are at high risk for acquiring STIs. Bad obstetric history. In this graph 6 you can see about 24 women had bad obstetric history. According to Gaddar et al. Study, women with previous miscarriage were more likely to develop Candida krusei infection with statistically significant increased risk of spontaneous abortion. It is therefore recommended that all antenatal cases with such bad obstetric history should be considered as a high risk group. And trimester, in present study, 64 women presented during second trimester, and in Sultan et al. Study and William et al. Study, they presented during first trimester. Presenting complaints, in this study, most of the women presented with discharge, that is 47.3%, followed by 31 with VDRL reactive titers tested outside as a part of ANC screening, came to our STD clinic for confirmatory test. And thus routine antenatal visit helps in detection of asymptomatic infection in pregnancy. Clinical examination. In present study, most of the women had thick curdy white discharge as shown in figure 1, which was demonstrated on gram stain which showed budding yeast and pseudo-hyphae. And figure 3 shows the condyloma lata lesion of secondary syphilis in pregnancy. Figure 4 shows the discharge of Trichomonas vaginitis, which was demonstrated on wet mount where there, we can see trichomonas. And figure 6 shows condyloma acuminata lesion, and figure 7 shows the ulcers of genital herpes. Patient serology. Out of 110 patients, 33 had reactive VDRL, 36 had TPHA reactivity, and 9 were HIV positive, and 1 had hepatitis B infection. Partner serology. Here in graph 9 you can see 25 were reactive for VDRL, and 36 were reactive for TPHA, and 9 had reactive HIV. Microscopic examination. In graph 11, 12 and 13 demonstrates that candidiasis is more common in this study, and then graph 14 you can see that Candida glabrata was more common, which indicates that non-albicans species was more common in our study. Diagnosis. Among 110 patients, 50 had vulvovaginal candidiasis And out of 36 syphilis patients, 34 had latent syphilis, 2 had secondary syphilis, 12 had bacterial vaginosis, 11 with HPV infection, 8 had MC, 3 had trichomonas vaginitis, 9 had HIV. On follow-up of syphilis mother, children of 4 syphilitic mother were found to have congenital syphilis. Out of 4 children, 2 had 1:2 VDRL positive titers and all 4 had reactive TPHA. Co-infection in pregnancy is very common, and in this study, 4 women had vulvovaginal candidiasis and latent syphilis together. Among 9 HIV positive women, vulvovaginal candidiasis was most common, followed by genital herpes, genital warts, bacterial vaginosis, and molluscum contagiosum, which is different from Joseph et al. Study where chlamydia was most common. Limitations: larger study is required to calculate the exact prevalence in this population. Association between candidiasis and diabetes were not included in this study. Serological tests to detect gonorrhea and chlamydial infection in pregnant women were lacking in this study. Conclusion: sexually transmitted infection are an important cause of maternal infant morbidity and mortality. These STIs have an adverse effect on the outcome of pregnancy by affecting both mother and fetus. They can cause chronic pelvic pain, miscarriages, chorioamnitis, as well as preterm delivery. The pattern of STIs during pregnancy varies according to the population examined in the different published study. In this study, most common STI was vulvovaginal candidiasis, and 4 children were found to have congenital syphilis. Hence, this study highlights the importance of screening for all major STIs during the antenatal visits, along with their sexual partners, which helps in early diagnosis. In addition to screening, counseling services and effective treatment can help prevent further transmission of these infections. These are few references. Thank you so much for this opportunity.
Thank you, Dr. Logeshwari. Now I call upon Navya S. Dr. Navya S. A study of clinico-histopathologic and dermatoscopic findings in hyperpigmentary skin disorders among patients attending a tertiary care center.
Good afternoon to one and all. I am Dr. Navya S. and my title of presentation is A Study of Clinico-Histopathological and Dermoscopic Findings in Hyperpigmentary Skin Disorders Among Patients Attending a Tertiary Care Center. Introduction: hyperpigmentation of skin is the most commonest dermatological complaint. Globally, now it has become an issue of cosmetic concern which has profound effect on the appearance of an individual and also his quality of life. There is usually overlapping of clinical features among these various hyperpigmentary disorders. Despite of the ease of appreciating the clinical morphology, our accuracy in making the diagnosis remains far from perfect. A dermoscope is a diagnostic tool which visualizes the subtle clinical patterns of skin lesions as well as the subsurface skin structures not normally visible to the unaided eye. A certain number of lesions defy both clinical and dermoscopic diagnosis. Then in such cases, histopathology becomes the ultimate standard for diagnosis. Therefore, in this context, the present study is undertaken to evaluate the clinico-histopathological as well as the dermoscopic findings in hyperpigmented skin disorders. The aims and objectives of the study being to study the clinico-histopathological and dermoscopic findings and to correlate the diagnosis arrived by the dermoscopic examination with that of the clinico-histopathological diagnosis, and to establish that dermoscopy as a non-invasive modality for the diagnosis of hyperpigmentary skin disorders. It was a prospective cross-sectional observational study conducted over a period of 18 months. After taking a detailed history, clinical examination was done, and according to the standard definitions and features accepted in the literature, clinical diagnosis was done, clinical photographs were recorded, dermoscopic images were captured in the dermoscope DermLight DL3, which is depicted in the picture. The patients were further subjected to skin biopsy. All the data was analyzed and tabulated. The 71 consecutive patients of all age groups which are clinically diagnosed as hyperpigmentary skin disorders were included in the present study. Patients not giving consent who were on topical as well as systemic treatment for more than 2 weeks, invasive and non-invasive procedures where the patient were undergone for the past 6 weeks, pregnancy, lactation and keloidal tendency patients were avoided. were not included in the study. So coming to the results and discussion, among the 71 patients, 22 patients had melasma and exogenous uchronosis, 20 patients had lichen planopigmentosis, 11 patients had erythema dyschromicum persistens, 10 patients had macular amyloidosis, and other groups which included Reels melanosis and PIH. Overall, in our study, female outnumbered males with a ratio of 4.9:1. The mean age group was between 31 to 40 years. The mean duration of disease was more than 12 months in melasma, exogenous uchronosis, macular amyloidosis. But in case of LPP, EDP and others group, it was between 1 to 6 months. So I'll be telling in 3 parts, that is the clinical examination, the histopathology, as well as the dermoscopic features. The clinical examination of patients with melasma, mandibular type of melasma was least common, whereas centrofacial type of melasma was most common. All the patients were asymptomatic. On clinical examination, light brown pigmentation, which blotchy pattern was the most commonest finding. This is the dermoscopic pattern. The dermoscopy of each patient was dealt in these topics, that is the background color, dots globules, the reticular network, and specific pattern. So in melasma patients, it was 61.1% patients had epidermal type, which was in same with Manjunath et al. Study and Tamler et al. Study. 22% patient had dermal type, as well as 16 patient belonged to the mixed type of melasma after dermoscopic examination. So on histopathology, it was done only in 11 patients of melasma, as patient did not give consent for the biopsy on the face because of the cosmetic reasons. Basal and suprabasal increase in the melanin pigment was observed in 5 cases, that is 27.8%. Upper and mid-dermal melanophagus was seen in 22% of the patients. The 4 patients was diagnosed with exogenous uchronosis, among which 3 patients were asymptomatic, 1 patient had erythema. Blotchy pattern of pigmentation was seen in all the patients. Hyperpigmented macules were seen in 3 patients, whereas papules and erythema was seen in 1 patient each. The most commonest dermoscopic findings was the light brown background with dark brown dots and globules, which was observed on dermoscopy with perifollicular pigmentation. The worm-like pattern of pigmentation, arcuate structures helps us to differentiate this from melasma. Pigment incontinence and ochre bodies was the most commonest findings, which was seen on histopathology. In lichen planopigmentosis, where the number of patients examined were 20, face and upper neck was the most commonest sites involved. Most of the patients were asymptomatic, 30% had itching, and it was slate gray pigmentation, which was clinically observed in this picture, is the most commonest type. Hem-like pattern of pigmentation was in 20%, whereas the most commonest type was incomplete pattern of dots and globules, which were observed in 65% of the LPP patients on dermoscopy. On histopathological examination, pigmentary incontinence was seen in all 100% of the patients. So this is the comparing the present study with that of the Vinod Kumar et al. Study, where it was comparatively similar with that to our study. In EDP patients, most of the patients were asymptomatic. It was diffuse gray color pigmentation was the most commonest presentation, and face was involved in 72% of the patients. So this is the dermoscopy and histopathology of EDP, where it was gray-brown dots and globules arranged in a reticular pattern was the most commonest dermoscopic findings, and histopathology showed basal cell vacuolation in all the patients. So in macular amyloidosis, it was itching was the most commonest type with ripple pattern of pigmentation. Hub and spoke pattern on dermoscopy was most common. Apple green birefringence with amyloid deposits in the papillary dermis was the most commonest histopathological findings. We had to correlate the clinical and histopathological and dermoscopic diagnosis. We had to do a kappa statistic. There was 100% correlation in melasma, exogenous uchronosis, as well as Reels melanosis patients. The limitations of the study was it is a single observer study. There was, we couldn't correlate all the dermoscopic findings with that of the histopathological findings, and there's paucity on literature. So here, after the present study, I conclude that dermoscopy is a valuable diagnosis, and it is an adjunct to the clinical diagnosis. It's not only helping in diagnosis, but also a prognostic response. The low-cost portability and ease of it helps us to make a promising diagnostic tool. These are my references. Thank you. Thank you one and all for your patience.
Thank you, Dr. Navya. Now I call upon Dr. Shushma Sukruti. A study on efficacy of microneedling combined with topical 5-fluorouracil 5% in stable vitiligo patients and attending the tertiary care.
Good evening all. This is Sushma Sukriti. I'll be talking on a study on the efficacy of microneedling combined with topical 5% 5-fluorouracil in stable vitiligo patients attending the tertiary care center. So we know that vitiligo is an acquired depigmenting condition causing great cosmetic concern and psychological morbidity, and it is also continues to be a major dermatological challenge despite the availability of numerous medical and surgical treatments. Hence, a combination of both would lead to a better repigmentation. The aim of the study is to establish that microneedling combined with 5% 5-fluorouracil is a safe, simple, and an effective modality to treat the vitiligo patches. The objectives of the study is to evaluate the efficacy, to assess the rapidity with which the pigmentation occurs, and also to assess the safety of this modality. The materials and methodology, we have employed 30 patients having stable vitiligo patches who are willing to undergo the study, while excluding lesions over the lips, genitals and intertriginous areas, pregnant women and those planning for pregnancy, patients having any systemic infections, breach in the skin surface, bleeding diathesis, and sensitivity to the topical anesthetics. So, following microneedling on the top picture, following microneedling, till the pinpoint bleeding occurs, we do, and then we do application of 5-fluorouracil and soframycin in a 1:1 ratio under occlusion. Then the patient is advised to apply the cream once daily for 5 consecutive days in a week for 2 weeks. This procedure is then repeated once in a month for 3 consecutive months and is followed up for the next 3 months after the last procedure. The patient is evaluated with photographs and with qualitative scoring techniques, which are the physician global assessment, which is a 5-pointer scale, and in our study we have considered grade 4 and grade 3 to be successful repigmentation. The patient global assessment is a 4-pointer scale ranging from 0 to 3, where 3 is much better and 0 is worse. Coming to results, we have seen that nearly 48% of them have responded with excellent improvement, with 18.5% of them showing marked improvement. So nearly 2/3 of them have shown successful pigmentation. Coming to the rate of repigmentation, we see that 2/3 of them following the first sitting itself have shown repigmentation, while coming to the second sitting, we see that 7.5% have started to show more than 75% repigmentation. Coming to the size and the rate of repigmentation, we see that sizes 1 to 3 centimeters, considering them as small, medium sized are 4 to 6 centimeters, and the larger one being 7 to 10, of which the smaller and the medium sized have repigmented faster and better, where following the end of the study, we see 83.3 of the smaller ones having more than 75% pigmentation, whereas 43.8 of the medium sized having more than 75% repigmentation. Coming to the site, we see that the face have responded better. The face have responded better in comparison, and following which the trunk, and then we have the limbs responding least, of which the upper limb has responded the least. The patient assessment scale, 63% of them have said that they felt much better, while none of them have reported that the lesions have become worse. Coming to the distribution of side effects, we see that erythema is the most common one that we have encountered, being around 52%, following which we have burning, oozing, erosions, and melia occurrence. So this is one of the pictures of response, seeing 100% repigmentation, and the other one showing more than 75% repigmentation. This is also more than 75% with melia formation. So we see that combination treatments help to bring about improve the overall effectiveness of the treatment, and also reduce the time that is needed to achieve the repigmentation, as well as reduce the potential side effects. So microneedling mechanism of action is it creates micro-injuries that lead to the release of growth factors and inflammatory mediators, thereby stimulating the melanocytes and cause their migration from the pigment and margins. Then it also increases the transdermal drug delivery of topical treatments as well. Coming to the mechanism of 5-FU, it causes the overstimulation of the follicular melanocytes, which migrate to the surface during epithelialization, causing pigmentation. So while, in our study we have considered successful repigmentation to be more than 50%, in which we've seen 66.6% of the patients showing such a response, and we have seen that 96% patients in our study have shown pigmentation from the margins of the lesion rather than perifollicular. So comparing our study with other studies that have employed similar methodology, we've seen that more than 75% pigmentation have, in our study, have shown 48%, similar percentages in the others. while those employing only 5FU have shown a really poor response of only 4.3%. Those employing tacrolimus with needling have shown 16%, whereas where dermabrasion was used as a methodology for therapeutic wounding, had shown more better pigmentation, but we see that they're associated with maximum complications. Now, what is the start of repigmentation? In our study, it is in 66.6% of the patients have shown following a single session after 4 weeks, whereas similar studies who have employed doing once in 2 weeks, and after 4 weeks, they have shown just 20%, 65%. So once a month session is actually enough. And once using 5FU, have shown only 38% response, and tacrolimus even less. So the complications, hyperpigmentation erythema noted in ours was seen in the other studies as well, except for those using tacrolimus. Ulceration noted in the others was not seen in us. Melia exclusively in our study, and hypertrophic scar only in dermabrasion. So as 66.6%, that is nearly 2/3 of the patients have shown good to excellent response, with 63% of the patients saying that the lesions are much better, and the side effect profile being mild and tolerable, I conclude that this methodology is simple, safe, and an effective modality to treat the vitiligo patches that are associated with a greater psychological morbidity. These are my references. Thank you.
Thank you, Dr. Shrishma. Now I call Dr. Harshini, a study to establish usefulness of trichoscope in diagnosis of patchy alopecia.
Harshini.
A very good afternoon to one and all. Today I, Dr. Harshini, is going to present on topic trichoscopy in diagnosis of patchy alopecia. Introduction. Alopecia can be diffuse or patchy, cicatricial or non-cicatricial. Though the etiopathogenesis of alopecia have been evaluated, very few data are published in the literature. Trichoscopy, the scalp and hair dermoscopy, may help to distinguish scarring versus non-scarring alopecia, support the diagnosis, choose biopsy site, and predict the prognosis. This technique, both simple, non-invasive, can visualize subtle clinical patterns and skin surface not visible to naked eye. Our study focused on identifying the role of trichoscopy in patchy alopecia. The findings in each group were in accordance with those already described in the literature. Aims and objectives. To establish usefulness of trichoscope in diagnosis of patchy alopecia, to analyze the trichoscopic finding in different cases, and to correlate the trichoscopy with clinico-histopathological diagnosis. Materials. This cross-sectional study includes 50 patients of both gender in age group of 10 to 60 years with clinical features of patchy alopecia attending the outpatient department of DVL at tertiary care hospital for a period of 18 months. Methods. After obtaining approval from the ethical committee, informed consent was taken from every patient and a detailed clinical history and examination was done, followed by tabulating with a non-polarized contact dry and immersion fluid trichoscopic follicular, perifollicular and interfollicular findings. Histopathological evaluation along with other relevant investigations were carried out in every case, ensuring results were statistically analyzed. Results. In the present study, with a total of 50 patients presenting, the following demographic results were seen. With a gender prevalence of female patients, and age group was around from 10 to 60 years with a younger age onset of less than 20 years. Duration of disease was less than 6 months in most of the cases. This table shows the distribution of patients according to trichoscopic follicular findings in the clinically diagnosed case with a significant p-value of less than 0.01 in most of the findings. This table shows the distribution of patients according to trichoscopic perifollicular, interfollicular findings in clinically diagnosed case with a significant p-value of less than 0.01 in most of the findings. These tables shows the distribution of subjects according to trichoscopy diagnosis as well as histopathological examination. Discussion. The commonest type of alopecia in our study was alopecia areata, followed by discoid lupus erythematosus and lichen planopilaris. Alopecia areata, dermoscopically the patient had non-scarring alopecia, exclamation mark hair and yellow dot were the most common findings, followed by black dot, broken hair and vellus hair. These are the images, clinical image and histopathological image, with a trichoscopy image showing follicular ostia, black dots, vellus hair and pigtail hair. Pseudopelade of Brock. A single case was seen with the trichoscopy showing scarred ivory white dots with absent follicular openings. DLE in dermoscopy showed reduced number of hair follicle in all patients. Telangiectasia was the commonest finding, followed by perifollicular cast and scales. Out of all cases of DLE clinicotrichoscopy, one case was diagnosed as SLE histopathologically. SLE case showed dermoscopic examination of vellus hair, follicular plug and many telangiectasias. These are the images, clinical and histopathological images, with the trichoscopy showing white dots, absence of follicular ostia, scattered dark brown discoloration and perifollicular scales in the periphery of the patch. LPP was the second most common scarring alopecia in my study. Dermoscopically, all patients showed reduced number of hair follicle, perifollicular cast and blue-gray dots in 100% of the cases, followed by follicular plugging and scales in few of the cases. Out of all cases of LPP, clinicotrichoscopically, one case was diagnosed as DLE histopathologically, and 2 cases of LPP was clinically GLPS, Grams-Little-Picardy syndrome. The trichoscopy image of the LPP showed perifollicular scales, white dot, blue-gray dots and follicular structures. Trichotillomania. 2 female patients presented to my OP and the trichoscopy showed broken hair at different levels, V-shaped hair, few irregular hyperpigmented area and perifollicular hemorrhage were the most common findings. Limitations of the study. A limitation of this study is the small sample size and not all variant of patchy alopecia were included. Histopathology remains the gold standard for confirmatory diagnosis. This imposes a drawback as it is an invasive procedure. And the assessment was done by a single observer with no assessment of inter-observer validity and intra-observer reproducibility. And there is also a paucity of literature describing the trichoscopic findings. Conclusion, a positive correlation between clinicotrichoscopic with the histopathological diagnosis indicated that the trichoscopic findings are indeed diagnostically significant, and it may be concluded that the trichoscopy is a valuable diagnostic option for patchy alopecia disorders, and it is a good adjuvant to the clinical diagnosis with the histopathology as the final confirmatory diagnostics tool. These are few of my references. Thank you for your patience.
Thank you, Dr. Harshini. Now I call upon Dr. Hina Ferdoz. A comparative study of safety and efficacy of intraneedle triamcinolone acetonide 40 milligrams per ml and 5-fluorouracil in treatment of keloids.
Good evening, everyone. This is Dr. Hina Firdaus. I have done a comparative study of safety and efficacy of intralesional triamcinolone acetonide 40 mg per ml and 5-fluorouracil 50 mg per ml in the treatment of keloids. Keloids result from abnormal wound healing due to benign hyperproliferation of dermal fibroblasts. They follow dermal injury and exhibit exuberant indefinite growth of collagen. Keloid formation has been ascribed to genetics, immune dysfunction, altered growth factor regulation, aberrant collagen turnover, sebum reaction and altered mechanics. No single unifying hypothesis adequately explains keloid formation. They are firm to hard, irregularly shaped, fibrous, pink to brown colored lesions which are frequently symptomatic. They occur on any part of the body, specifically on shoulder, anterior chest wall and earlobes. They are disfiguring, they cause pain, itching, decreased range of motion and impaired psychosocial well-being. There is no universally accepted treatment for permanent ablation of keloid or hypertrophic scars. Many treatments have been advocated either alone or in combination, include surgical excision, intralesional therapy, radiotherapy, laser, cryo, topical treatments. Aim of this study is to compare the safety and efficacy of intralesional triamcinolone acetonide and 5-fluorouracil in the treatment of keloids. Objective is to compare the efficacy of intralesional triamcinolone and 5-fluorouracil in terms of regression in size, flattening of the lesion, time taken for the regression of lesion, reduction of symptoms and recurrence rate, and to compare their adverse effects. It was a prospective randomized interventional study for a period of 18 months with sample size 100 patients in our outpatient department. Inclusion criteria was patients with keloid following trauma, inflammation and other causes in the age group 18 to 50 years and who are willing for follow-up. Exclusion criteria, pregnant and lactation, patients on immunosuppressive therapy, and patient with extensive keloid following burns, infections, who are not willing for follow-up and who are not on other simultaneous treatments. Results, more patients were in 21 to 30 year age group. There was near equal sex distributions, students predominated, and most common symptom was pruritus, and there was a spontaneous onset. And the score used here was Vancouver SCAR score, which includes vascularity, pigmentation, pliability and height parameters. Treatment response was graded as poor response 1 to 50%, good response 51 to 74, excellent was 75 to 99 and complete response is 100%. Comparison between the percentage of patients showing complete response in regimen 1 and 2. For pigmentation score, there was a significant reduction by 6 weeks in regimen 1 and 9 weeks in regimen 2. Based on pliability, there was significant reduction by 6 weeks in both the groups, and height score, there was significant reduction by 9 weeks in regimen 1 and 12 weeks in regimen 2. This was the clinical photograph of case 1 before intralesional steroid regimen 1 and after 15 weeks, that is 6 sittings of intralesional steroids. This is case 2, same before intralesional steroid and after 6 sittings of ILS. This is the case of before intralesional 5-fluorouracil and after 15 weeks of intralesional 5-fluorouracil. Second case of regimen 2 IL-5FU before and after 15 weeks. Discussion pathogenesis of keloid, patient-related factors, genetics, racial, hormonal, and other environmental factors like trauma, inflammation, burns, surgery leads to abnormal cellular response, and there is increased growth factors like platelet-derived and transforming growth factor beta, which further leads to proliferation of fibroblasts, new vascularization, leading to abnormal wound healing. It was noted that majority of the patients, 52% were in 21 to 30 years, and the rest, keloid can develop at any age, but more prevalent in 10 to 30 as studied by Uddin. Out of the 100 cases, 51 were males and 49 were females. Among the occupations, students constituted the maximum number, followed by housewives, 16.7 farmers, skilled laborers, business and unskilled workers. Duration out of the 100 patients, 68 has duration less than 1 year, 17 has 1 to 2 years, and 15% has duration more than 2 years. Site, majority were over the chest, followed by shoulder, earlobe, back, lower limb and face. In a study by Kabel et al., the most common site were chest, shoulders, back, forearm and neck. Comparison of Vancouver SCAR scores in both the regimens, there was no statistically significant difference in height, vascularity, pliability and pigmentation. Hence, both regimen 1 intralesional triamcinolone acetonide and regimen 2 were equally efficacious. Side effects, after the 100 patients, 30 did not develop any side effects. In regimen 1, 25% developed side effects, and in regimen 2, 45 patients, which includes 5 developed atrophy, depigmentation, hyperpigmentation, pain, telangiectasia and none developed ulceration. In regimen 2, 10 patients developed ulceration and none developed telangiectasia. Conclusion, out of the 100 patients, there was random allocation of subjects, 50 under regimen 1 and 50 under 2. Majority belongs to second decade, 21 to 30 years of life, near equal sex distribution, students populated, and overall chest was the common site of involvement. Itching was seen in more than half of the patients, and 38% had spontaneous onset. Among both regimens, the results were statistically, there was no significant difference with p-value more than 0.05. There is statistically significant difference in regimen 1 and 2 with respect to proportion of patients experiencing pain and ulceration. Recurrence was seen in 12% patients in regimen 1 and 10% patients in regimen 2. Hence, there is statistically no significant difference in proportion of recurrence. These are some of my references. Thank you.
Thank you, Dr. Hina. Now I call Dr. Ashok Sudula. Clinical and epidemiological study of non-venereal genital conditions.
Good afternoon, everyone. My topic is clinical and epidemiological study of non-venereal genital conditions. Non-venereal genital dermatosis tend to be confused with venereal diseases, which may be responsible for considerable concern to patient and may cause diagnostic dilemma to the physicians. Determining any causal or aggravating factor can save the patient from persistent discomfort and restricted social life, thereby considerably improving the dermatological specific quality of life. Non-venereal dermatosis need not be restricted to the genitalia alone. They may affect other mucous membranes and also the skin. Aims and objectives: to determine clinical and epidemiological pattern of non-venereal genital condition that present as genital lesions alone, genital and skin lesions, orogenital lesions, and orogenital and skin lesions in both males and females. Materials and methods: it was a descriptive study with source of data being OPD and inpatient registered in DVL department. Period of data collection was from December 2017 to May 2019. Method of data collection: detailed history of the disease and history of exposure was taken. Diagnosis was done based on history and physical examination. Investigations were done as and when required. Informed written consent was taken. Observation and results: prevalence was 6.1% per 1,000 patients. Age ranged from 8 months to 77 years. Majority of the patients were in the age group of 21 to 30 years, followed by 31 to 40 years. The male is to female ratio was 2.28:1, that is 70% males, 30% females. Coming to the classification of non-venereal genital lesions based on sites of involvement. In this study, out of 200 patients, genital alone comprised of 70.5%, accounting for the majority, followed by genital and skin in 16.5%, orogenital and skin in 7%, and orogenital in 6%. Involvement of genitalia alone was found to be significantly higher than other groups. Coming to non-venereal genital lesions involving only genitalia. Out of 141 patients, majority was constituted by pearly penile papules, that is in 19% of the patients, followed by genital vitiligo, that is in 13.6% of the patients, and followed by lichen sclerosus chronicus, as you can see in the chart. A similar pattern was seen among male study population, whereas genital vitiligo seen in 20% and candidiasis in 14.7% was predominant among female study population. Next, lesions involving genital and skin. Of the 33 patients, 93% were male. Scabies was a predominant disease involved in male with 45% of the cases. One case each of vitiligo and molluscum contagiosum was seen among female population. Coming to the lesions involving orogenital area. Out of 12 patients, 50% cases of vitiligo followed by lichen planus and fixed eruption with 16% each were observed. Among the male study population, vitiligo was seen in 57%, followed by fixed eruption in 28% and lichen planus in 14%. 40% patients with vitiligo and 20% each with candidiasis, lichen planus and pemphigus vulgaris were seen among the female population. Coming to the lesions involving concurrent orogenital and skin lesions. Out of 14 patients, 57 cases of vitiligo, 21% each of lichen planus and drug reaction were observed, as you can see in the chart. In male group, 54% vitiligo and 27% of lichen planus cases were seen. 66% cases of vitiligo were observed in the female group. Venerophobia. 19% in our study gave history of sexual exposure. All 19 were male. Among them, 18 patients had venerophobia and thought that they developed the illness because of their high-risk behavior. It was most commonly encountered in patients with vitiligo and pearly penile papules, 22% each. 14 patients had multiple exposure, whereas only 4 gave history of unprotected sexual exposure. Discussion. In our present study, most common age group was 21 to 30 years, which is similar to the other previous studies. And our common dermatosis was genital vitiligo, which is similar to CUTICON et al. And Ashok et al. Number of clinical patterns was 34 in our study, which were more than other studies. Comparison of vitiligo, which was common in our study to the other studies, it was 16.8%, which was similar to the previous studies. Comparison of pearly penile papules, in our study it was 13.79%, which was similar to QLS et al., which is 14.3%. No pre-malignant or malignant lesions were noted in the present study. Since none of the previous studies has classified the non-venereal diseases into genital, orogenital, genital and skin, and concurrent orogenital and skin, no comparison was possible regarding the pattern and distribution in similar lines. In the present study, 19 male patients gave history of sexual exposure. Among them, 18% patients had venerophobia. Venerophobia was found to be affect only male population. None of the other similar studies had looked into the aspect of venerophobia. True prevalence and pattern can be known only with the multidisciplinary approach, that is with input from dermatology, gynecology, genitourinary, as well as psychologists and psychosexual therapists. In conclusion, all the lesions on genitalia are not sexually transmitted. Hence, it is very important to distinguish between venereal and non-venereal genital dermatosis, as these lesions on genitals cause tremendous mental stress and feeling of guilt. A total of 34 different types of non-venereal diseases were encountered in our study. Localized genital lesions were found to be significantly higher among the 4 groups. The most common disorder was vitiligo, followed by pearly penile papules. Pearly penile papules and genital vitiligo were the 2 most common disorders among the male population. Genital vitiligo and candidiasis were common disorders seen in among female population. 19 patients gave history of sexual exposure. 18 patients had venerophobia. The study was quite useful in understanding the clinical and etiological characteristics of various types of non-venereal dermatosis. However, further studies with larger sample size are required, which is our limitation to our study. These are my references. Thank you for giving this opportunity.
Thank you, Dr. Ashok. Now I call upon Dr. Varsha KL. Study on clinico-etiological wood slamp and dermoscopic evaluation of facial melanosis.
Good evening, everyone. My study is on clinico-etiological wood slamp and dermoscopic evaluation of facial melanosis and have no conflicts of interest to declare. Facial melanosis are one of the common ailments why a patient visits a dermatologist. It not only causes cosmetic disfigurement, but it also has a lot of psychological impact on the well-being of a patient. The effectiveness of the treatment depends not only on correct diagnosis, but also identifying the cause. However, there's a lot of clinical overlap, and wood slamp just tell us about the level of pigmentation. It will not give us any specific diagnosis. Biopsy and histopathological examination is not specific, and it causes untoward scarring. Not all patients of facial melanosis expect us to do a biopsy on their face. Hence, there is a need for alternative methods to diagnose. So, dermoscope is one such non-invasive tool. Since it is evolving and there are not many studies, use of dermoscopy in facial melanosis was undertaken in our institution. Aims and objectives were to determine the various subtypes of facial melanosis in relation to age and sex, to determine the etiology of facial melanosis, to correlate clinical wood slamp and dermoscopic findings of facial melanosis. It's a prospective and observational study conducted from Jan 2019 to Jan 2021. 100 cases of facial melanosis from a tertiary care hospital was taken, informed consent was taken, required photographs were taken. Consecutive type of non-probability sampling were used for selection of study subjects. All the patients of facial melanosis of age more than 18 years were included in our study. Patients who are not willing to give consent, patients with active infection were excluded. For dermoscopic examination, we used DermLight DL4. Coming to results, among the sex distribution, we had a female preponderance of 77%. Mean age in our study was 38.89 years with a standard deviation of 9.145 years. Among the occupations, housewife topped the list, followed by self-employed and teachers. Among the triggering factors, we found cosmetic usage as a top of the list, followed by skin lightening cream and hair dye usage. Among the clinical diagnosis, the most common diagnosis we made was melasma. However, on dermoscopy, this melasma was further subdivided into epidermal and mixed type, and we also could pick up the case of exogenous sucranosis on dermoscopy, which was clinically diagnosed as melasma. Then we had a clinical overlaps of Reals melanosis, seborrheic melanosis, Reals melanosis with LPP. We could differentiate it basically on dermoscopy. Coming to disease-wise sex distribution, we had female preponderance in most of the conditions, but except for in facial acanthosis nigricans, where we had equal sexual preponderance, and in maturation hyperpigmentation, we found a male sexual preponderance. Coming to disease-wise sun exposure, almost all the conditions had duration of exposure of less than 4 hours. Disease-wise Utslam findings, we had accentuation of pigmentation mainly in melasma and in case of pigmentary demarcation line, whereas in other conditions we did not see accentuation of pigmentation on Utslam. Coming to the dermoscopic patterns, so here, the most common pattern we observed was the pseudoreticular pattern followed by reticuloglobular and reticular pattern, and the archiform structures were seen in exogenous sucranosis, melasma, LPP. On the specific signs of jelly sign of melasma was seen in 31% of our cases. Hem-like pattern of LPP was seen in 100% of our cases. Salci and gyri of facial acanthosis nigricans was seen in 100% of our cases. Worm-like areas of exogenous sucranosis was seen in 100% of our cases. So correlation of dermoscopy diagnosis with histopathology and with provisional diagnosis was done using kappa statistics. We had 100% concordance in exogenous sucranosis, facial acanthosis nigricans and LPP, whereas even with histopathology we had a 50% discordance in Reals melanosis / seborrheic melanosis. With the dermoscopic diagnosis, again we had 100% concordance in most of the conditions except for Reals melanosis, where we had 90% concordance. Coming to the photographs, here this is a photograph exogenous sucranosis. You can see the confetti-like depigmented macules, and this is the worm-like body obliterating the ecran and the follicular opening. This is a image of maturational hyperpigmentation showing ring-like pattern of pigmentation in the perifollicular and peri-ecran regions along with the keratotic follicular plugging. This is an image of Reals melanosis where you can see the background faint erythema, and here there are a lot of out of focus blood vessels, and there is a reticular pattern of pigmentation with mild scaling. This is dots which are arranged in linear and parallel lines. This is giving a diagnosis of lichen planus pigmentosus. This is a dermoscopy of melasma where we are seeing the exaggerated pseudoreticular pattern with the concave border calling the jelly sign. So this is a linear crista and salci cutis simulating that of the brain with the dark brown dots and globules of facial acanthosis nigricans. Coming to discussion, so the most common age group we observed in our study was 31 to 40 years, which is similar to other studies. The sex were females. Housewife for the most common occupation we observed, and most common trigger was cosmetic usage. On Utslam examination, 60% of them had accentuation of pigmentation. Dermoscopic finding, the specific jelly sign was seen in 31.5% of the cases, which was not compared with other studies. They have not mentioned it. Hem-like pattern was observed in 100% of our cases of LPP, but it was only 20.9%, maybe because of the usage of better equipment in our study. Worm-like areas of exogenous sucranosis were seen in 100% of all the studies, and even the salci and gyri pattern of facial acanthosis nigricans was seen in 100% cases of all the studies. Dermoscopy of seborrheic melanosis is showing pseudoreticular pattern was seen in 80% of our cases, but in comparison to 67% in Verma et al. Coming to conclusion, dermoscopy definitely delineates epidermal and dermal pigmentation. It is considered conclusive, reproducible and repetitive in cases of melasma, exogenous sucranosis, facial acanthosis nigricans, nevus of Otta and maturational hyperpigmentation. Dermoscopy can definitely serve as a prognosticating scale because we can definitely identify the level of pigmentation, and then we can counsel the patient regarding the mode of treatment what they need. It serves as a link between the macroscopic skin lesion and the microscopic histopathological feature. Since it is non-invasive, it can be done in all the age group without any scarring. However, even the histopathology did not definitely diagnose many of the facial melanosis. Hence, further studies correlating the dermoscope with histopathology is needed. My limitations are smaller sample size, and not all the patients underwent biopsy, and it's a single observer study. These are my references. Thank you.
Thank you, Dr. Varsha. Now I call Dr. Prashanti Mogli. This would be the last paper. Cross-sectional study of comorbidities among patients with chronic plaque psoriasis at tertiary care hospital.
Good evening, everyone. My topic of presentation is cross-sectional study of comorbidities among patients with chronic plaque psoriasis at tertiary care hospital. Introduction. Psoriasis is a common chronic inflammatory papillosquamous disorder of skin in which both genetic and environmental factors have a critical role. The worldwide prevalence of psoriasis is estimated to be approximately 2 to 3%. Among the patients attending hospitals in India, the prevalence is about 0.44 to 2.8%. Comorbidity is the occurrence of one or multiple disorders in association with a given disease. Comorbidities tend to arise in complex disorders. They are frequently multigenic and multifactorial and most often demonstrate an inflammatory background. My study aim and objectives of the study. Aim is to study comorbidities among patients with chronic plaque psoriasis. Objectives are to determine comorbidities among chronic plaque psoriasis and to assess the relationship between socio-demographic variables with comorbidities of chronic plaque psoriasis. Materials and method. The study design is cross-sectional and observational study. Sample size 100 chronic plaque psoriasis patients included between December 2018 to March 2020 over a period of 18 months. Ethics committee clearance was approved. Written informed consent was taken from all patients. A detailed general cutaneous and systemic examination followed by investigations were carried out and recorded in proforma for analysis and interpretation of data. Subjects above 18 years of age with chronic plaque psoriasis of both males and females were included, excluding age less than 18 years and immunocompromised patients with chronic plaque psoriasis. Results. Among the total 100 patients studied, 73% were having comorbidities. Male patients 65 outnumbered the female patients 35 in our study. Maximum number of patients were in 51 to 60 years age group, that is 25%, followed by 31 to 40 years age group 22%, 21 to 30 years of age 21%. This is the graph showing distribution of various comorbidities in our study. Dyslipidemia was found in 60% of cases, followed by hypertension in 23% of cases, diabetes mellitus in 16% of cases, metabolic syndrome in 13% of cases, obesity in 6% cases, myocardial infarction in 4% of cases. This is the table showing age-wise distribution of comorbidities. Comorbidities were more frequently seen in above 60 years of age group, that is 90%, followed by 51 to 60 years of age group, 84%, 31 to 40 years of age group, that is 77%, 41 to 50 years of age group, 64%, 21 to 30 years of age group, 57%. Gender-wise distribution of comorbidities, 74% of male patients and 71% of female patients had comorbidities. Disease-based distribution of comorbidities, 88% of psoriasis vulgaris patients with more than 5 years of disease duration and 68% of patients with disease duration of less than 5 years had comorbidities. Severity of disease-based distribution of comorbidities, 84% of psoriasis vulgaris patients with PASI more than 10 had comorbidities and 60% of patients with PASI less than had comorbidities. This is a table showing socioeconomic status-based distribution of comorbidities. 92% of psoriasis patients with comorbidities were from upper lower class, 78% of patients were from lower middle class. Area of residence-based distribution of comorbidities, 75% of psoriasis patients from rural area had comorbidities and 72% from urban area had comorbidities. This is the picture showing psoriasis vulgaris of severe type in a female with waist circumference of 94 centimeters. This is the picture of psoriasis in pregnant female. Discussion. In the present era, psoriasis is emerging as an important skin disease associated with various comorbidities. These comorbidities are associated with increased risk of morbidity and mortality. The chronic inflammatory nature of psoriasis is responsible for the occurrence of comorbidities, and tumor necrosis factor alpha plays a central role in this. In our study, prevalence of comorbidities is 73% among patients with chronic plaque psoriasis. The comorbidities observed in our study in the decreasing order of frequency are dyslipidemia 60%, hypertension in 23% of cases, diabetes mellitus in 16% of cases, metabolic syndrome in 13% of cases, obesity in 6% cases, myocardial infarction in 4% of cases. A study by Kotiwala, S.K. Khanna et al. Found that psoriatic patients had higher prevalence of metabolic syndrome, hypertension, abdominal obesity and diabetes. A study conducted by Jayakar Thomas et al. In Tamil Nadu stated that obesity was seen in 6.6% of psoriasis patients. Reither et al. Found a significant increase in lipid levels among psoriasis patients than in controls. Cohen et al. Found that psoriasis is associated with dyslipidemia, similar to our results. Hypertension, diabetes mellitus, metabolic syndrome, myocardial infarction are common in those aged about 40 years in our study. Gisondi et al. Found metabolic syndrome in psoriasis was more common after 40 years of age. Both males and females had all the comorbidities. There is no statistical significant difference. Hypertension, diabetes, dyslipidemia, myocardial infarction were more frequently seen in males and metabolic syndrome was frequently seen in females in our study. 88% of psoriasis patients with more than 5 years of disease duration had comorbidities, and 68% of CPP patients with less than 5 years of disease duration had comorbidities. There is no statistical significance. Comorbidities are significantly more in psoriasis vulgaris of severe type. They are also found in mild and moderate type. There is no statistical significance. Langan et al. Also observed an increasing trend of the presence of metabolic syndrome with increasing severity of psoriasis. A study by Kotiwala et al. Khanna and found that there was a significant trend to increase in prevalence of metabolic syndrome, hypertension and type 2 diabetes mellitus with increased severity and longer duration of the psoriasis. 92% of CPP patients with comorbidities were from upper lower class, 78% of patients from lower middle class. There is no statistical significance. History of comorbidities. Only 8% of our patients were diagnosed to have comorbidities while presenting to us, of whom 4 patients had developed comorbidities before chronic plaque psoriasis. Conclusion. In our study, prevalence of comorbidities higher in patients with psoriasis vulgaris. A multidisciplinary approach is needed in the management of chronic plaque psoriasis due to systemic nature of inflammation in psoriasis. We should not just recognize and treat the signs and symptoms of psoriasis, but should also screen patients to detect the existence of comorbid conditions like hypertension, diabetes mellitus, dyslipidemia, metabolic syndrome and cardiovascular diseases. Our study strongly recommends screening for comorbidities in all patients with chronic plaque psoriasis, irrespective of their age, sex, socio-demographic profile, duration of disease and severity of psoriasis. Even if comorbidities are not detected at screening, adopting healthy lifestyle practices are highly needed from the time of diagnosis in present era to prevent these comorbidities. These are my references. Thank you for this opportunity.
Thank you, Dr. Prashanti. Is Girish Kumar there? In case Girish Kumar is not there, then we wind up the session. The results would be announced in the valedictory function, and I have to say why we have chosen dissertation award in name of my father, Dr. Patnaik, is because he always loved the thesis, and post-retirement also for almost 5 years he had been guiding the various students from Gandhi and Usmania in the dissertation. So he loved dissertation. Actually he was a guide for me also, which I had a very troublesome time with him. But it went on to win the Indoor Prize Award later on. So he was strict, but he was amicable. Thank you very much.
Thanks a lot for the organizers for giving us this opportunity to chair this session. Now, the valedictory function is going to take place within a short time. I hope everyone will be there.
Yeah, to valedictory. Sundaran. Meanwhile, I'll invite John.
I request all the delegates to assemble for the valedictory function and hand over the mic to Dr. Bhumesh Kumar to proceed with the further proceedings.
So after we have come to end of our 7th annual conference of IADVL Telangana State after a marathon batting from Friday, Saturday and Sunday. The 18 panel discussions, 160 faculties from the state and outside, and 160 papers, and more than 450 delegates, those who have participated. And just bear with us. So another half an hour to 45 minutes, this validatory function. So which is very, very important, especially the younger generations, those who have participated and presented the papers. It's a time to appreciate to the younger generation with the prizes in the validatory function. So now I invite onto the dais the EC of IADVL Telangana 2021, our president. Yeah, he will join. And president-elect. So another half an hour or 45 minutes, he will become a president. So Dr. N. Ramesh sir, please come onto the dais and occupy the chair. So myself, Dr. Bhumesh Kumar, secretary. So I am here only. And immediate past president, Dr. Pavitra Vani Patale. Ma'am, please come onto the dais and occupy the chair. Okay. Treasurer, Dr. D. Janardhan, sir, please come onto the dais and occupy the chair. Vice President, Dr. Geeta. Joint Secretary, Dr. Rajita and Dr. Raj Kirit. Dr. D. Benmurthy, sir, please come on to the dais, President. And Scientific Chairperson, Dr. G. Narasimha Rao Neta, and Co-Chairperson, Dr. Sudharani. Ma'am, please come on to the dais and occupy the chair. I request our President to give a message. You can speak from there on.
Good afternoon, everyone. First of all, I thank you very much for staying with us for such a long time. And we did, as a team, what we could with the help of your support and the effort of our team members to do this physical conference after a very long time. During the post-COVID times, we took all the care, and I hope we have done our job. Now, I thank everyone during my tenure who were very supportive to me and encouraged me, and really Dr. Bhumesh, of all the people who worked like a workhorse from morning to evening, sending messages throughout the year, conducted various webinars, health education meetings, health camps, what not, everything he did, taking the responsibility of on his shoulders. I have yet to see a dynamic secretary who worked like this till today. He needs a great applause because nothing he expects from us other than accepting what he has done and appreciating what he has done. Thank you very much, Dr. Bhumesh, for all your efforts. We acknowledge it and we appreciate it. I hope from here you have to go for much more heights. I wish you go now into the Central IADVL also as a secretary, And I wish when the time comes, we all will be supportive to you, and we will see that you will definitely make a success as a General Secretary also for the National IADVL. Now, I request Dr. Bhumesh to give his report during his tenure as a General Secretary for the TSIADVL. Thank you very much once again.
So a big thanks to one and all. So nothing much to say because you are seeing almost since 3 days, so I maybe get bored for all of you. So I don't want to take much time. So whatever I have done my level best by putting my body, mind and soul for the association and IADVL and Telangana. So thank you very much. And the report, whatever he has, everything as told by our beloved President. Thank you one and all.
I sincerely thank my executive body also, who were very supportive and encouraged me and helped us to conduct this conference. Everyone who are there on the dais, who are our executive body, who are meeting us regularly on all our meetings, I thank them from my heart.
So yesterday in the inaugural ceremony, because of lack of time, so the EC was not well stated. So bear with for 5 minutes for the felicitation to the EC. Over to Shahna.
Now,
So it's the time to invite the elected body of 2022. President Dr. N. Ramesh already is there, and Honorary State Secretary Dr. Mohan Lal, please come on to the dais. Treasurer Dr. Satyasri, Vice President Dr. Venkatakrishna, Dr. Naeem Saadat Hanif, Joint Secretary Dr. Vikram Kumar and Dr. Shankar. Over to Shana.
now we are going to felicitate Dr. TBN Murthy, President, TS IADVL.
I'm sorry. I invite the President-elect Dr. Rajiv Singh, sir. Rajiv Singh, please come onto the dais. Anybody?
The proposer is behind you. Venkatrishna sir.
आपका 120 हो गया।
मैं गूगल पे करूंगी।
ओह, मेरे पास तो सिर्फ यही है।
यही है? तू मुंह चला छोटे, गूगल पे सब जगह चलता है।
यूपीआई क्यूआर कोड कोई भी हो, गूगल पे उतनी ही आसानी और सिक्योरिटी के साथ चलेगा।
Facilitating Dr. Bhumesh Kumar Katakam, Honorable General Secretary, TSI. Facilitate Dr. B. Janardhan, Treasurer.
Now, in this auspicious occasion, as a gesture to his work, I declare him as the most distinguished, determined, dynamic dermatologist of this year 2021 to Dr. Bhumesh. This is President's Appreciation Award. Probably every time the President can declare anybody he likes who has done the job for the society, for the association, and for the academics. Thank you.
Now we will visit. Congratulations, Bhumesh sir, once again. Now we will facilitate Dr. B. Janardhan, Treasurer, TS IADVL.
was a very silent person throughout the year, but he was very supportive and definitely gave his efforts for the constructive decisions of this executive body. Thank you.
Now I invite Dr. Narasimha Rao Nehta, Scientific Chairperson, to be facilitated by TS IADVL.
Gita.
Dr. Rajita Damisetti, Joint Secretary.
Dr. Rajita has done an extraordinary work through ITATSA, and her contribution to this association is highly appreciated, and we thank all for her efforts.
Facilitate Dr. G. Narasimha Rao Nehta, Scientific Chairperson. And I invite Dr. Sudha Rani Madam to come on to the dais for facilitation. She is Scientific Co-Chairperson. I invite Dr. Rame, President-elect, to be facilitated by TS IADVL.
I request Dr. Aruna, she was last time General Secretary, she has some announcement now. If she is not available, Dr. Kavita can come. Please come on to the dais and just say what you want to declare.
Good afternoon, one and all. I'll just take 1 minute of your time. This is during our tenure 2020. I would like to submit this balance sheet of what all the payments, particulars regarding to our President Sir DBN Murthy Sir. Yesterday, due to out of time or something, Madam has forgotten. So kindly, thank you so much, sir, for giving me this opportunity.
So now the distribution of prizes. We will start with the IADVL Telangana Dermanor. So that is actually it's a brainchild of the ECF 2021, the Dermanors, when we are in a special situation of COVID-19 pandemic, but our academic activities did not stop. In spite of that, this Dermanors, almost 30 institutions they have participated throughout the year. So we have done 14 Dermanors in 2021. So we decided that the top 5 Dermanors will be selected, and among those top 5, those institutions who will get maximum, the top 5, they are going to be announced as the first prize and second prize of the IADVL Telangana Dermanors. So among 30, the 16 times the institution who has got from their PGs, that is the Department of DVL, Usmania Medical College, they have won 16 times. The hearty congratulations to the team, DVL department, and the PGs who have won the top 5, and because of them, the institution has got good the name and prize, and subsequently the faculty and then HOD. So I request on behalf of the Department of DVL, the HOD Dr. Rajiv Singh, please take this honor and prize on behalf of Department of DVL Usmania General Hospital.
All my faculty members who were instrumental in getting those prizes, I request all associate professors, assistant professors to be with me, and I call upon all the PGs to be present here on the dais, please. They have done an excellent job. Really, Telangana is proud of Usmania Medical College, which has been throughout a reputation in the history of South India. Usmania stands first again. Please, all PGs, please do join us for this. Chapina, I shouted. Please come. Associates, other professors, Padma Madam, Indra Madam, all please do join with me here. Please, all postgraduates who have been excellent right throughout, for the last 1 year have been consistent in scoring in all the Dermanors. They have been also in the other quiz competitions of South India. Some of them have made up to the recent South Zone also.
The PGs actually they are the backbone for any institution. So this is the occasion, so we need to stimulate by ourselves, we need to stimulate the department and subsequently get the name to yourself and your PGs. Because of your PGs, we got the institution as a name. Thank you very much. Thank you very much. So this is a motivation to other institutions and the colleges. Now the second highest, the top 5 goes to the second. It is 10 times they got the top 5. That second prize goes to the Department of DVL, Gandhi Medical College. I request the PGs, those who have got the terminars and the faculty and the HOD, on behalf of Department of DVL, I request the HOD sir to take this honor.
Very happy news. I am requesting all our PGs come on to the dais. Our faculty members, please come on to the dais. This is the happiest news we have to maintain here future too. Please come on to the dais. Enjoy. All happy, very happy.
So this action of terminars, it has initiated by the EC of 2021, and for this the academic grant has taken place by the team Hetero Healthcare. So almost it is a project of almost the 14 terminars, the 15 to almost 20 the technical teams they have worked behind, because it is a quiz academic and sharing of awareness, all as initiated by without taking any money. The team Hetero Healthcare, definitely on behalf of EC, we congratulate, we thank the EC, and even in the we are going to felicitate the team, the Hetero Healthcare, especially Guru Prasad, Vijay, and Srinivas Chiranjeevi. They have participated the day and night. Whenever we say the do it, so without any problem, without taking anything. So they are big thanks to the team Hetero Healthcare. Yeah. Yeah, they will, when we are felicitating the all Dharma, the Pharma, so we will felicitate during that time. Yeah, that's. And the distribution of prizes to this award papers, posters. I invite Dr. Padmaja Madam, Dr. Indra Madam, Dr. Sudharan Madam, please come on to the dais. So for the posters, we got 80 posters. So we divided into 2 days, day 1 and day 2, first prize and second prize in day 1 and first prize and second prize in day 2 with a appreciation certificate with a token of appreciation as well as cash. I request Dr. Arna Madam, please come on to the dais. So the posters, day 1, the second prize goes to Dr. Tain Mozi from Gandhi Medical College. First prize goes to Dr. Rida Juveria from Kamaneni Medical College. Take the award.
Thank you.
And day 2, the second prize goes to Dr. Aslima from Kamaneni Medical College. Aslima is there? Kamaneni. Yeah. Ramdas sir, you have come, please. You have a bumper offers. Narkatpal, anybody is there from Narkatpal Medical College? Aslima. If Navanita is there, she can come and pick up. So otherwise, Ramdas sir, please hand over. So we have a cash also in back and the certificate. Thank you. And first prize goes to the for posters in day 2, Dr. Varsha BH from Usmania General Hospital. From Usmania. Dr. Varsha, she is not there. I request the HOD to place it. And the pre-paper session, because of COVID, most of the PGs they could now not present their oral presentation. It is mandatory for the in the final year examination. So we have divided each session, the first prize and second prize with the certificate and money. The day 1, the second prize goes to Dr. Meenakshi, Chalmada Medical College. And before that, the judges for all these papers, we thank on behalf of PC, Dr. Manjunath Senai, Dr. K. Ramdas, Dr. Ashok Matate, Dr. Aruna, Dr. R.C. Reddy, Dr. Jair, and Dr. A.G. Rao, and Dr. P.S. Chandravani. Thanks for your contribution for selecting these papers. Chalmada, anybody is there? Anybody faculty from Chalmada Medical College? Okay, the Indra madam will take care, she will hand over. And first prize goes to Dr. Ashima Chandran from KMC, Kaktiya Medical College, for the free paper session 1. Session 2. The second prize goes to Dr. S. Naveena Reddy from Bhaskara Medical College. I request Dr. Manmohan Sir, HOD from Bhaskara Medical College, please take this award on behalf of your PG. You are a PG. Okay, you are on behalf of HOD, you can take it. Please come. Congratulations, sir. Now the first prize goes to Dr. Vaishnavi, the Meenakshi Medical College. Free paper session 2. Meenakshi Medical College. Free paper session 3. The second prize goes to Dr. M. Kavya, South Central Railway Hospital. I request HOD sir, please take. Aruna madam, please come. First prize goes to Dr. Maria Yagraj. Mayur. Dr. Mayur Yagraj. Free paper session 3. Session 4. The second prize goes to Dr. Shambhavi Reddy from Gandhi Medical College. And the first prize goes to Dr. Yashashwini from Usmania Medical College. The second prize goes to Dr. Ravali Rao from Gandhi Medical College. And first prize goes to Dr. Sada Diksha from Kamdeni Medical College. Sada Diksha from Kamdeni. will hand over. Yes, sir, please come. And all five papers, 3 paper sessions is over. Now we move on to the award paper. So, award paper session. So we have one award paper session and one Professor R. Patnaik Gold Medal Dissertation Award. So we are giving separate. The second prize goes to Dr. Amulya Batula from Usmania General Hospital. First prize goes to her award paper Dr. Mandavas Nehasti from Gandhi Medical College. So the Professor R. Raghunath Patnaik Gold Medal Dissertation Award, the first thesis. I invite Dr. Sunil to come on to the dais, and I invite Dr. Aruna and Arthur from Madhya Pradesh to come on to the dais. Award goes to almost, we have 11 papers, almost it became a very, very difficult and tough time to judge these papers, and this goes to Dr. K.L. Varsha from, she has done the, she has done the post-graduation from Gandhi Medical College. Now she is doing the senior residency from Usmania Medical College. Congratulations. So it's a medal, gold medal, the cash of 5,000 rupees and the appreciation certificate. Congratulations. God bless you. So now, Jela, please wait. So this conference, almost all conferences, the academic grant has taken place by. Sir, మీకు మెడల్ వేస్తే మీరు లాస్ట్. So we have the sponsors of this conference, the platinum, gold and silver. So just honorary we have divided. So the platinum, it has, I invite From each pharma company, please represent two people, and later you can take group photo over there. So all pharma people, please come forward. The Canixa, Alchem, Medmanar, IPCA, and Etro Healthcare, and this team of Guru Prasad, Vijay, Chiranjeevi, and Srinivas, and Talent H&H. Yeah, Talent India. Please come, please come. Canixa, Alchem, Medmanar, H&H, Talent India, and Etro Healthcare. Please, please, fast, make it fast. Canixa, Kamesh, prize to Kamesh, Mr. Kamesh, because almost he has our backbone, so it should Alchem. Next Medmanar. So thank you Alchem. So for sponsoring the yesterday banquet. So it was a great enjoyed all. So they have sponsored our delegate meetings for the faculty and for the delegates as well as faculty. So we request the tempo continues. So they have taken some responsibility of taking responsibility from outside. Can't contribute to Talent India. Talent India, so we enjoyed your the tea, the snacks, everything. So Sudhakar is there, so we request it should be continued. All four yeah. It will be one separate. Guru Prasad. Vijay. So yeah, some other way from the promised and we did it. Now I invite one by one. Madam, Glenmark, FDC, Oaknet, Sanofi, Derma India, Pfizer, and Glenmark, FDC, Oaknet, Sanofi, Derma India, Pfizer. Glenmark. FDC. FDC. FDC is there. Derma India. Derma India. Oaknet. If you miss anybody, please raise the hand and then. No. This is Oaknet. Sanofi. Sanofi. Pfizer. It is gold in over, then silver. Today, I request. Sanofi saving calculator. Silver Curatio, Dermazone, Varkas, Sun Pharma, Mankind, Minarne, Intas, Galderma, Dr. Reddy's, GSK, Cipla, Ajanta. Here we go. Curatio, Dermazone, Dermazone. Oh. Varkas, Sun Pharma, Varkas. Varkas. Ada balik. Cover this is clear for 5 lakhs. Varkas, Sun Pharma, Mankind, Minarne, Intas, Galderma, Reddy's, GSK, Cipla, Ajanta. Sun Pharma. Please come. Reddy's. ఓకే చేతులుంటాయి వీళ్ళకి ఇట్లా ఇంత నెక్స్ట్ ఓనికేం అజంతా అజంతా సిప్లా Anybody is there? Parka, Sun Pharma, Minarne, Mankind, Intas, Galder, Linux, Parsons, Vinalur, Monichem, PLM, PNP, Torrent, Yash, Impact, JRK, Primeless, Abort, Biocon. KLM, చేతులు ఏది ఉంటాయి చెప్పండి. J&J, పిల్లలు మోనికేం మీ చేతులు ఏది ఉంటాయి చెప్పండి. గాల్డర్ Pharma, PNP, Vinalur, J&J కాదు PNP అది యాక్చువల్గా PNP అది ఇది మార్చి చేయాలి. PNP ఇది ఒకటి తప్పైంది. Next ఎవరైనా ఇంపాక్ట్ మెడల్ Abort, Intas, Biocon, Paulson. If they are not there, we will kill later. Torrent. Okay. Lucky dip, they said that one. Lucky dip. Time to the expression of views from the floor. I request any senior members, anybody please express your views.
పిఎన్పి వచ్చింది. పిఎన్పి we have modified and changed immediately. Instant. Change చేసేసి immediately. అంటే పిఎన్పి మళ్ళీ
పేజీలు వెళ్ళిపోయినట్టు కూడా ఆగిపోయారు చూడు ఎవరు.
సో మార్చేసాం ఇమీడియట్గా. ఇగో చలో లక్కీ డిప్ తీసేసారు తొందరగా తీసేసారు. The presidential medal to the President Dr. N. Ramesh. చేసినా కదా సార్. ప్రోటోకాల్ బిఎన్ రెడ్డి గారు చెప్పిన ప్రోటోకాల్ కాకుండా चलो I request that please stay for 1 minute, please. I request President, please hand over the presidential medal to the incoming President Dr. N. Ramesh. Now I request President Dr. N. Ramesh, please give the presidential message. The CV of Pandu, please display. Same last year kuda ka sir. Last year also ide chesinamu. అవును ఇవాడ చెప్పలేదు సార్ అది ఓన్లీ టు ఎంకరేజ్ సార్ అది
గుడ్ ఈవినింగ్ ఎవ్రీబడి ఆన్ బిహాఫ్ ఆఫ్ సౌత్ సెంట్రల్ రైల్వే ఎంప్లాయీస్ సంఘ్ we are honoring newly elected President Dr. N. Ramesh. He is the doctor of our Central Hospital Lalaguda. Really we are very much proud of him. He is a man of humanity. He is a man of sincerity. He is a man of dedication towards his dream, and he has helped so many families, and they are working hard, and he has rendered human service to the railways fraternity. So on behalf of National Federation of Indian Railwaymen, we are honoring and we are felicitating Dr. N. Ramesh on being elected as a president of your new team.
ये ले लेगा अरे ये लेके यार ये Check, check. Aims and objective.
Each time.
Slide change. It will go there.
Right one is slide change. Yeah.
And you have to be doing like this here.
If I do it, this is enough now.
The slide change is connected there.
Both I should do.
For reading, if you want to read there.
No, I don't. I'll read from here only. Good evening, all the delegates. Yeah, outgoing President Dr. D.B.N. Murthy and his team, and my new team members, General Secretary, Joint Secretaries, and Treasurer, Vice Presidents, and President-elect. Thank you very much for transferring the mantle of presidentship for the next 1 year to me. I just wanted to make a small presentation. Basically, since the young postgraduates were the majority participants in these 3 days proceedings, I just wanted them to know the spirit of being a part of the executive committee which runs the State Dermatologists Association. The theme or the spirit with which we have to work, apart from practicing the specialty, you need to be a part of the community, general community, as well as people as members of our own specialty. So basically the team spirit of executive committee elections every year, the mantle of passing the responsibility of running the association is dependent on promoting dermatology, venereology, leprology, and allied specialties. That's a basic reason why this association has been running since 1973. If you know the history of IADVL, it started, first association was formed in 1973 with these principles guiding the successive IADVL associations. So we need to educate. We have a lot of obligation and responsibility towards the community also. We need to do public education through community services and hold academic conferences, CMEs in different parts of the state. So district-wise also we can form sub-branches. At least 7 members should be there in each branch who should work in the interests of the association. They will be functionally and economically also independent, autonomous. They won't be under the definite strict control of the state body. To be involved with the adjacent state branches also, we need to conduct health camps, particularly school health camp they say, because you need to catch them young in the school itself. The dermatological problems, whatever community faces, the awareness about those problems should be inculcated in the younger school children. So that's why school health programs we need to focus on. And also the membership drive also should be one of the mottos of association. So every year March, we need to give an updated list to the central body of IADVL. And we need to motivate provisional life members to convert them, during post-graduation, before you could get a diploma or a degree. Nowadays only degrees are there in the medical colleges. Previously when we were students and all, until recently diplomas also used to be there. So during that period you will be called as provisional life members. These people should be made life members. So I want to request the HODs of all the departments, medical colleges, at the time of their passing out, the students should be made compulsorily, they should register themselves to become life members. That onus should be taken up by the HODs. And further research, of course we do thesis work, basic research, students are exposed to that, and further little advanced research also we should have access for the younger generation. It's not coming. So we have planned activities this coming 1 year on three focused on three perspectives. One is resident. So we have focused developmental activities around three perspectives. One is resident oriented, young postgraduates in the departments. The other one is teaching institutions, teachers. So for students, we have contacted some of them. They said they should be focused CMEs on dermatosurgery, dermoscopy, pathology, cosmetology and leprosy. So we wanted to plan quiz programs to PGs of various medical colleges, even in districts. We would like to hold these quiz programs even in district medical colleges also. And as far as the teachers are concerned, promoting and facilitating research studies in teaching institutes which are granted by So we need to create awareness in public that dermatologists are the only doctors qualified in treating skin and hair diseases. So we are planning to address the problems that are faced by young recently completed postgraduate students. We need to support them as far as we need to give them ideas how to build their practice as a professional career, and particularly the procedural dermatology, like using lasers, fillers, Botox. So we will specially try to hold CME sessions on these aspects, and particularly any dermatology emergencies and difficult to treat cases also, how to manage them. We will try to bring experts to address their problems. So community services. This is the fulcrum on which our dermatology practice depends on. So we need to create awareness about, it's already been running last 2 years or so, steroid misuse and abuse, that we would like to continue at a higher scale. So we will promote community health education through public meetings, health camps, brochures, distribution, through electronic media, during days of importance like Psoriasis Day, Leprosy Day, HIV AIDS and Vitiligo Day, etc. We would like to visit even orphanages and old age homes periodically and address their specific targeted dermatological problems and distribute free drugs to them. We even plan to visit some of the worship places during festivals and conduct skin health camps and promote awareness about skin diseases. So we need to there has been, I think, the president of National IADVL yesterday made a remark that social welfare activities have to be brought to the access of IADVL members. So I think the national level there is one ex gratia benefit program, and we would like to bring it closer because nobody knows much about this program, and we will come up with details and encourage and motivate people to become a part of this DVL Welfare Trust. So to bring people together, not only at the professional level, even the social and cultural level also, we would like to bring karaoke nights among the doctors, men and women on Telangana Formation Day, celebrating Batkama and Dandiya, not only which is now limited only at the state conference level, even in between also we will find opportunities and try to come together for cultural and recreational activities. Other objectives, I think the financial issues have been cleared to a great extent yesterday, and we would like to continue the transparency and see that our finances are strengthened and we will find sources of support, grants coming up from other sources also. And the bank account also has been made single bank account. The confusions of financial management also are being reduced now. So the journal, as far as journal, strengthening of journal is concerned, still I think indexation is an issue. Shortly we will address that and come back, so that a lot of contributions, even at private practitioners of district and rural levels also, any interesting cases that you people would like to publish, you can do that in our state journal. So I once again thank the outgoing IADVL EC led by Dr. D.B.N. Murthy and Bhumesh Kumar and others. And I welcome my team, the Vice President Dr. A. Venkat Krishna, and another Vice President Dr. Naeem Sadat Hanif. Yeah. General Secretary Mr. B. Mohanlal, and Joint Secretary Mr. Dr. Shankar. Shankar hasn't come. So Treasurer Dr. Satyashri Teki, she is a very key personality in our team. Joint Secretary Dr. Vikram Kumar. I hope the members of IADVL state, Telangana state would give the same support and encouragement like during last year and ever after. We'll come up, we promise that next year, next state conference will be no less interesting, and in fact more richer in content and appreciated by one and all. Thank you very much for this opportunity.
Thank you, sir. So, wish you all the best in your tenure. So, at the end, the audio, visual and everything, the last night also we enjoyed. So, I request the event manager, Mr. Pandu, please come on to the dais. Just accept our token of appreciation. Then followed by the vote of thanks by Treasurer Dr. B. Janardhan. All the best. Then we'll have a national anthem. Vote of thanks. Thank you. Very well done. Well done. Janardhan. Then followed by the national anthem.
Hello. Is there anyone who wants to speak few words about what has happened? Or ठीक है. Now next vote of thanks from Dr. B. Janardhan.
Respected Honorary President Sir, Dr. D.B.N. Murthy Sir, General Secretary Dr. Bhumesh Kumar Sir, dear IADVLites, a very warm good evening to one and all. On behalf of Team TS IADVL 2021, it gives my proud privilege to propose the vote of thanks for CUTICON 2021 State Conference of Telangana on 24, 25 and 26th of December. I thank this eminent faculty within the state and outside the state who participated enthusiastically in their respective positions as moderators, speakers, panelists, chairpersons, etc., which made the scientific session very informative to all the delegates, covering the clinical dermatology, dermatosurgery, cosmetology, sexually transmitted diseases and leprosy. I thank all the professors and HODs of the departments of all colleges who encouraged their postgraduates to participate for paper and poster presentations. And congratulations to all the winners. I thank the hall coordinators who helped us in maintaining the schedule on time. I thank each and every delegate who participated in this conference and made it a grand success. I thank all the pharma companies who participated in a large scale and the audio-visual team and technical staff. I thank Mr. Gajanan Malia, General Manager, SCR, for giving permission to conduct the conferences at the Rail Kalarang. Long live TS IADVL. Best wishes to the forthcoming Team TS IADVL 2022. Thank you very much. All the delegates, please join for the group photo, please.